Scientific Committee Chairman, IMA Amravati in 2017-18. He is Joint Secretary, Association of Surgeons of Amravati in 2014-15 and 15-16. He is Maharashtra Medical Council accredited speaker. You can continue.
Yeah, thank you. Good morning, everyone. At the outset, I would like to thank Association of Surgeons of Amravati and President Masi Dr. Ganeriwal sir for the opportunity. Today, I'll be speaking on a common urological topic, that is urolithiasis. The management of urolithiasis has undergone a radical change in the last few decades owing to the advances made in endourology. And my endeavor today is to highlight the current concepts in the management of urolithiasis. The urolithiasis is a common problem, and the lifetime prevalence of having a urinary stone is 1 to 15%. Urinary stones are more common in hot, arid, dry climates and in summer months. Now, as you all know, majority of the urinary stones are calcium-containing stones with calcium oxalate contributing to 60% of the stone occurrence, followed by calcium phosphate at 20%. Non-calcium containing stones are relatively uncommon, with uric acid and white stones contributing to 10% of the stone occurrence. Cystine and drug-induced stones are rare. Now, whenever a patient of urinary stone comes to us, he asks a common question as why do stones form? So let us try to understand this. Whenever we add salt to water, initially the salt will dissolve. If you go on adding salt, eventually the solution gets saturated, and further addition of salt will lead to the precipitation of the salt. A similar process occurs in the urine, but with a difference. This picture shows urine in different states of saturation, with the bottom area being undersaturated. Here, the stone forming salts are present, but they do not crystallize. As the concentration goes on increasing, the urine enters the metastable range of concentration. Here, the urine is saturated with these salts, but still the crystallization doesn't occur because of the presence of inhibitors of stone formation like citrate, magnesium, and various glycoproteins. However, if the concentration of these salts goes on increasing, then ultimately the urine will enter an unstable range of concentration. Here, even the presence of stone inhibitors will not prevent the nucleation and precipitation of these salts, and it is in this range of concentration that stones form. Now, there is a popular misconception that urinary alkalizers dissolve an existing stone. I say misconception because they are actually intended to prevent a recurrence and not for dissolution of a stone. So how do they prevent a recurrence? They contain citrate, magnesium, which are inhibitors of stone formation, and they keep the urine in a metastable range, which helps to prevent nucleation and precipitation of the salts. Another common question a patient will ask is, if I get treated for a stone, will I get a recurrence? So the answer is that first time stone formers have a 50% risk of recurrence in the coming 10 years. And hence all patients are given empiric fluid and dietary advice, out of which the most important is to have a high fluid intake to achieve a urine output of more than 2 liters per day. In the dietary restriction, animal protein and sodium restriction are important. Older recommendation to significantly reduce calcium intake is no longer recommended. And avoidance of oxalate-rich food, the benefit is unclear because only 10% of the urinary oxalate comes from dietary sources. Now, there are certain patient groups who are at a very high risk of recurrence, like recurrent stone formers, patients having strong family history of stones, patients with solitary kidney, children, etc. So these patients have a metabolic problem which leads to the high recurrence rate, and they should undergo metabolic evaluation, which includes various blood and urinary tests, which helps them to be classified into 12 different categories like hypercalciuria, hyperoxaluria, hyposaturaturia. So this will help to initiate the treatment according to the pathology, and for future recurrences can be avoided. Now, whenever a patient of urinary stone comes to us, the diagnostic evaluation will involve a history, examination, blood test, urine analysis, urine culture to find out if there is a UTI. Ultrasound is important to find the location and size of the stone. Ultrasound should be done on a full bladder. If it is done on an empty bladder, then bladder and lower ureteric stones can be missed. And X-ray KUB is commonly done to find out if the stone is radiolucent or not. Intravenous urography is commonly done to find out the function of the kidney, and it also gives us the roadmap to plan our surgery. CT scan is used for complex renal stones and for radiolucent stones. Now, whenever we are planning treatment for urinary stones, the goal of the treatment should be complete stone clearance with minimal morbidity. Now, I will divide the further discussion into management of renal, ureteric, and lower tract stones. So initially, we'll discuss the treatment of kidney stones. So till 1980s, open surgery was the treatment of choice for the renal calculi, large renal calculi. Today, there are 4 minimally invasive treatment options for treatment of renal calculi, which are percutaneous nephrolithotomy, extracorporeal shockwave lithotripsy, retrograde intrarenal surgery, and laparoscopy. The treatment of renal calculi was revolutionized in 1976 when Firstrom and Johnson performed the first PCNL. In India, the first PCNL was performed by Dr. Shivdev Bapat from Pune in 1983. Today, PCNL is the treatment of choice for all renal calculi more than 2 centimeters, including ASACON stones. Another breakthrough in the treatment of renal stones was the introduction of ESWL in 1980 by Dornier, a German company. And today, ESWL is the treatment of choice for small renal stones which are less than 1 centimeter. Another advance in the treatment of renal stone is the introduction of retrograde intrarenal surgery, that is RIRS, and this is an alternative treatment option for renal stones less than 2 centimeters. RIRS basically is done by a flexible ureteroscope, which has a bendable tip, and this can access the calyces, and stones are fragmented by laser. Now, whenever we have a patient of renal stones, there are various factors which will decide the treatment. Like stone factors are the most important, like stone size, number, location, composition. So this algorithm shows the management of non-lower polar renal calculus. So if you have a non-lower polar stone more than 2 centimeter, PCNL should be done. If it is less than 1 centimeter, then ESWL is recommended. After 3-4 sessions of ESWL, if the stone hasn't cleared, it is considered as a failure of ESWL, and these patients should undergo a PCNL for stone clearance. For stones between 1 to 2 centimeter, both ESWL and PCNL can be done, and RIRS is the third option which we can use. All these options have pros and cons, and these should be discussed with patient. Like ESWL will require multiple settings. RIRS is a very costly option. PCNL is invasive but has a very good stone clearance rates. Now, ESWL and RIRS success rates are inversely proportional to the stone size, and they are not recommended for large renal stones, especially ESWL. If we do for a large stones, then we'll end up with a condition called Steinstrasse, which is a street of stones. So these stones come and block the ureter. So it is very cumbersome to treat these stones with endourological techniques. It is better to do PCNL for large upper ureteric and renal calculi. For lower polar renal calculus, the algorithm is different because lower pole is in a gravity dependent position, which hampers the clearance rates of the stones after ESWL. So for a lower pole, if the stone is more than 1 centimeter, PCNL is recommended. If it is less than 1 centimeter, then we have to consider the anatomy of the lower pole. If the lower calyx infundibulum is short, wide, and has an obtuse angle, then ESWL is recommended because the stone clearance rates are good. If the angle of the infundibulum is acute, or if the infundibulum is long and narrow, then for these ESWL is not recommended. For these, RIRS should be done. Now, in the last 2 decades, there has been a miniaturization of the PCNL instrumentation with the introduction of mini PCNL in 1988, ultra mini PCNL in 2013, and micro PCNL in 2011. These are basically minimally invasive PCNL techniques in which the PCNL size decreases as per the procedure. Like mini PCNL, the tract size is 14 to 20 French compared to a 24 to 30 French tract size in a conventional PCNL. In ultra PCNL, it further goes down to 12 French. In micro PCNL, it is only 4.5. These are ideally recommended for small renal stones, like mini PCNL for stones less than 2 centimeter, and ultra and micro PCNL for stones less than 1.5 centimeter. As you can see in this picture, traditional PCNL, the tract size is very large compared to the minimally invasive PCNL techniques. These techniques offer similar stone-free rates as conventional PCNL. However, the complication rate is less because of the small tract size, and they are recommended for smaller stones, pediatric patients, stones in diverticulum. So these indications compete with the indications for ESWL and RRS. Now, a lot of patients undergo sonography for other reasons, and they find many times incidentally small calaceal stones are detected which are non-obstructing. So what to do with these stones? The natural history of these stones is that most will increase in size and will cause symptoms in future. So small calaceal stones less than 5 mm need regular follow-up, and development of symptoms or an increasing in size are an indication to treat. In pediatric patients or patients with high risk professions like pilots, treatment of asymptomatic stones has to be. Another important factor in deciding the management are renal anatomy factors, like if there is associated PUJ obstruction, horseshoe kidney, renal ectopia. So this will require a change in the surgical technique while we are doing the surgery. Clinical factors are also important, like if there is an infected upper urinary tract, which is suspected if the patient has history of fever, tachycardia, raised counts, hypotension. So these patients should be first treated by either stenting or nephrostomy tube placement. This is to tackle the infection first. We deobstruct the kidney, let the infection get controlled with antibiotics, and only then, once the infection is under control, then the patient is subject to a stone surgery. If we do not do this, then there is a very high risk of life-threatening septicemia in the perioperative period. Similar with renal failure, if the patient has renal failure because of obstruction, then the renal function must be optimized by regenerating or nephrostomy tube placement. And once the patient creatinine reaches a baseline level, only then the patient is subjected to a stone surgery. This is because the morbidity and mortality in a patient with high creatinine is very high compared to a patient with normal creatinine. I won't go into the details of the technique. In a short, PCNL will involve cystoscopy. The patient is made prone. Ureteric catheter is placed during the cystoscopy initially, and through the catheter we inject dye, and the kidney is accessed through a Seldinger technique. The tract is dilated, and through the dilated tract we can pass various instruments like nephroscope, and through the nephroscope various instruments like lasers, lithoclasts. The stone is fragmented and the fragments are removed with forceps. So even for large Stagon stones we can do PCNL. Sometimes these may require multiple tracks, but open surgery is not required. Now, advantages of PCNL is that the morbidity is minimal. There is minimal pain. Patient is discharged on the 3rd or 4th day. There is a 1 centimeter incision, so obvious cosmetic advantage. Complications, so most important is bleeding. 4% of PCNL patients will require blood transfusion. Adjacent organ injury is rare if proper technique is followed. So that is the reason why it should be done only by trained urologists. Now, ESWL is the other treatment for renal stones. It is consists of basically a machine which will generate the shock waves which are focused onto the stone using sonography or fluoroscopic guidance, and the stones are fragmented by oncoming waves and they get clear to the ureter. In patients who have stones more than 1 centimeter, DJ stent is commonly kept to prevent obstruction of the ureter. Coming to the management of ureteral calculi, again till 1980s they were treated by open surgery. In 1964, first flexible ureteroscopy was done, followed by introduction of rigid ureteroscopes. These were initially these had a rod lens system, which was followed by fiber optics, which led to the miniaturization of the ureteroscopes. Today's ureteroscopes come in the sizes of 6, 7, and 8 French, and even 4.5 French for a pediatric ureteroscope. Again, the diagnostic evaluation is same as for renal stones. Again, factors involving stone management, most important is stone factor. And 5 mm is the break point. If the stone is less than 5 mm, then conservative treatment is recommended because the chances of spontaneous expulsion is 77%. If the stone is more than 5 mm, then Surgery is recommended because the chances of spontaneous expulsion are less than 50%. The location of the stone is important. If you have an upper ureteric stone, then there is a chance of retrograde migration into the kidney during the procedure. And if this happens, then ideally in the same setting, RIRS is done. If RIRS is not available, because this is not available in every center, so if it is not available, then PCNL can also be done. If both of these cannot be done for various reasons, like sometimes even PCNL may not be available in some centers, then the patient later can be subjected to ESWL also. However, we should know that ESWL success rates range between 70 to 90%, whereas the clearance rates of PCNL and RIRS are more than 90%. Duration of stone presence is important for a ureteric stone because any ureteric stone has the potential to cause irreversible damage to the kidney function, and symptoms and stone size do not predict the loss of renal function. For stones more than 5 mm, the patient should be counseled about the risks associated with waiting. Clinical factors again are important. As I've already told, if there is associated infection or renal dysfunction, then that has to be treated first before we address the stone. So conservative treatment for ureteric stones, the indications are stone less than 5 mm, duration of stone presence less than 2 weeks, pain control with oral analgesics, no evidence of infection, and mild degree of hydronephrosis. Oral analgesics are given for pain relief. Antispasmodics will relieve the pain, but delay the stone clearance as they hamper the ureteric peristalsis. Alpha blockers like tamsulosin, silodosin, alphozicin are commonly used for medical expulsion. Patients are advised to have small amounts of oral fluids to achieve a urine output more than 2.5 liters per day. Forced intravenous hydrotherapy, which is a very popular therapy still with general surgeons and gynecologists, is not recommended. It is unscientific. It does not help in stone clearance. It causes significant complications, sometimes even life-threatening complications. It adds to the cost of the treatment. IV fluids may at best be used for a short period in a patient who has vomiting. So indications to intervene for ureteric stones are intolerable or intractable symptoms, infection, obstruction of a solitary or kidney or bilateral ureteric calculi, stone which are unlikely to pass spontaneously, that is more than 5 mm, and if significant progress has not occurred after 2-3 weeks of medical expulsion therapy. This is even for stones which are less than 5 mm. So for ureteric stones, the treatment of choice is URSL, which is ureterorhinoscopy, and lithotripsy, in which ureteroscope is passed through the urethra and then into the ureter. And once the stone is accessed, it can be fragmented either with laser or lithoclast, and fragments are removed with forceps. In majority of the patients, a DJ stent is kept. So advantages of URSL is that there is minimal morbidity, it is painless, patients are discharged the next day, and obvious cosmetic advantage that there is no incision. Other treatment options for ureteric stones are ESWL, but this is not very popular, but it can be done for upper ureteric stones which are less than 1 centimeter and present for less than 2 weeks. It is generally done only for patients who are not fit for URSL because the success rates are not very good. For large upper ureteric stones like this one, PCNL should be done. In this procedure, the ureteroscope is passed and stone is pushed back into the kidney, because it is very difficult to clear such a large stone through the ureter because the size of the ureter and ureteroscope are very small. So in a PCNL, this stone can be cleared in half an hour. Indications of open surgery are almost nil in today's era. Coming to the management of bladder stones, these are suspected by lower tract symptoms like dysuria, intermittency, hematuria, or obstructive LUTS. Again, diagnosed by ultrasound or X-ray. Now, if the bladder stone is less than 3 centimeters, then they are ideally treated by transurethral systolethal apexy. This is ideally done by laser. If the laser is not available, then we can also use stone punch or lithotrides like this one, which is a more mild stone punch. The advantage of laser is that collateral damage to the urinary tract like bladder, ureter, and kidney are less if lasers are used, because the fragmentation is very precise. For stones which are more than 3 centimeters, we have two options. One is percutaneous cystolithotomy, in which a full bladder is punctured in the suprapubic area and a tract is created similar for PCNL. An ampla sheath is passed and nephroscopes and other instruments can be used to fragment the stone and stone fragments are removed. If you have a very large stone like this one involving the whole bladder, then sometimes open cystolithotomy may also have to be done rather than doing an endourological procedure for hours. We should know that sometimes bladder stones are secondary, and we should find out if there is a secondary cause for bladder stones or a primary cause for bladder stones, and that primary cause may be an enlarged prostate, stricture, and these should be treated to prevent a recurrence. Coming to the management of urethral stones, if the stone is in the posterior urethra, it can be pushed back into the bladder followed by transurethral cystolithopexy. If it's in the anterior urethra, it can be fragmented in situ by an endoscope and laser, or sometimes if it is small, it can be milked out. So that is all from my side. Thank you very much. If there are any questions, I would be happy to answer them.
So what's your take on symptomatic non-obstructing stone in kidney? Asymptomatic non-obstructing 1.5 centimeter stone in kidney. It may be in the middle calyx or superior calyx.
Where is the question coming from? Okay, Kishan. Asymptomatic
non-obstructing stone in the kidney. 1.5 centimeter non-obstructing stone in the kidney, the middle calyx.
Yeah, as I've already said, any kidney stone, the natural history is that it will eventually increase in size and lead to symptoms. So this patient is going to require surgery in future. It is better to treat it either by ESW or by minimally invasive techniques like RRS or PCNL, because eventually he's going to require a surgery in future.
How many days you should wait in a unilateral ureteric obstructing stone, and why? How many days you should wait in unilateral obstructing stone in the ureter?
What is the size? It depends on the size. If it is less than 5 mm, then 2-3 weeks. More than 2 weeks, you cannot predict the loss of renal function. So it is better to treat the stone after 2-3 weeks. If it is 5 mm, then there is no point in waiting.
From audience.
What will be the management for the bigger lower ureteric calculus or mid ureteric calculus if they are more than 1.5 to 2 centimeters?
We can do URSL.
Yes.
The last patient, large ureteric stone that I treated was about 2.5 centimeter, and I could clear it in 20-30 minutes with a URSL, with a lithoclass, not even with a laser. With a lithoclass. So,
is there any chances of the passing the stone in the upper?
yeah, the chance of retrograde migration in an upper ureteric stone are 50 to 70%. In a lower ureter, it is 5%. Even lower ureteric stones, they can migrate into the kidney, and that I've already addressed that if it migrates into the kidney, if it's a large fragment, we should treat it in the same setting either by RRS or minimally invasive PCNL techniques can also be used. Or if these are not available, we can do ESW later on also. But the stone has to be cleared because otherwise he will again come back with symptoms.
Is there any your personal experience with the laparoscopic retrograde ureteral lithotomy?
See, laparoscopy is not commonly done. It is done if you have to do some other reconstructive surgeries for the renal stones, like if there is a associated PUJ obstruction, you have to do a pyeloplasty, then that can be done with a pyelolithotomy in the same setting. Otherwise, there is no, or if there is a large lower ureteric stone with a obstruction in the lower ureter, which will require a reimplantation, then the reimplantation and the stone removal can be done. Doing a laparoscopy or pyelolithotomy is not recommended. PCNL is much more straightforward.
I'm talking about the big stones in the mid ureter and the lower ureter.
So URSL is better
Quite
option.
traumatic. Quite traumatic.
I didn't get you to quite traumatic.
Quite traumatic. Trauma to the ureter. Postoperative edema and partial clearance of the stones and migration of the stone in the upper.
See, almost all these patients will be cleared through the unless there is a obliterative stricture and you cannot pass a ureteroscope.
Yeah.
Then it's a different story. Then we are talking about a stricture which is causing a secondary ureteric stones. In that case, you will have to treat that stricture. In that case, you will do ureteric anastomosis and removal of the stone. That is a different story. We are basically talking about the treatment of a stricture which is secondary stone. For primary stones, I mean, what you are saying will never occur. I mean, we will always be able to, because see, we have a 6 French ureteroscope, 4.5 French ureteroscope. So it is unlikely that we will not be able to clear the stone. At the most, if I am thinking that I will take more time in the ureter, I'll just push it back into the kidney and do a PCNL.
It's very difficult to pass the bigger stone into the upper
No, sir.
ureter.
It's very easy. It is actually very easy than doing a URSL.
When the stone is impacted in the ureter.
So,
In the ureter.
So
It's
these are
difficult to pass
these are routine surgeries for us, and we can easily tackle it. You can ask Vishal also. We are doing it regularly.
Yeah, that will be your experience. Okay, thank you.
Sir, I think when there is a narrowing of the upper ureter also, in that case, you have advantage in lap ureterolithotomy, obviously.
Thank you.
But if the ureter is very much dilated, then it is very easy to push that stone.
At the most, what will happen is, sir, at the most, what will happen if we cannot pass the ureteroscope? At the most, we will have to do a pre-stenting before the ureteroscopy. We pass a stent after 1 week, the ureter becomes dilated, and you can pass 8 French ureteroscopes also. Even if we keep a guide wire for 5 days, still the ureter gets dilated.
Okay.
So these problems generally don't occur.
Can nice talk. I just wanted to ask one question. What is the management of recurrent stones, urinary stones, even after doing recurrent endourological treatment?
For these patients should undergo metabolic evaluation. These involve a lot of blood and urinary tests. We should find out the cause of the recurrence. This basically involves a metabolic problem. As I've already narrated, there are 12 various categories like hypercalciuria, hyperoxaluria. Sometimes the stone inhibitors, the levels of these inhibitors like citrate, magnesium are low. And then these patients should be treated according to the pathology that has been identified in the metabolic evaluation. Stone analysis should be done. And then accordingly, we should find out the primary cause for the recurrence.
Thank you.
Thank you, sir.
When you will be advised laparoscopic removal of ureteric stone?
Laparoscopic removal of?
Ureteric stone.
Sir, as I've already told, if there is a requirement of a reconstructive surgery along with the removal of the stone, only then laparoscopy is indicated. Otherwise, all these stones, all can be removed by endourological techniques, irrespective of the size. It may be a 3 centimeter stone, it doesn't matter. You can still do an endourological surgery.
Okay, thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. I would like to invite Dr. Vishal and Dr. Avinash sir to give a memento on behalf of ASA.
I'd request Dr. Kaustubh Sarda to give mementos to our chairpersons. I call the next speaker, Dr. Abhishek Bhagwat sir, for his topic on surgical management of acute pancreatitis. For this session, we'll have chairpersons Dr. Anil Darokar sir and Dr. Ravi Telkar sir.
Good morning to everyone. At the outset, I congratulate the present Association of Amravati for conducting this wonderful event and thank them for giving the opportunity to present this topic, which is close to me. And I carry my regards from Akola. The management protocol for acute necrotizing pancreatitis has seen a paradigm shift, wherein a patient with infected necrotizing pancreatitis was initially subjected to an emergency
please,
early
please.
open necrosectomy.
Sir, please, may I introduce you before starting lecture?
I'm sorry.
Good morning. Myself, I'm on the behalf of my co-chairman, Dr. Ravi Tilkar. I welcome you, all the delegates. We have Dr. Abhishek Bhagwat as a speaker. Dr. Abhishek Bhagwat has completed his MBBS from Grant Medical College and JJ Hospital, Mumbai. He did his DNB surgery from St. Stephen's, Delhi. He did FNB fellowship in minimal access surgery from Meenakshi Mission Hospital, Madurai. He has presented many papers in national and international conferences. His field of interest is advanced laparoscopy and advanced flexible endoscopy. May I invite Dr. Abhishek Bhagwat to deliver his talk. Please, sir.
I'm sorry for that, and thanks for that. So, moving on. The protocol of management of acute necrosing pancreatitis has seen a paradigm shift where initially a patient, when was diagnosed with infected necrosing pancreatitis, he was subjected to an early emergency open necrosectomy, which had very high rates of mortality and morbidity. But as our understanding of the disease and treatment improved, we have now shifted to a delayed intervention protocol, and only when required, we would go ahead with a necrosectomy, that too through a minimal access route. It is found that this route has a low mortality and morbidity, and this now is the standard of care. The job given to me is to describe the various surgical role in acute pancreatitis. It's a wide topic. So for this, I have divided this topic into 4 parts. First, I will be talking about the recent terminology that we use in acute pancreatitis, the various indications for surgeries in these various scenarios, when should we operate these cases, and what are the different ways. The Atlanta classification, which was initially described in 1982, was updated in 2007 and later revised very recently in 2012. It told us that any patient of pancreatitis would initially have an early phase reaction, which would be mainly inflammatory during the first week. Those patients are generally managed conservatively. But as the patient crosses the first week and goes into the subsequent period, he has a tendency to develop local complications. And this is the time when one might need to intervene surgically. It was found that organ failure is the single most important prognostic indicator, and any patient at the time of diagnosis, when had no organ failure, he would group in mild pancreatitis. Whereas a patient who had any organ failure, 1 or 2, and it recovered within the initial treatment within 48 hours, or a patient had any local complications, then he would be grouped in moderately severe pancreatitis. And for those patients whose organ failures persisted even beyond 48 hours, was grouped in severe pancreatitis. Generally, these patients would undergo imaging in the form of contrast-enhanced CT scan, or less preferably through MRI. And depending on the picture, they would be classified into interstitial edematous pancreatitis or necrosing pancreatitis. Interstitial edematous pancreatitis is characterized by enlargement of pancreas, which can be localized or generalized, but it will have a homogeneous pickup of contrast. It might be associated with peripancreatic fat stranding or peripancreatic homogeneous collections. Whereas a patient is said to have necrosing pancreatitis if he or she at least has 30% of pancreas, which has a heterogeneous pickup of contrast, or it may be associated with pancreatic parenchymal or peripancreatic heterogeneous collections. Such patients might have any of these 4 complications. For a patient of interstitial edematous pancreatitis, in the initial 4 weeks, he or she might develop a homogeneous fluid collection in the peripancreatic area. This collection will not have a well-defined wall, and this is called as the acute peripancreatic fluid collection. But when the patient goes beyond 4 weeks, they tend to develop a well-defined wall, and this is called as a pancreatic pseudocyst. Whereas a patient of necrosing pancreatitis in the initial 4 weeks will develop a pancreatic parenchymal or peripancreatic heterogeneous collection, which is called as acute necrotic collection. And when this collection forms a wall, well-defined wall, which occurs after 4 weeks, they are called as wall of necrosis. Now, moving on to what are the indications of surgery in these various scenarios. I have divided this into 2 basic groups. First, indications that aim at mitigating the cause of biliary pancreatitis, and other indications which aim at handling the complication of pancreatitis. For a patient with mild biliary pancreatitis, there are two schools of thoughts. Various guidelines have advised for an early cholecystectomy as compared to an interval cholecystectomy. Interval cholecystectomy is said to be done after 4 to 6 weeks of settling of the patient. This is associated with high rates of recurrence of pancreatitis because of the passage of stone. Early cholecystectomy is defined by various guidelines in different ways. For example, for the British group, they define that cholecystectomy which is done within 2 weeks of discharge of such patient. And whereas other groups like American group or International Association of Pancreatology define that the cholecystectomy should be done in the index admission itself. For a patient with severe biliary pancreatitis, it is undoubtedly proven that interval cholecystectomy is the best way. However, these guidelines give us a fair indication that at the time of discharge, one can consider doing a biliary sphincterotomy, and many centers are practicing first ERCP, biliary sphincterotomy, and then do an interval cholecystectomy. For a patient with moderately severe pancreatitis, biliary pancreatitis, there are no definite guidelines, but we generally tend to follow the protocols for mild biliary pancreatitis. Now, indications for surgery in case of complications. Let us talk about pseudosis. For pseudosis, we can group the indications into three types. First, when the pseudosis is complicated, that is, it can cause gastric or duodenal obstruction. It can cause obstruction to the common bile duct, can cause cholangitis, obstructive jaundice, or it itself can get infected, or there might be hemorrhage or any vascular complications like compression of large vessels, or it might be associated with pancreatic dural fistula. Those pseudosis which are not complicated but are symptomatic because of the sheer size of the pseudosis, like they might have early satiety, nausea and vomiting, pain, or upper GI bleeding. This generally patient will present with failure to thrive. And there is one another indication, that is asymptomatic pancreatic pseudosis, which are more than 5 centimeters. And even on treatment or your conservative management for more than 6 weeks, they tend to be of same size. This, however, is quite debatable point, because many of us do practice to have a long conservative management, and much more beyond than 6 weeks we do wait. The options for pancreatic pseudosis surgery are internal drainage, resection, and external drainage. Internal drainage is still the gold standard, because many of times they might have a communication with the main pancreatic duct. And in these scenarios, laparoscopy or minimal access route has proven its benefit with respect to decreased morbidity at equal mortality rates with comparison to open. This can be done either by cystogastrostomy, cystoduodenostomy, or Roux-en-Y cystogenostomy. Depending upon the location, we can plan the surgery. For a patient who has a pseudosis in the lesser sac, where the pseudosis is close to the stomach wall, we can go ahead with a cystogastrostomy. For a pseudosis which is more near the duodenum, near the head of the pancreas, we can plan a cystoduodenostomy. And for any other locations, a Roux-en-Y cystogenostomy can be done. Resection is generally preferred whenever a pseudosis of pancreas has any vascular complication, it has a hemorrhage in it, or it is associated with any pseudoaneurysms. External drainage is generally a temporary or an interim approach in cases of infected pseudosis, or when the patient is not fit for surgery. And if we limit only to external drainage, these patients will have a high rate of recurrence and complications. I will describe the most common cystogastrostomy that has been done. So this was a case of 40-year-old gentleman who was diagnosed with alcohol-induced pancreatitis. He presented to us after 4 weeks from the onset of the pain. He came with complaints of recurrent vomiting and upper abdominal pain. His CT scan showed a pseudosis in the lesser sac. This was an ideal case for a cystogastrostomy. Generally, in such scenarios, we always have a look at the inframesocolic compartment for the external pseudosis. Then we localize the pseudosis, and over the area, we proceed with the anterior gastrotomy. This can be done with a harmonic shear or with any monopolar or bipolar cutting devices. After the anterior gastrotomy, we localize the pseudosis with the help of an aspiration needle. We confirm that we are in the right location, and then proceed with the posterior gastrotomy and opening of the pseudosis wall. Now we are widening the posterior gastrotomy and opening of the pseudocyst wall. We had some hemorrhage in this patient, which was cleared and whole of the contents were aspirated from the pseudocyst. Now we could see some of the debris which are clearly visible. Even those can be nicely cleared with the help of laparoscopic route. After clearance, we have to approximate the posterior gastric wall with the pseudocyst wall. This can be done with the help of endo-GI staplers, which is very quick, but at the same time it is costly, or we can do it with sutures. Here I am using a barb suture. The benefit of barb suture is we do not need to apply continuous traction. Once it is pulled, it tends to remain in its place. Here we are applying continuous sutures in all the clocks of the opening. Barb sutures makes suturing very simple in such scenarios. And once we complete all the clocks, then we make sure that the opening of the posterior gastrotomy and the pseudocyst wall is sufficient enough for continuous drainage. We do the final check and then close the anterior gastric wall. The same approach can be used for a necrotic collection which is localized behind the stomach. Now, moving on to indications for surgery in case of walled-off necrosis. This can be grouped into two indications. Once where there is a proven infected collection, or when a patient is suspected to have an infective collection. Proven infected collection are those patients wherein we have a very definite positive culture report, which is a culture which is obtained from the collection material itself, obtained by fine needle aspirations or through any percutaneous drainage procedure. If we don't have any positive culture report, but if we see gas on CT scan, that is a very strong evidence of any infected collection. Sometimes we might have patients which might not respond to any conservative management. We don't have any culture reports. They persistently deteriorate over time. Such patients are also having failure, also in the group of failure to thrive. These patients are referred to as called to as suspected infected collections. Now, these patients, when should we operate? All the guidelines and all the trials have very clearly indicated that such patients should be operated beyond 4 weeks from the onset of pain. This is associated with decreased rates of mortality and decreased rates of morbidity. But having such a delay may not be easy in such patients. We might need to make use of certain strategies which mainly are focused on pain management, nutrition, and sepsis control. We have various drugs for pain management, but we should keep a very low threshold for using epidural analgesia, as it is very effective in having a very good pain control and preventing complications with respect to respiratory system. Nutrition is the second most important thing, and sometimes when oral nutrition is not possible, we can take help of nasogeneal tubes for enteral nutrition. The third most important thing is sepsis control, which can be done by placing percutaneous pigtails, image guided. It can be one or multiple pigtails. Using the same principle, there was a randomized controlled Dutch trial. This is the Panther trial, which was published in 2007. It made a comparison between the step-up approach and open necrosectomy. They gave us a protocol of step-up approach, wherein a patient who was diagnosed with acute necrotizing infected pancreatitis, it might be proven infection or it might be suspected infection. These patients were subjected to image-guided pigtail positioning, preferably on the left side in such wall-off necrosis. These patients are further observed for 72 hours, 3 days. And then if the patients are still having signs of sepsis, they are re-imaged. Depending upon the present findings, we will reposition the pigtail, or we can put even more pigtails. These patients are further observed for next 3 days. And if there are signs of sepsis or the pigtail is not sufficient enough to drain the collection, we can proceed with a necrosectomy through a minimal access route. The choice of procedure in such cases in this paper was a video assisted retroperitoneal drainage. The thing that we understood from this paper was we should aim at mitigating sepsis, that is taking out the heat of the flame from such collections by putting pigtails. This would give us some time and make the patient stable. And it has been found that over 50% of such patients might not need any kind of surgery. But for those who require any surgery, we can go ahead with necrosectomy through minimal access route. What are the different ways in which we can do a minimal access necrosectomy? It can be through, as I described before, video-assisted retroperitoneal debridement, or it can be through a laparoscopic route, or it can be through an endoscopic route. Endoscopic route is preferably done by gastroenterologists who are well trained in flexible endoscopy. I would be focusing more on the first two approaches. This picture clearly describes how the step-up approach and the WAD works. Through step-up approach, whenever a patient has a wall of necrosis, which is infected or suspected to have infection, through image guided, we would place a pigtail in the cavity. This would create a track from the skin to the collection. We would wait for a certain time. Now that time might be 72 days, might be even more. Many of us tend to wait for more time as compared to only 3 days, which was mentioned in that trial. So once the tract is formed, and if we feel that patient is not responding to our treatment, we can go ahead with debridement through this tract. And this can be aided with the help of any laparoscope, cystoscope, or nephroscope. This was a 50-year-old gentleman who presented with alcohol-induced acute necrotizing pancreatitis. We initially tried to manage him conservatively, but he developed a wall of necrosis, which we, even on conservative management, he kept on worsening. So we first put a pigtail in him. And even after subsequent management, he continued to have that wall of necrosis with signs of sepsis. So in this scenario, we take an incision on the pigtail, deepen it till the wall of the pseudocyst. And then after opening the cavity, we drain off all the collection and clear the necrosome. This surgery is a combination of open as well as minimal access route, because we are very focused going on that particular collection. And once we have done open necrosectomy through this route, we take the help of either laparoscope or any other scope which is available for the necrosectomy. Necrosectomy is generally done either with gentle dissection through finger or through instruments like sponge holding forceps by applying uniform gentle pressure. Jerky movements and strong application of pressure should be avoided, because this necrosome might be connected to a wall which might harbor a pseudoaneurysm of the vessel. And bleeding in such scenarios is very torrential. Now we have introduced the scope, and under vision we are clearing the necrosome. Here, suction and irrigation are the two important steps for doing the necrosectomy. Copious amount of irrigation is necessary in such procedures. It helps remove the necrosome or the muck, and also helps us achieve hemostasis. After irrigation and after seeing that, after achieving hemostasis, we generally place two drains. One is for irrigating and second is for taking out the irrigating fluid. Generally, we use an infant feeding tube in such cavity, and another big drain is kept. We first make sure that irrigation is working. And this is the final picture. Going on to the other ways of necrosectomy through laparoscopic route. This was an elderly gentleman who came to us with alcohol-induced acute necrotizing pancreatitis. He presented to us in a very septic stage. He was having an acute fluid collection in the subdiaphragmatic area. Along with that, he was having a wall of necrosis. At that time, I didn't have the facility of putting percutaneous drains, and we tried to manage him conservatively, but he was not responding to any kind of treatment. So we decided to proceed with laparoscopic necrosectomy. We made a direct trocar entry first into the collection, removed all the fluid that was there, and then under vision, we achieved pneumoperitoneum and then placed the further ports. Since the wall of necrosis was more in the head and the body of the pancreas, we went through a transgastrocolic approach. Gastrocolic omentum was adherent to the wall of necrosis itself. After pushing the colon down and putting a traction on the transverse mesocolon, we entered the wall of necrosis. Generally, adhesions are the markers where the wall of necrosis will be there or any collection will be there. Here we can see the necrosome. Again, gentle traction, suction, and irrigation are the three important ways by which we do a necrosectomy. Because of benefit of having the visualization of the cavity, we can see all the corners. Sometimes we might need to put scope from the other side so as to see the cavity from our side. Here we can see the necrosome is still there in the uncinate area of the pancreas. It is preferable to have a bag then and there and keep all the necrosome in the bag itself, because there might be a chance of we might lose the necrotic material and it might be a focus for infection later on. Now the necrosome was cut in the bag and removed. And later, after the final check, we had to place the irrigating tube and the abdominal drain. I'm sorry for the poor quality of this video. I made this video when we didn't have proper recording facilities. It was recorded on the mobile. Now the second route, that is the inframesocolic necrosectomy. We had one case of 45-year-old gentleman. Again, he had alcoholic pancreatitis. He presented to us with acute necrosing collection. And that time he didn't have any well-defined wall. And he had all the signs of sepsis, which he was not able to manage even on conservative treatment. So we went ahead with laparoscopic inframesocolic necrosectomy. Here colon is pulled up and the bowel is, adductolysis is done. We are pulling the proximal vaginal loop downwards and then the collection would come into picture. Here we can see that it doesn't have a well-defined wall and the necrotic material is not well demarcated. It is not as we had seen the previous surgeries. Generally, this is not a common indication, but yes, once if the patient is not responding and we can't put pigtails in these scenarios, then this kind of approach can be used. This patient required another 3 months of that tubes which were kept over there. After seeing all these ways, we come to the question, which way should be my way? There is no single study or trial which says that this particular way or other way is better than the other. We have to tailor our approach as per the patient's condition, the location of the collection, and the number of collection. Apart from that, available resources as well as available expertise in that particular field plays an important role. So my take-home message is, for mild biliary pancreatitis, early cholecystectomy in index admission is preferable. For severe biliary pancreatitis, delayed cholecystectomy is definitely the mode of treatment, but we can consider doing a biliary sphincterotomy at the time of discharge. Pseudocyst of pancreas, internal drainage is the gold standard. LAP has its own benefit with respect to morbidity as compared to open. And for necrosectomies, we have to tailor the approach individually as per the patient's scenario. But step-up approach has definitely proven that minimal access route and taking out the heat of the flame is the way of managing such collections. Thank you.
Excellent, Dr. Abhishek. A very lucid one, explained a difficult topic in a very simple way. I want to know what are the indications of ERCP in acute pancreatitis?
The role of ERCP is very limited in acute pancreatitis. I would say there are only 3 indications. One is when patient is having cholangitis. When all the parameters are showing that he is having an acute cholangitis, in such patients, ERCP should be done within the first 24 hours itself. If the patient is not having cholangitis, but his persistent pictures, lab pictures are showing that he has a persistent CBD obstruction, this can also be one of the indications for doing ERCP. And the third is, if we are having a severe biliary pancreatitis and we are discharging the patient, in those patients, we can subject this patient to ERCP with sphincterotomy with the aim that this will reduce the chances of recurrent passage of stones and causing recurrent pancreatitis.
Any questions from the audience?
Abhishek, you are one of those young surgeons who is a very good endoscopist also, intervention endoscopist. So your take on endoscopic management of pseudocyst or walled off necrosis?
sir, I have not put any side on that, but it is definitely one of the very strong modalities which can achieve equivalent results as compared to other minimal access routes. And this now in some trials is the first preferred route. Even in the Panther trial, they have said you have to put image guided pigtails or do a endoscopic drainage as the first step. There's one trial which is coming up. It is a tension trial. It is in process. It is a randomized control trial between endoscopic routes of necrosectomies and a minimal access necrosectomy. We are waiting for the result, but yes, it is a very promising and having equivalent results.
No, so would you like to venture in that? I mean, do you think that is a very good option for a patient if you?
Yes,
so,
sir.
Or you will select depending on the amount of necrosis or whatever the condition is.
Sir, definitely I would say that I would like to venture. But again, there is a very broad difference between the thinking process of a gastroenterologist and a thinking process of a surgeon. For example, we had once a talk with a very profound gastroenterologist. He said that we don't believe in taking out necrosome altogether. We believe that we should take it in parts. We might do it in multiple steps. This, however, is one of the accepted one of the accepted principles. Whereas the surgeon, on the other hand, would prefer to take out everything in one go. He would not subject patients to again and again procedures. Now
that is one biggest advantage we have, that if we are going in, we are taking out everything in a single go. That is why we still prefer going in with minimal invasive or whichever way we
agreed.
Thank you.
Thank you, Dr. Abhishek. I'd request our chairpersons, Dr. Telkar sir and Dr. Darokar sir.
May I request? I just want to invite all of you to a conference Akula is going to conduct. It will be the 4th conference of Vidarbha Surgeons Association. We are planning it in the March of the next year, that is on 5th and 6th. If you allow me, can I play a video of that same?
Sure.
Thank you. Audio. Thank you.
Thank you, Dr. Abhishek. I request Dr. Telkar sir and Dr. Darokar sir to felicitate our speaker.
I request Dr. Amit Bhasme to felicitate our chairperson. Next, I request Dr. Siddharth Dubashi sir on topic blunt injury, abdominal injuries. And I request chairpersons Dr. Abhijit Deshmukh sir and Dr. Sangeeta Khona ma'am.
I request Dr. Abhijit Deshmukh sir to introduce our today's speaker.
Very good morning. We have speaker Dr. Dubashi sir. He is an eminent surgeon from Nagpur. Professor Dr. Siddharth Dubashi is an alumni of BJ Government Medical College, Pune. Apart from being a surgeon, he holds PhD in higher education and is also a FEMER fellow with a teaching experience of over 20 years and an administrative experience of over 15 years. He has more than 100 research papers to his credit. He is a recipient of over 33 fellowships and awards. He has delivered over 150 lectures at various international, national, and state conferences. He has been invited as an expert committee member by Government of Maharashtra for formulating the process of impact assessment of health services, health science institution in state, as well as by Rajiv Gandhi University of Health Services, Karnataka, for formulating competency-based program for MS surgery. He has been appointed by the National Medical Commission as expert member for emergency medical program. He is the professor and head of Department of Surgery at AIIMS Nagpur. Please, sir.
Thank you. Thank you for the kind introduction, respected chairpersons. The President of the Maharashtra State Chapter of ASI, Dr. Ganeriwal sir, the office bearers of the Maharashtra State Chapter, the President of the Association of Surgeons of Amravati, Madam Ingole, and her team, senior surgeons, fellow delegates, ladies and gentlemen. I express my sincere gratitude to the organizers for giving me an opportunity to be a part of the scientific deliberations here. I bring greetings from the All India Institute of Medical Sciences, Nagpur. This topic of blunt injury abdomen is a very vast topic. If I choose one particular organ or one particular entity out of it, then 20 minutes may not be enough. So I thought that we would go in for some evidence-based guidelines and basic principles in management of blunt injury, and let us have an overview. So we will talk of the initial assessment aspect, the debate of a non-operative versus an operative management for blunt injury abdomen, role of interventional radiology, the complications and sequelae, especially with reference to the blunt liver and splenic injury. What are the critical care issues, the discharge and the follow-up protocols for such patients, especially those who would be managed with a non-operative modality. So blunt trauma abdomen is definitely a challenging situation in the emergency department, posing a diagnostic challenge, dilemma. There would be abdominal as well as extra-abdominal injuries. The causes would be because of the vehicular accidents or falls or assaults. The mechanism of injury, it may be evident on clinical examination itself or on history taking by direct impact, or you may have the deceleration forces or certain shearing forces all acting together. The base for this particular lecture today are going to be the evidence-based guidelines which have been framed by the Indian Society for Trauma and Acute Care and our Center of All India Institute of Medical Sciences, New Delhi, in collaboration with the WHO Collaborating Center for Emergency and Trauma. The first point, when you have a patient in the ER, the initial assessment of a patient with a blunt trauma abdomen, we have the primary survey and the secondary survey. Primary survey comprising of the airway, breathing, circulation, disability. But what is more important with respect to the modality of treatment that we are going to take up is the evaluation of the hemodynamic status of the individual. In case of a hemorrhagic shock, the initial assessment, initial response, whether it's a partial responder, a complete responder, or a non-responder to the initial resuscitation, also takes call. And when you talk of an hemodynamically unstable patient, what comes into vogue is the damage control resuscitation and the amount of fluid. We should not overload the initial fluid bolus, which has to be given of around 1 liter. All these concepts, when you talk of damage control surgery, damage control resuscitation, why have all these come into practice now? Why are they finding place in the evidence-based guidelines? We all need to take care or combat the lethal triad. We talk of acidosis, we talk of the coagulopathy. We need to tackle all these at an appropriate time. Not only that, if you talk of the recent guidelines, Asensio et al. Added even the component of arrhythmia to the dangerous triad. So when you talk of the damage control resuscitation, ladies and gentlemen, what is our aim? We optimize the tissue perfusion and oxygen delivery at that particular instance, correct the coagulopathy, minimize the use of crystalloids, correct the acidosis. How do we achieve all this? The early judicious use of blood and blood products, warm fluids, warm patient, and if hemodynamic unstable, with all these, along with all this armamentarium with you, shift to the OR. A word about the crash trial, that is the randomization for the use of the antifibrinolytics in significant hemorrhage. We are going to talk of the matter study. That brings us to the point I told, how do we achieve the damage control resuscitation? And that everybody should know is about the massive transfusion protocols, massive hemorrhage protocols, which established to provide rapid blood replacement in the setting of severe hemorrhage. Can we predict? Can we predict who's going to require more blood transfusions? Yes, we can objectively predict. We have the TASH score now. We have the trauma-associated hemorrhage scores, which takes into account the gender of the patient, the blood pressure, the heart rate. We have got the clinical findings. We have got the laboratory, and that is the point of care test now, and that is the FAST. And C4 in associated pelvic fractures, unstable pelvic fractures, femoral fractures, which would be having a greater score. So the entire TASH score would range from 0 to 31. The moment you have more than 17, 18, you can predict that the patient, around 50 to 70% of the patients would require multiple transfusions. So initiation, apt initiation of massive hemorrhage protocols is the need of the hour. Definitions in terms of 10 units of RBCs in 24 hours, total blood volume replaced within 24 hours, 3 units over 1 hour, or 50% of total blood volume replaced within 3 hours is the accepted definition. The role of antifibrinolytics, tranexamic acid in patient with hemorrhagic shock recommended within first 3 hours of injury. The activation of these protocols would reduce the time to initiate blood transfusion, and the ratio, the ideal ratio recommended for these components when you talk of the RBCs, the platelets, or FFP is 1:1:1. We have the proper trial by Holcomb et al. In 2015, who has compared the ratio of 1:1:2 versus 1:1:1, found favorable with a balanced ratio. When you talk of the point of care tests or the point of care ultrasound, that is an established guideline now, that is FAST, or added now is eFAST, where you can even evaluate, apart from the 2 quadrants, the cardiac evaluation or the hypogastric evaluation, we can even evaluate the hemithoracis. And the FAST is recommended in all patients with blunt abdominal trauma. Now, the management of a hemodynamically stable abdominal trauma issue, whether to operate or not to operate. If you see I was reviewing the literature, the pendulum swung towards the non-operative management after 1960, high non-therapeutic laparotomy rates with associated morbidity and costs, the evolving diagnostic techniques, and the various non-surgical interventions which are available. Significant change in the management strategies, especially for the liver injuries, occurred after the late 1980s. We have a paper here, a multi-center experience with 404 patients, 1995, the landmark paper. We also have the first reported series of pediatric patients managed non-operatively for blunt splenic trauma. Before we go on, quickly, the liver injury grading as we have from grade 1 to 6, starting from the subcapsular hematoma or a superficial laceration, going on to the increasing depths of the parenchymal laceration up to the devascularization of the liver or the hepatic avulsion. Similarly, for spleen, from a subcapsular hematoma, non-expanding, expanding, the parenchymal lacerations going in depth, and finally a shattered spleen. When we talk of the non-operative management for a blunt liver and splenic trauma, criteria: hemodynamically stable patients, facility for CCT scans, intensive care monitoring, blood product transfusions, angioembolization, endoscopic procedure availability. Apart from that, 4-hourly serial clinical examination for first 48 to 72 hours, rider preferably by the same team. Laboratory investigations, we have got point of care tests. Apart from the blood count, even the thromboelastography, the viscoelasticity tests available now, and the arterial blood gas analysis. Baseline coagulation profile repeated as per requirement. Ultrasound recommended at 48 to 72 hours in high-grade blunt liver and splenic injuries. Repeat scans in case of clinical laboratory signs of worsening. At least 3 days of hospital stay for any grade of injuries. There is still a debate, no consensus statements available for the prophylactic use of antibiotics or prophylactic intraperitoneal drains. Another topic which finds a place in the evidence-based guidelines, and that is the damage control surgery. It's a paradigm shift. Described, if you really go into literature, the concept of an abbreviated laparotomy was brought about by Stone in 1983. 93, we had subsequently Rotondo and Schwal bringing it the concept of the damage control surgery. We have the initial control of the hemorrhage, quick in, quick out for the first encounter, restoration of the normal physiology, the critical issues, the ICU management, and subsequently we can have the planned operations and reconstructions of the abdomen. When you talk of the operative management for the blunt liver injury, hemodynamic instability, peritonitis, and failure of the norm. The main reason for the failure of norm is the ongoing bleeding tendencies that would be there. But still, when you talk of operative, it is not something heroic, but a damage control approach in hemodynamically unstable patients, control the hemorrhage and the contamination. That's the only requirement at the moment. Major hepatic resections, of course, deferred for a second look or centers with the required facilities. When you talk of the operative management for a blunt splenic injury, again, hemodynamic instability or peritonitis or the failure of the non-operative modality of management, considered in high-grade blunt splenic injury, even in stable patients, in a resource-constrained setting where intensive monitoring facilities will not be there, angioembolization facility not available, we can go in with a splenectomy. Splenic salvage procedures not recommended in hemodynamically unstable patients. Incidental finding during laparotomy for some other evaluation of other injuries. Attempt to mobilize the spleen completely, understand the full extent of injury, and take the appropriate decision. Angioembolization facilities in blunt liver injury for the hemodynamically stable patients with the evidence of the blush on the CCT scans. Not recommended in hemodynamically stable patients with the high-grade blunt injuries without evidence of a contrast leak. Recommended in hemodynamically stable polytrauma patients, but not with concomitant severe head injury, where again the hypotension would be an issue. In blunt splenic injuries as well, in hemodynamically stable patients with splenic vascular injury, prophylactic value in high-grade injury, irrespective of the vascular pathology. When we talk of the critical care issues, extremely important because we told that the component, if you talk of damage control surgery, there are 3 phases, actually 4 phases. That means it starts from the pre-hospital scenario, then the damage control, actually taking care of the hemorrhage and the contamination. After that is restoration, try and attempt to have the optimum physiology. And then we have the reconstruction, the planned ventral hernia, and subsequent, the definitive methods of the abdominal wall closure. So the optimize and maintain the physiology with ongoing resuscitation and intense monitoring, that's the critical issue. Low tidal volume ventilation for all receiving mechanical ventilation following the solid organ injury. Target hemoglobin values at around 10 in those with risk of bleeding, around 7 in stable patients with satisfactory hemostasis. With the point of care ultrasound tests, again the value. When you talk of the viscoelastic methods, wherein you are actually evaluating bedside evaluation of the intrinsic extrinsic coagulation pathway, it's really helpful. Measurement of the lactate and the base excess is extremely crucial. Base deficit is extremely crucial. Lactate levels, which would reflect the oxygen depth and the tissue hypoperfusion during the shock phase, and the best base deficit values provide an estimation of the tissue acidosis. So both are essential. Early and repeated coagulation profile in hemodynamically unstable patients with solid organ injury. Maintenance of normothermia in the trauma patients. Now, initial, because the patients may have some bleeding disorders, not confirmed, initially mechanical thromboprophylaxis, and at the earliest, when every situation is under control, now a combination of mechanical and pharmacological thromboprophylaxis. Abdominal girth chart, of course, not to be ignored with other clinical parameters, preferably serial clinical examinations by the same team. When we talk of the complications and the sequelae of the blunt liver injury, blunt liver injuries have a higher complication rate with the operative management in one of the trials, 2016, 45 versus 21%. Complication rate would naturally increase with the higher grades of liver injury. Hemorrhage is the most common cause of the failure of the non-operative management, and operative management recommended for hemodynamically unstable patients with ongoing bleed. Again, damage control approach. Angioembolization recommended for hemodynamically stable patient with signs of ongoing bleed. Biliary complications would range from 4 to 7 in non-operative versus 8 to 15 in the operative mode. ERCP internal standing recommended for management of significant biliary complications following blunt liver injury. In case of the development of the collections, image-guided percutaneous drainage with antibiotics, the first line of treatment, surgical intervention when this is failed or not feasible. Emergency splenectomy recommended in failed non-operative mode of management. But here, of course, an entity of the delayed splenic hemorrhage. Emergency splenectomy recommended in hemodynamically unstable patients. When we talk of the follow-up protocols for patients with blunt abdominal injury, non-operative, those patients which have been tackled with a non-operative modality, followed up at 7 days after discharge, asymptomatic patients to be recalled preferably at 3 months, 6 months after the first follow-up visit. Word about pancreatic injuries. 5% of cases of the blunt abdominal trauma, but significant mortality, morbidity due to the delayed diagnosis or the missed injuries. Diagnosis of pancreatic injury based on only serum amylase lipase levels is not recommended. CT scan is recommended for diagnosing pancreatic injuries in hemodynamically stable trauma patients. Presence of peripancreatic fluid and active hemorrhage within pancreatic parenchyma recommended to be highly specific for evidence of ductal injury. MRCP can be used as second line investigation to diagnose pancreatic duct injury. ERCP recommended for planning of select cases of post-injury complications, and the non-operative modality for the hemodynamically stable patients recommended for grade 1, grade 2 pancreatic injuries detected on a CECT. Non-resectional management for grade 1, grade 2 pancreatic injuries which are found during laparotomy for other indications. In case of grade 3 injury, yes, operative management. Grade 4, grade 5, again see the hemodynamic status of the individual, whether it warrants just a damage control approach or a definitive procedure can be done. And the incidence of the pancreatic fistula surgery ranges from 5 to 37%, abscess formation following trauma around 10 to 25%, and acute and fluid collection cirrhosis formation would be evident in cases after the non-operative modality has been used for the blunt injury abdomen. renal injury with the lesions starting from small contusions, increasing in size, expanding hematomas, or a shattered type of a lesion. All blunt trauma patients with gross hematuria, macroscopic hematuria, and shock should undergo renal imaging, usually CT with IV contrast. Hemodynamically stable patient with an injury well staged by CT scan can usually be managed without the exploration, but 90% of the blunt renal injuries can be managed non-operatively. Grade 4, grade 5 will require surgical intervention. Another thing, apart from the blunt liver trauma, blunt splenic injuries, pancreas, the renal injuries, let us not forget another entity, and that is a traumatic abdominal wall hernia. And these present in the acute setting due to blunt injury, though rare, but it is an entity. And I'll just present the case which we have encountered. So traumatic abdominal wall hernia occurs in about 1% of all cases of abdominal trauma. And the handlebar hernias are the type of the traumatic abdominal hernias caused by such blunt objects. They would present with the disruption of the muscle and the facial layers, but an intact skin and no signs of previous hernia at the same site. This is what mentioned in literature. We had a 23-year-old boy presented to the ER with herniation of the bowel loops to a traumatic defect in the left lower abdomen. It is a sustained injury as a result of the blunt impact force of the handlebar of the motorcycle was riding. Impact was so severe that the blunt injury has caused the disruption of the skin, muscle, and facial layers. The herniating congested bowel loops were examined for viability. Fortunately, no resection was required, no evidence of free fluid in abdomen, and the hernial defect closed. Post-operative period uneventful. Described initially by Selby in 1906, first case of handlebar hernia described in 1956. If you see the classification of these traumatic abdominal wall hernias, type 1, when you have a localized abdomen defect caused by low energy blunt force, objects like the bicycle or the motorcycle handlebars, or you have got the larger defects caused by the high energy deceleration forces or the compression forces, or you can have herniation to an isolated peritoneal defect due to fall from height. Now, the elastic properties of skin prevent disruption due to the blunt forces. But in our case, though the mode of injury was as per the type 1 pattern, which is described, still the abdominal layers were disrupted along with the loss of skin integrity. We have the history of the blunt trauma abdomen, pain, local swelling, and even the skin ecchymosis. Tattoo or imprint is described as the London sign. Abdominal wall defect would be palpable. This I'm talking of the classical traumatic abdominal wall hernias, wherein it is expected that the skin integrity is not lost. And the imaging modalities would be helpful. We also have the CT classifications, which have been given right from the subcutaneous tissue contusion right up to the muscle disruption and finally the open herniation itself. So the management includes the exploration and the defect closure, acute emergency presentation, advisable to do the repair, hemodynamic instability, signs of peritonitis warrant urgent laparotomy. To conclude, ladies and gentlemen, our entire focus on preventing the lethal triad. The issues of acidosis, the issue of coagulopathy needs to be looked at. Hypothermia, acidosis, hypothermia, coagulopathy, and now added arrhythmias. So focus on prevention of the lethal triad, combat the lethal triad. And for that, we need to prioritize. When you talk of the initial assessment, everything would depend, everything would revolve around the hemodynamic status of the individual. And then we have the concepts of the damage control resuscitation, the damage control surgery, the non-operative management, depending on the hemodynamic status of the individual, and the ancillary facilities which we have, especially with reference to the scans which would be available or facilities for angioembolization if required. So if we talk of the pillars of the non-operative management, the improved sensitivity of the diagnostic modalities and the rise of interventional radiology, there is a place now, evidence-based place now for the point of care tests, and the point of care ultrasound focus is now the need of the hour. Revolutionizing advancement in the resuscitation strategies. When you talk of the normothermia, when you talk of the massive transfusion protocols, when you talk of the trauma-associated hemorrhage scores, we can anticipate the risk. We can anticipate the patients who would require multiple transfusions and the prompt availability of expert operative management with the ancillary support. As mentioned by Salter, decisions are more important than incisions. And of course, a balance needs to be maintained. Thank you, ladies and gentlemen.
Thank you, sir, for elaborate explanation. Any questions from audience?
Morning, sir. In any case, if there is a injury to abdominal wall, do we need to put mesh in such cases? If hernia is there, accidental hernia is there?
It all would depend on, see, classical, if you talk of the evidence-based guidelines, it is not recommended. Number two, if you see the blunt trauma, there would be local clots, ecchymosis, all those factors would be there. Now, these clots and all are going to be definitely nidus of infection. But we mostly find that there is local contamination, so mesh placement is not advocated in emergency setting.
Thank you, sir.
In fact, it is said that for such defects, let it be a planned ventral hernia later on. It will give better results. Thank you.
Thank you, sir.
Thank you.
Thank you.
May I request chairpersons to felicitate our speaker? I request Ingole ma'am to felicitate our chairpersons. Our next topic from Dr. Prashant Rahate sir on pelvic floor anatomy and ODS. I request chairperson Dr. Santosh Somani and Dr. Sachin Jamma sir.
Good morning, everybody. Dr. Prashant Rahate. You don't need any introduction. He is one of the eminent surgeon, endoscopist, and laparoscopic surgeon, colorectal surgeon, and many more. I may request Dr. Prashant Rahate sir to proceed his lecture.
Thank you, Somani sir, for that introduction. This particular topic is basically a totally neglected topic when we are in our medical schools. The anatomy of the pelvic structures. During anatomy dissection, then in gynec, then in surgery, we usually don't give much importance to this part. And it is really very difficult to understand also, but I will try to simplify this topic. I have prepared some three-dimensional videos. My son has helped me in preparing those videos. There is no financial support or affiliations for this presentation. I will be discussing some commercial instrument while giving this particular lecture. And I thank ASA, executive body, Dr. Jayashree, Dr. Ganeriwal sir, Umay sir and the complete Masi for giving me this opportunity. So we will start immediately. A voice lagla hai kya? Voice lagla hai, okay. So diamond shaped space formed it between the various bony structures. This is the ischium bone. This is the pubic bone anteriorly, and this is the coccyx posteriorly. So in between these three bony structures, it is the perineum. And the perineum is supported by the pelvic muscles, which are iliococcygeus muscle, puboanalis muscle or puborectalis, and the third one is the pubococcygeus muscle. So all these muscles, they converge at the perineal body. Perineal body is a center point of the perineum where both fibrous and muscular tissue coverage converges. And it is present in between the anal opening and the urogenital opening anteriorly. So first we will see the structure of the anal sphincter. This is the anal sphincter, and this part is the most subcutaneous part of the external anal sphincter. Therefore, it is called a subcutaneous part. And the second part, deep to the subcutaneous part, is the superficial part of the external anal sphincter. It is continuation of the anococcygeal ligament. So this is very tough structure, and this is the muscular part of the anococcygeal ligament, which forms the superficial part of the external anal sphincter. And lastly, the deepest part is the deep part of the external anal sphincter. It is formed by the puboanalis or puborectalis muscle. So puborectalis muscle supports the deep part of the anal sphincter, or it converges into the deeper part of the anal sphincter. So anal sphincter is having three parts: the deep, superficial, and subcutaneous. So now we will see. After seeing the pelvic diaphragm from the perineal side, we will see it from the inside. So I will be rotating here and will be going anterior to the sacrum. So this is the pubic symphysis here. The urogenital opening here in female vaginal, and in males and females both is the urethral opening. Now we will see the muscles. This is the pubococcygeus muscle, starting from the pubic bone going toward the coccyx, and the lateral muscle is the iliococcygeus muscle. So from the ilium to coccyx. So from the inner side, only two pelvic muscles they are visualized. So after confirming all the muscles of the pelvis from the perineal side and from the pelvic side, we will see the various organ disposition. First, we will see the urogenital thing. I will be adding urogenital. Then I will be adding the digestive, that is the rectum, and I will reduce the size. So all these structures, they are configured in the pelvic cavity in such a way that they accommodate each other. And during the act of parturition or childbirth, during the act of micturition, and during the act of defecation, every time, along with the gravity, this pelvic muscle diaphragm is bearing the insult, because it has to bear down the complete pressure. The pressure sustenance is to be done by the pelvic diaphragm. And basically that is the genesis for development of ODS, that is the obstructive defecatory syndrome. Because of the constant trauma, the pressure management systems, the pelvic diaphragm goes down, it becomes weak, fibrotic, and descends down as the age advances. And that leads to obstructive defecatory syndrome. Then after these muscles and organs, the various arteries and veins, they are then the autonomic nervous system and the somatic nervous system, all these are there in the pelvis, a very cramped place there. So we will see what is this ODS. It is the obstructed defecatory syndrome, is the term used to describe whole complex of the mechanical and the functional disorders leading to difficulty in or inadequate rectal emptying. This ODS and slow transit constipation are the two subgroups of the constipation as defined in the Rome 3 or 4 criteria for the functional bowel disorder. ODS is confined solely to the evacuation disorders, that is at the last portion of the GIT, that is the anus and the rectum. But slow transit constipation is the disease of complete GIT as well as the complete colon. So that is the difference between slow transit and ODS. 30% of the patient, they will have both the problems. ODS is an iceberg syndrome. So what is this iceberg syndrome? This is very important slide here. We are seeing only this tip of the iceberg. That is the peritoneal-entero-sigmoidocele, that is the cystocele, colpocele, then rectorectal intussusception and solitary rectal ulcer. That is what we see it actually. But behind that, there is a lot more thing, that is the anxiety, anismus, then non-relaxing puborectalis, straining, rectal hyposensation, pudendal neuropathy, and spastic colon. But all these are very difficult to diagnose. And these are all functional things. This is organic things. So at least 2 occult lesions are present in all patients with ODS in a prospective study conducted by the group of Pulvereni. So these are typically seen in middle-aged multiparous women. Prevalence ranges from 3.4 in general population. Population up to 23% in middle-aged women, they suffer from this ODS. These are the 10 classical symptoms, right from straining during defecation or even during micturition, incomplete emptying, and fragmented stools. This is important history that every now and then they will visit the washroom, they will pass on small defecation, and again they will come back unsatisfied and again they will visit. So their whole day is preoccupied with that thing only. And they do all types of posturing. They will put a finger in the vagina to expel out. They will put a finger in the rectum, anal canal. Then vaginal and rectal digitation is very important. The pain will be there, prolonged and repeated visits to the toilet. So the complete house is also preoccupied with the worry of their defecation physiology. And they are very much dependent on the laxative. Varying degree of fecal incontinence is also there in these patients. Why they do digitation, self-digitation? The aim of self-digitation is twofold. One, by compressing the rectocele pouch through the vagina, the patient makes the anorectum straight and facilitate the evacuation of the stool. And this particular act, by pushing on the peritoneum, the transverse muscles of the perineum, they are stimulated, and this elicits the reflux of rectal contraction and the evacuation of this feces occurs. But unfortunately, this act of self-digitation may cause anorectal ulcerations, followed by bleeding, discomfort, and anal fibrosis leading to strictures. How to measure this type of ODS so that we can label it that the severity of the ODS, and then depending on that, we can give the management protocols to the patient. There are many scoring tools. One of these, the Cleveland clinics, then Wexner constipation, then Dr. Longo's ODS score. All these scores, they are modified by multiple people, but all said and done, all these things, they are asked from the history itself, the 8 points. All 8 points are there in all these scores, different types of scores. So depending on that, scoring system is there. So in history itself, in OPD itself, you can score what is the ODS score. So what is the etiology? Defecation is a complex process and composed of several essential factors. So we will see, since it is a complex process, we will again see a small video. The pathway for defecation reflux, entry of the feces is here into the rectum, and then the rectum is distended. It gives the sensory nerve endings are stimulated, and the impulses are transmitted via the afferent fibers to the defecation center. The center sends the afferent descending colon impulses to descending colon and sigmoid via the efferent nerves, and these impulses, they cause strong contraction of the rectum and relaxation of the internal sphincter and anal sphincter, and thereby defecation occurs. So this is the act of physiology of the definition. So at every step of the system, there might be a problem, and that will lead to ODS. So if there is a neurological problem, then anorectal thing will go in for hyposensitivity. The tonic response of the rectum will be decreased, and these blunted response, the ODS patient with or without slow transit constipation will ultimately have a false thing of the defecation. This thing will be elicited, but they will be unable to expel out the fecal matter. The most likely cause is the impairment of the afferent sensory pathway due to pelvic nerve injuries during multiple birth traumas, pelvic surgeries such as hysterectomies, or excessive perineal descent or prolapse. The relaxation of sphincter and the pelvic floor muscles, this can also lead to a strong spastic pathology in the muscles of the pelvis will ultimately lead to anismus, dyssynergia, and that will lead to a reverse phenomena that patient will be unable to expel out. He will keep on holding the fecal matter. So there is a third thing, the anatomical or mechanical obstruction. The rectocele is a result of weakening of the rectovaginal septum. This is the rectovaginal septum here, and the rectum will be herniating into the vaginal side, leading to rectocele development. Similarly, particularly in elderly women with hysterectomy, the Douglas will come down, and all the along with the sigmoid, the small bowel will be herniating down, and this herniating bowel will cause compression over the rectum and the distal anal canal, and that will lead to obstruction. So that is the enterocele. So what this enterocele will cause? It will cause fecal incontinence, the bowel mucosa damage, leading to the rectorectal intussusception will ultimately lead to bowel mucosa damage and solitary rectal ulcer. The pudendal nerves can be damaged because of the stretch, the dilated sphincters, because the complete rectum and anal canal is protruding out, so it will dilate the sphincters, anal sphincters. The insensitivity reflux because of the pudendal nerve damage. The rectum will cause mechanical obstruction, and all these things ultimately will lead to obstructed defecatory syndrome. So this is rectorectal intussusception. This is the normal. This is the rectorectal intussusception starting. This arrowhead is classical of the rectorectal intussusception. The rectum is herniating into its own. So intussusception is being caused, and that will lead to obstructed defecatory syndrome. So high grade of full thickness intussusception is confined to symptomatic patients, and these patients, they should be treated. So how do we examine it physically? The first is the digital rectal examination. proper inspection, the perianal sensation is to be noted down, whether they are normal, impaired or absent. This will occur in pudendal neuropathy. Then various digital manure after putting the finger inside, whether there is mass, tenderness, whether there are stools, how is the stools, at what part of the anal canal and rectum the stools are present. That is very important, because if the patient is having anterior rectocele, the hard fecal matter will be present there. We ask the patient to squeeze down, bear down, and how is the sphincter relaxation and perineal descent is there, that we can see it properly. So most of the diagnosis will be there by your digital rectal examination and history. So physical examination, inability to relax, especially paradoxical contraction. Sometimes the internal prolapse can be felt touching the fingertip of the unstraining. So this is one video which will tell you that this is intussusception. You can see the intussusception. This we can see by sponge test or by the biwall speculum. We can see the rectum is descending down, rectorectal intussusception is there. The classical, we can detect it. And this particular rectorectal intussusception is obstructing the anal opening. And this is the anterior rectocele, which we can judge from the clinical history itself. So what investigations they are to be done? A battery of investigation, but difficography, ultrasound, then pudendal, then the psychological evaluation. During difficography, we have to do, we have to see some things. Here, this is a dynamic study, MRI, MR difficography. This rectocele is being getting herniated into the vaginal wall. A shelf is getting formed. This is the intestinal part which is giving pressure. Patient is straining. The fecal matter is coming out. This is the anus here, anal opening. But this part is not getting evacuated. So patient will be having a persistent feeling that he has not defecated completely. So that is the dynamic enterocele which we have seen. Then rectal sensitivity, this is very important. This test is done with the help of balloon expulsion test, usually assessed with air or water insufflation and distension of either balloon or condom inserted in the rectum. Multimodal balloon catheters, they are available with analysis of electrical and temperature receptors as well. The balloon expansion resembles the full rectum and triggers the need for evacuation. The time, the volume of the balloon, and difficulty to expel. These are the three things which we see on the balloon expulsion test. This is very simple, can be done on OPD basis also. And we can label the patient whether he is having dyssynergetic defecation or not. The mean balloon volume is usually 50 ml water. The expulsion should take less than 30 seconds in young men and less than 1 minute in older men. But in women, expulsion should occur in about a minute, regardless of the age. Balloon expulsion test along with the anorectal manometry is considered the primary diagnostic test for identifying ODS. So these two tests are very important for diagnosing the balloon expulsion. So these are the balloons which are available. These are with the catheters and electrodes. Thereby we can do the manometry as well. The manometry is also very important to detect the various pathologies. So this is the algorithm. And excessive straining, the thing starts with the excessive straining. This causes tissue weakness and organ descents. Long standing, patient becomes anxiety. There is muscle tension. The consequent non-relaxing puborectalis. We can palpate puborectalis perrectally as a classical U-shaped strong muscle. And increased straining decreases the pudendal nerve stretch. It causes the pudendal nerve stretch. This pudendal neuropathy ultimately will decrease the sensation of the rectum. The stools become small and hard, and these small stools, they will not propel. They will be difficult to evacuate, and they are less effective in stimulating the rectal wall because the volume of the stool becomes very small. The surgery has a secondary role in correcting the above mentioned defects. So all these defects they are usually, the pathophysiology behind this is not, it will not be corrected by the surgery. So it requires a long complex treatment, that is change of dietary regime, psychological support, and pelvic floor rehabilitation. And that is the reason why we should give very cautiously the decision of surgery to the patient. But seeking the faster solution, both patient and surgeon prefer faster solution to the problem. That is a straightforward operation. But this explains why most of, if not all, surgical procedure tends to fail in the long term. As reported by Wexner and Vermeulen when reporting the high failure rate of the surgery. Therefore, caution is needed prior to recommending surgery in all these patients. The conservative treatment, as I already told you, the hydrocolonotherapy, that is the rectal irrigation, can help almost 50% of the patient. Biofeedback is indicated in case of anismus and rectal hyposensation. Here in biofeedback, the patient is having the control. I will take few minutes more, sir. And the patient can judge whether he is, how is the pressure at the anorectal junction, and he keeps on relaxing, and once he is relaxes, the angle becomes straight and he defecates. So that is the feedback mechanism, how that patient is trained to reduce the puborectalis strain and how to defecate. There are various conservative line of treatments, the botulinum toxin, transcenal electrostimulation, psychological counseling, then the biofeedback. These are the pelvic floor exercises. The surgical treatment, the manual techniques, basically the resection rectopexy, Delroms, mucosectomy, sacral rectopexy, the anterior mesh rectopexy. They have satisfactory short-term results, but long-term, they will have a recurrence at the end of the 4 years. And this is one of the video of STAR. So parachute stitches, they are taken anteriorly 3 stitches at 12 o'clock, 3 o'clock and 9 o'clock. And both these, all the 3 stitches, they are brought out, and the posterior wall of the rectum and anal canal is protected by a tongue depressor there. And then the complete anterior pouch is resected with the help of stapler. So 2 firings are done with the help of this PPH1. PPH1 and PPH3, they are different. Similar procedure is repeated on the posterior side. So 2 specimen donuts are there, incomplete donuts, but they are very thick, and the rectal pouch is made straight. Complete excision of the rectal pouch is there. Then how are the results? 55% of the patients still had at least 3 symptoms of ODS at 18 months after STAR, and 19% of the cases require re-intervention. So that is the result of the surgery. So we have to be very cautious while advising the patient any surgery. Instrumentation PPH1 and 3 are different. PPH1 is having larger, bigger staplers. So therefore, while doing thicker resections as in STAR, PPH1 is used. PPH3 is used only for hemorrhoidectomy. Trans-STAR, that is the contour. This is the contour which we use it while resecting a bigger rectocele, so that the complete rectocele is excised. So this is one video, very last, I think. So that is the principle of POPSTAR, the pelvic organ prolapse and stapled transanal resection rectopexy. This is the mesh which is applied at the Douglas. The complete organs, they are prolapsed down. The complete pelvic muscles, they are relaxed. So these mesh is applied at the anterior superior leg spine, and complete thing is lifted. So the prolapse organ of pelvis, POP part is taken care of, and then STAR procedure is done. Similarly, this from the lateral side. This video I have taken from Professor Longo. with his permission, I am showing you. So this is how all the prolapsed pelvic organs, they go up by applying a V-shaped mesh here. The one part of the V is coming to right anterior superior iliac spine and the other going to left superior anterior iliac spine. So this is the short video of pop star surgery. First, examination of the pelvic organs, adenolysis is there, and a V-shaped mesh is inserted. And at the pouch of the Douglas apex, we take a stitch, and in this stitch, we incorporate the apex of the V mesh. And once that mesh is taken and fixed at the Douglas, then we insert one Maryland forceps from anterior superior iliac spine in the extraperitoneal root like this, and the end of the mesh is held and brought out toward the anterior superior iliac spine. Same thing is applied on the opposite side, and the mesh is then peritonized properly so that the pouches, the pararectal pouches, they are closed. So there will be no herniation of the abdominal organs or the intestines. So these pouches, they are closed. So that is the pop star surgery. So the NICE guidelines gives that this particular procedure is helpful in few patients, selected patients. So I again repeat this particular slide. There is utmost caution is needed prior to recommending surgery in these patients of ODS. Thank you very much for that. Thank you.
Hello.
Yes.
Very excellent presentation, Dr. Prashant. Particularly your 3D presentation of pelvic floor. Very excellent.
Thank you, sir.
Yeah. Any questions?
Yeah, Prashant, as you said earlier,
Yeah.
this is the most neglected but complicated topic and you have simplified it.
Thank
I
you,
must
sir.
appreciate the 3D presentation. It reminded us the movie Piku.
Yeah.
So, few things. One is for slow transit constipation. Do you use barium pellets, lead
Yes.
pellets, and do the
Yes.
serial X-rays?
Yes, I have presented this in ACRC meet this time. I have done, we have presented that case of colonic transit. Colon was totally immobile. There was no peristaltic movement. All the pellets were stranded in the cecum. And even after 4 days, those pellets they were not going into the transverse colon or ascending colon. So there we did appendicostomy to that patient and patient is very happy. Yes, we regularly do that for the slow transit constipation. And that is very simple. And we have modified that technique of doing, we give the charra, the bearing marbles, and we insert them in the vitamin capsules. In one capsule, we can insert 5 of that charras. And then the patient drinks water along with them. And those patients, they are not given any laxative 2 days prior to the study. And we call them after 4 days and take a simple X-ray. So how many of the foreign bodies they are expelled out, we can count, and depending on and where exactly they are there. So that particular segment of the large intestine, if it is aganglionic or if it is not mobile, aperistaltic, then the foreign bodies will be collected at that particular point. So we have done even transverse colectomy for that. We have done left-sided colectomy for that in few patients where they are aperistaltic in that particular segment. So they are helpful.
And secondly, how about conservative treatment and biofeedback? What is the time limit? You stop and go for surgery.
Yes, at least 1 to 1.5 years it takes. Before that, you have to bear with the patient and patient has to bear with us. But usually these patients, they start getting response after the 6th week, and they start keeping faith in you after 6 months. But 90% of the patient, they don't need surgery because the basic pathology, as I have told you, is the neurological and the muscular weakness, which we are not going to tackle by shortening the pouch or by shortening the large intestine. We are not going to improve the neurological function or the muscular function of the pelvis. And that is the reason why very few patients, they need surgery.
Thank you, Prashant. Are there any questions from audience?
Thank you, Prashant sir.
Thank you.
Thank you.
May I request our chairpersons, Dr. Somani sir and Dr. Jamma sir, to felicitate our speaker with a token of appreciation of memento. And may I request Dr. Darokar sir to please felicitate our Darokar sir is not there. For the next session, may I invite Dr. Yogesh Bang sir as the next speaker. And to chair this session, I request Dr. Rajesh Bobde sir and Dr. Amol Dhoran sir to chair the session, please.
Today is a birthday of Dr. Sachin Jamma, sir. Very happy birthday to you, sir. I wish you a very happy birthday on behalf of all the faculties and delegates. We will celebrate in the evening in the banquet. Thank you, sir.
I request Dr. Bobde sir to introduce our next speaker.
He is an accomplished surgical gastroenterologist, having done his post-graduation from one of the premium institutes in Government Medical College, Nagpur. After that, he did his super specialization in surgical gastroenterology under guidance of Dr. G. Rao and Dr. R. Pradeep at Asian Institute, Hyderabad. He worked as consultant at Asian Institute Gastroenterology, Hyderabad for a year. Since 2018, he is working in Nagpur as a surgical gastroenterologist. He is well versed with a wide range of gastroenterology surgical procedures and have performed and assisted most of the procedures. Thank you.
Thank you very much for that introduction, sir. I thank Associations of Surgeons of Amravati for inviting me to this forum. My topic is management of bile duct injury. And as such, this is a very huge topic, and I am going to cover only the bile duct injury which happens on table. What to do if we come across a bile duct injury on table. So bile duct injury, as we all know, as the incidence or as the number of procedures for cholecystectomy have drastically increased because of laparoscopy, or in this laparoscopy era, the bile duct injury has also increased a bit as compared to the open era. Bile duct injury is a rare but still a complication of around 0.22 to 1.5% overall. And if we look into the literature, we'll see that incidence from 0.3, 0.2 to 1% in some of the studies. And the most consistent finding among all these literature is that there is a gross underreporting of bile duct injury, or there is very much underreporting of this entity. Now, why I say that, when we look into these literatures, they have showed that nearly 1/3 to 1/2 surgeons in this study from USA or Canada have reported that they have a near miss or they had a history of bile duct injury being done. Even in this, nearly 72% of the surgeons had done a bile duct injury or had a near miss. The why I said it is underreported. So this was the one paper published in Sages. They had sent query to nearly 3,400 surgeons, and only 559 responses they could get. So even people don't want to commit to it, or people don't want to accept the fact that yes, they have done a bile duct injury. Only 16.5% responded to the queries. And of those 16.5%, nearly 47% had committed or had done a bile duct injury. Now, this is the extent to which the problem is, and then we have to diagnose it and manage. So injury to bile duct injury, committing a bile duct injury is not a problem. It's actually an accident which can happen to anyone. To miss that bile duct injury on table is also a mistake which can happen to any person, any surgeon. But then if we have diagnosed it, if we are mismanaging that, it is a negligence which should not happen. So as I said, the presentation could be an on-table detected injury. It could be a jaundice or a biliary leak. I'm going to keep myself on an on-table detected bile duct injury. The causes could be multifactorial, like an anatomical abnormality or inflamed gallbladder, which is causing obscure anatomy, pathological, as I said, or instrument failure. We are not going into detail of that, why it happens. The most common reason why it happens in most of the cases is visual perceptual illusion. You see what you want to see, you clip and you cut. That is the reason why we land up in bile duct injury. There are various classifications of bile duct injury. The most common or most important, which we all should know, is this Strasbourg classification, in which A to E classification is done. Type A is basically a leak from minor duct, which is still in continuity with the bile duct. Usually it is the cystic duct stump leak. Type B is something in which there is an aberrant duct, usually a right posterior sectoral duct, which is entering into common hepatic duct directly and is getting clipped here. These patients present very late or in late phenomena with jaundice. Type C is the same right sectoral duct which was cut, leading to bilioma or bile leak. Type D is something in which there is a lateral injury. So usually on table, what we see is either a type A, C, or D, in which we can be seeing some bile, or any one of these in which we have completely transected the bile duct. So this is the classification we all need to understand and keep in mind. And most of my talk is based on these consensus management, consistent statement for safe cholecystectomy, the prevention and bile duct injury. Many of the GI surgeons or senior laparoscopic surgeons are author in this paper, and I have taken up many of the matter from this article. So we'll go case by case. We'll see how in different scenarios we can land up while doing cholecystectomy and what to do. So this was a female patient, a patient with chronic cholecystitis. Her liver function test was absolutely normal, but intraoperatively there were dense adhesions. There was a frozen callot. As you can see, there was a colon loop which was densely stuck to the mid-body or fundus of gallbladder there, which was carefully separated by using both harmonic and blunt dissection. It was separated using a stapler there, and then the callot dissection was begun. As they can further notice, the callot was frozen, and the surgeon is trying to open up the callot strangle by using harmonic. And as the surgeon proceeds towards the anterior dissection on that side, surgeon sees a golden yellow bile which is coming out. So that was the point at which a surgeon stopped himself. Then he did a bit dissection. He called up, sending a video, and then this was the point where the surgeon stopped, considering that it could be something serious. So detection of bile duct injury on table. How to detect that we might have injured a bile duct on table? So there are 4 to 5 points on which we can think that bile duct might have got injured. First is the golden yellow bile. The bile in gallbladder is usually a dark colored bile. It is usually the bile which is stored for a long period of time. But once the bile duct injury happens, the bile which is coming up from hilum or porta is a golden yellow bile, as you can see here. Other aspect is a bile leak from porta. As you can see here, the gallbladder is getting separated and the bile is coming down from the porta, right? The third is if you have clipped something and cut, and if that duct which you have clipped, it has gone towards the duodenum. So in this aspect here, you can see it is a wide duct which the surgeon has clipped here. It was a very wide duct the surgeon has clipped. The another clip is being applied, and then it will cut. The surgeon will cut that tube. If the tube is getting cut and if the tube is getting retracted towards the duodenum, that means it was probably a CVD which was cut. As you can see, it will go down towards the duodenum. That has gone down, and then further dissection was started. And then the surgeon started noticing the golden yellow bile. And lastly, as we all know, we have to attain a critical view of safety. If we have not done that, we are seeing a tube, we are clipping, cutting, clipping, cutting. And if we are seeing a third tube in the callots, that means something is wrong. And that means bile duct injury is there, or we are just about to commit a bile duct injury. So here the bile duct injury is being already done, and the surgeon is still continuing his dissection there. And he will now, as you will see the video, the surgeon is going to cause further damage by injuring the right hepatic artery. So the bleeding has just started there. So 4 points which we have to remember: appearance of a golden yellow bile rather than a dark green color bile, a bile which is coming down from porta, retraction of the duct which we have clipped towards the duodenum, which is falling down towards the duodenum. And if we have not attained a critical view of safety, we are seeing a tube, clipping it, cutting it, clipping it, getting it. And the third tube which has come up into the gallbladder, we have already cut up a CBD, or we might be injuring some right duct or right posterior duct. So these are the pointers by which we can detect that, yes, the bile duct, or we might have done a bile duct injury on table. Now, why it is important to detect that on table? Why it is utmost important if we have committed or if we have gone on that pathway? Why? Because then we can prevent uncontrolled bile leak. If we have immediate expertise available nearby, then we can immediately repair that damage which we have done. If we don't have a expertise, if we are in a periphery center and if we have done a bile duct injury, then by understanding, yes, we might have committed a mistake, we can early refer the patient rather than keeping a patient, landing him in sepsis and then causing the referral, because delay in the diagnosis and referral will adversely affect the outcome of these patients. So detection is very much important. As soon as you detect, try to manage that if possible, if there is a expertise available, or refer, because then more delay, more would be the problem in managing these patients later. And what literature says, there is a varied incidence or varied literature that only sometimes it is only 10% of the surgeons who are really detecting it on table, or sometimes it is 90%. That much is the varied literature why how a detection can be done on table. Now, if it has happened, so we have seen, we have literally injured a bile duct, and we have also found out, we have actually diagnosed it. So if it's being done, the first and foremost thing is to call for help. If we are in a periphery or wherever center we are, just give a call to any of our friend, any of our senior, any of our junior, whosoever is next available, just give a call. For a surgeon, seeing a golden yellow bile, something goes back in the mind. There is a mental block. Then we try to dissect it out. We try to put a suction in. We try to use our Maryland forceps at the duct and all. These things cause further damage. Rather than doing all those things, just wait for a minute, see what is happening, give a call to any of your friends, just have another perspective in that field, what is going on, what might have gone wrong or anything like that. Call for any of the person's help. If there is any expertise available, think of repairing that immediately, if the expertise is available. If expertise is not available, put a wide bore drain and immediately refer the patient. As soon as the patient is extubated, tell the relatives properly and refer the patient to a higher center or a tertiary care center where the repair can be done. This is the protocol which has to be followed for a bile duct injury which a surgeon has detected on table. Now, why this is what the literature says, I'll just read it out if it's not clear to you. So in a suspected bile duct injury, conversion will not help if the facilities of primary repair are not available. By opening up the patient, we are going to cause more damage if we are not competent enough in repairing it. Bile duct may be worsened by further dissection, whether it is laparoscopically or by open. By more of dissection with the dissection tape or by using our Maryland in that area, we will be damaging it. We might be converting an E2 injury, that 2 centimeter stump, into a E3. We might be going up to the hilum. Attempt to cannulate the presumed cystic duct or cannulation the site of injury might also exacerbate the type of injury. Other important thing, a primary repair by an operating surgeon has a failure rate of 60 to 90%. So in an institute, it's very much simple to get another surgeon on call or get another surgeon on table immediately. Where I have worked, if a bile duct injury is being done by a surgeon, that surgeon used to go on left side, another surgeon used to come on right side, and he used to operate. That is what is the treatment, or that is what we should follow. We should call for help and we should ask a senior or an expert hepatobiliary surgeon to repair that, because there is a 60 to 90% chance of failure by a primary surgeon. And if the primary repair is unsatisfactory, further complications or further damage to the patient keep on happening. So unsatisfactory repair decreases the chances of successful subsequent repair. That is the reason why, if expertise is not available, simply put a drain and refer the patient. If expertise is available, call for help. So in a suspected bile duct injury, either call an expert surgeon or intraoperative assessment and management, or abandon the procedure, place the drain and refer the patient to a specialized center That is the treatment of choice. Now, what type of repair? If you have expertise which have come up to help you. So the injury, that repair depends on type of injury, the site of injury, as well as vascular injuries there or not. So if it's just a lateral injury, we can manage it with stent and suturing. If it is a complete transaction, we might need a hepaticojejunostomy. And if there is a vascular injury, we might not even attempt anything. We just keep a drain and come out. So if there is a complete transaction, like the case which we have seen, there was a complete transaction at hilum. So there are two options in this, again, end-to-end anastomosis or a Roux-en-Y hepaticojejunostomy. Hepaticojejunostomy versus end-to-end. I'm not a big fan of end-to-end anastomosis. We usually don't prefer that. We try to do a hepaticojejunostomy at hilum. The reason being, hepaticojejunostomy like this, by putting a stent or a T-tube, has a very high stricture rate, or the anastomosis of that bile duct tends to get strictured, and it might need, or it may need re-interventions in nearly 60 to 70% of the patients. The re-intervention in form of repeated stenting, PTBD, or sometimes even a resurgery. And why does that happen? If we look into anatomy, we'll understand that the bile duct is usually supplied by these 9 o'clock and 3 o'clock vessels, which arise on the lower aspect by this posterior superior pancreatic or duodenal artery, which goes up like this, or from a right hepatic artery, and the vessels come down. Now, this is the area where cystic duct joins into common hepatic duct. This is the area which is watershed area, where the vascularity of bile duct is minimum, and that is the area which is most commonly damaged in any of the bile duct injury. So if we do end-to-end anastomosis at this vascular shed area, the chances of letting up into leak or chances of having a ischemia at this point leading to stricture are very high. That is the reason why we prefer going up to the hilum, where the vascularity is very much good, and doing an anastomosis at this hilum is what is recommended, or is the treatment of choice. So as I said, if there is a loss of segment, there would be anastomotic tension in end-to-end anastomosis that would fail. If there is a clean-cut injury with no loss, end-to-end anastomosis can be done, but then the stricture rate is nearly 60 to 70%, which might need re-intervention. Stricture rate, if it is done at hilum in a most vascularized region, are only 5 to 8%. So that is something which is treatment of choice for these patients. So what we did in this patient, we opened up that patient. As you can see here, I'll show you one by one. This is the suction tip which is opening into the hilar plate. We have lowered down the hilar plate. This is the segment 4 retraction being done. Hilar plate was lowered. Right duct, we have put an infant feeding tube, and left duct we opened up by inserting our right angle forceps. We lower down the hilar plate, we open the left duct because it has got a good extra hepatic course. After doing that, you can see this is the hilum which we have opened up here. That is the left duct being opened up. Then hepaticojejunostomy by using very fine sutures. These are the parachuting sutures, pre-placed anterior bites which we have taken up. That is the lifted up bile duct. Then the posterior hepaticojejunostomy bites, and lastly a 2.5 to 3 centimeter of hepaticojejunostomy at hilum being done. That is the treatment of choice for a bile duct injury. We have to go on hilum. We have to lower the left hilar plate. We have to open up the left duct as much as possible. Take fine suture PDS 40 or 50 and pre-placed anterior bites, and then do a hepaticojejunostomy. Coming to the next case, this was a 68-year-old male patient, diabetes, hypertensive, chronic kidney disease. He had chronic cholecystitis, and on table we found this liver, which was probably a NASH-related fatty liver or a cirrhotic liver. And this patient had a chronic cholecystitis. On table, we thought that it is a Mirizi type picture, something like that. I'll show you why. So as the dissection was being done here, you can see there were dense adhesions, and as the duodenum was taken down, at this point, we started up lifting the gallbladder, and then we, this was the stone. This was the stone which was getting palpated here. So we thought that it is a stone which is causing a dense compression over the CBD. So infundibulum, considering that to be the infundibulum, we opened up that area with a bipolar. And as we opened up, we could remove a large stone from that. Sorry, okay. So as that opened up, that stone came out. So it was basically Mirizi's based on this. So once the stone was removed, further dissection was carried out. And when we try to go in and suture that defect, we found out that golden yellow bile is coming down just lateral to this defect which we had opened up. This is the infundibular area where the stone was removed, and we could see some golden yellow bile which was trickling down from the lateral aspect of that point. So probably it was a Mirizi in which there was a damage to the bile duct more than the segment, more than 1/3 of the segment. So what we did was we thought of firstly defining the anatomy, whether where is that bile duct. So as you can see, this is the golden yellow bile which is coming down laterally here. So there the hilum was going up. The instrument is being used there, and we can see the golden yellow bile which is coming down from the porta there. That golden yellow bile came down. So we kept a stent in this patient. So you can see we used an infant feeding tube as a stent. The stent was kept in the upper towards the porta. See, so we are putting a stent up there, and then the same stent was placed in the lower part of CBD. Now, why we thought of not opening up this patient? Because if you look at him, a diabetic hypertensive with such a cirrhotic liver, opening up the patient and then losing him in post-operative period just because we wanted to do an HJ is not right option for this. So here we have kept a stent in the CBD, and we did a choledocoplasty or repair of that or that stent like this. So that is how we have to think about outcomes of the patient and all, considering his age, all the other factors. We thought of going in for a repair of this CBD or a stent like this. This patient is on follow-up with us, and this patient is under repeated stenting. It was going to happen, but then at this old age, that is acceptable to him. Now, this is another one case. The laparoscopic cholecystectomy was done in a young female in a nearby district. This photo and the video is being given to me by one of my friend, Karthik. So intra-op, the surgeon who was operating, he detected some bile leak. So he did a WhatsApp video call with my friend, and what he showed that first I have ligated the duct and then the artery. This is what the 2 clips he has applied. And after the second clip, he started seeing the bile. That's what he had showed to my friend on a video call. So intra-op, a stent, a tube was placed there, and what Dr. Karthik thought was that it could be a right posterior sectoral duct which was injured. So the patient was advised, the doctor was advised to put a wide bore drain and refer immediately. This was something in the evening at around 3 or 4 o'clock. The drain was placed and the patient was referred to him. And the next day, the patient was opened up, and you can see here. So this was the cystic duct, this was right posterior sectoral duct, and this is the right posterior sectoral duct which was injured. A hepaticojejunostomy was done for this patient on the right posterior sectoral duct. I'll show you the anatomy better in this video. So that is the cystic duct being held in the Leahy's forceps there. Then the right posterior duct, and this Leahy's forceps will enter into the right posterior duct towards the porta. So that black thing which is there, that is the artery basically, and below that is the right posterior sectoral duct which got injured, and the Leahy's is entering into that. So this is the third scenario. As I said, if we have injured a bile duct, we can keep a drain and refer the patient immediately. Within 24 hours, if the patient is not in sepsis, we can go in and do a hepaticojejunostomy for this patient. As you can see, the infant feeding tube will be entering into that. So a hepaticojejunostomy was done within 24 hours for this patient. So timing of repair is also important. What is timing of repair? If it is, if an expert is available on table, immediate repair is the best thing which we can do. If it is not, then early repair within 24 hours is something which is accepted by most of the centers. If patient is not septic, if all the bile is draining out, even up to 7 days, people have done it. But then 24 hours is something which is defined as early repair. If the patient has come up after 3 to 4 days, and if the patient is in sepsis, just manage that sepsis, manage the uncontrolled drain or collections with pigtails, and go for delayed repair. That is the best option. What are the types of repair now? Just in a cut form. So if there is a bile leak, you have to examine if the duct which you are seeing is very small, less than 3 mm, sometimes duct Luxka we see, you can just clip it. If the duct is pretty big, then you have to do it a hepaticojejunostomy. It is usually the right posterior sectoral duct which gets damaged. If it is a common hepatic duct or a CBD injury, lateral one, then we can repair it over a stent or a T-tube or do a hepaticojejunostomy depending on the extent of injury or the patient. If it is a complete transaction, then a hepaticojejunostomy has been to be done. The most important aspect, no immediate repair if there is a vascular injury. If the surgeon has done a injury to a right hepatic artery, there was a bleeding, he was trying to control it, and that has led to bile duct injury, don't venture into immediate repair of these patients. These are going to invariably fail because of ischemia and anastomosis stricture. So to conclude, prevention, as we all know, is always better than cure. Diagnosing the injury on table is of utmost importance. Immediate repair or immediate referral to be decided based on the expertise available. A generous hepaticojejunostomy at hilum of 2.5 to 3 centimeter is the answer to most of the questions in bile duct injury. Thank you.
Thank you, Yogesh sir. Very well said that it is bile duct injury is the accident. It is not a stigma to the surgeon. So what is your opinion regarding the subtotal? How to prevent this injury, or how to, is there any
So,
role of subtotal cholecystectomy?
Subtotal is a treatment of choice in many of the scenarios. Rather than going down and down and then landing upon bile duct, it is always better to cut the gallbladder at infundibulum, remove the stones, clear it up, and apply a loop or suture it. Subtotal is the treatment of choice for many of the scenarios like empyema or Mirizi for that matter. It is an accepted procedure, and it is a very good procedure to bail out in terms of difficult gallbladders.
Second point is how should counsel the relatives?
Yeah, so my take on counseling the relatives would be that we have to be open and fair and clean to the relatives. We all know, it is in literature, that 40% of the times bile duct area has anomalous anomalies. The bile duct is not normal. The anatomy at bile duct is not normal in 100% of the patients. Nearly 30 to 40% have abnormal anatomy, and that abnormal anatomy leads to bile duct injury, or sometimes the disease itself leads to bile duct injury. We can show the relatives, we can ask them to come inside the OT, we can show them the video, this has happened, and the treatment, if we are in periphery center, the treatment is immediately referral. So if we are very much open and fair to the patient, telling him then the truth immediately as it has happened, the trust will be more, rather than asking them that there is some infection, you have to go, and then this has to be done, that has to be done, and then they come to know about it from some other sources. That is not good. We should be open and fair to the patients, telling them what the fact is. That would be the best option indeed.
Yogesh has put up very good videos on our Masi YouTube channel. So please see these videos related to bile duct injury.
So all these cases which I have shown, I have videos of all those on my YouTube channel. If you you just search Yogesh Bang and you can search those videos there.
Even the Masi channel.
Yeah, sorry, Masi channel.
See, in your protocol, since I also had presented this talk, I had read some literature. So there is one more thing I would like to add. Whether it's a thermal injury, non-thermal injury also makes a difference. If it's a cold cut injury and less than 1/3 of circumference of bile duct is damaged, you can do an end-to-end repair without a stent also. But if it's a thermal injury, it's better to go in for a HJ. That is what has been advised. Also, one important thing is experience of the surgeon. The best thing, if one has not done an HJ prior to that incident, it's best to put drain and refer. That's a take-home message.
Yes.
I would like to.
Yes.
Thank you.
Okay. Thank you.
Hello.
Yogesh, what is the definition of subtotal cholecystectomy?
Sir, definition of subtotal is something in which you are cutting up the gallbladder at infundibulum. You are not going up to the cystic duct. You are not trying to find out the cystic duct. You are just opening up the infundibulum. You are removing the stones, and you are applying a loop there, or you are suturing that end of gallbladder. That is the subtotal, in which nearly 80% of gallbladder is removed, 20 is still kept. We mentioned that in our notes that we have cut the infundibulum, we have applied a suture. There are two things in that also. There is a fenestrating type and a reconstituting type, in which you close up the stump of that gallbladder, leading to a small pouch there. You have to explain to the patient that there is 20-30% chance that he may develop stone in those stump again and might end up with another surgery over a period of time. So that is something which we have to tell them immediately after surgery, that we could not remove the complete gallbladder. We have removed 80% of it.
Okay.
Yogesh.
Yes, sir. Yes, sir.
Subtotal chole is done.
Yes, sir.
Right. Now, what advice should be given to the patient as far as the remaining part of the cystic duct is concerned?
Sir,
Whether
subtotal,
he should be advised redo surgery or not?
No, sir. not
Suppose a
all
patient does not develop any problem.
Not all patients need redo surgery. We just have to tell the patient that you still have 20% of gallbladder which is left. There is 25-30% chance you may develop stone in that. That
Right.
stone might cause problem. If that causes problem, then only he
Then
needs
only.
surgery. Then only. Nearly 60-70 won't even have issues over a lifetime. Subtotal.
What about the incidence of malignancy in remaining part?
Sir, that is, I don't know how much study is being done on that. If there are stones in that, again, that might be the reason why they may develop malignancy. But then again, just because he might develop a malignancy, so going in after 6 months to remove that pouch, which is going to be a difficult gallbladder, I don't think that is something.
So
which would
unless
make-
residual stone or patient is symptomatic,
Yes. Yes.
then he should.
Yes. Yes.
Thank you.
Sir, in the open surgery, we used to put the T-tube initially.
Yes, sir.
In partial injuries, we used to put the T-tube and drainage. But what happens here, if there is no stents are available and there is a partial injury, how are you going to delete?
Sir, simple infant feeding tube is available round the clock in each and every OT. That can be used as a stent, or you can even use the suction catheter as a stent. I prefer infant feeding tube because I get surety that infant feeding tube has gone into the duodenum. By injecting saline through that, I can see the duodenum getting filled up, or the saline is not getting refluxed back into the bile duct. That is where I confirm myself that yes, my infant feeding tube has gone into the duodenum, and then I cut it. So infant feeding tube is the simple stent which we can use if stent is not available or if T-tube is not available.
Dr. Yogesh,
Yes, sir.
what is the role of ERCP stenting in CBD injury?
Sir, ERCPs and ERCP is definitely one of the treatment of choice if we know that it's a cystic duct stump leak or if it's a lateral injury. But then we won't be knowing that on table first, because it is something which will be detected on post-op day 1 when we see bile in the drain. That is altogether a different topic to be discussed. That's why I have not included that. So if we have a bile in a drain, patient is absolutely asymptomatic, normal. In such patient, we can wait and watch. Depending on the amount of bile, if it is just 100-200 ml, it could be just a cystic duct stump blowout. If it is very high bile, then you need to get an MRCP that will show us what is the injury we have done, or whether it's just a cystic duct blowout. If it's a cystic duct stump blowout, ERCP is the simplest way we can treat that.
The small rent is detected on the table.
Yes, sir.
And if a small rent in the CBD is detected,
yes,
intraoperatively.
Yes, sir.
And we sutured it.
Yeah.
Is there any role for the ERCP stenting? Does
Sir,
it help?
suturing, I would rather put a wide bore drain rather than suturing that CBD if a small rent is there, because it is a non-dilated CBD. If we try to suture it with a 3-0 or 4-0, it might cause further damage or might lead to a stricture in the long run. So keeping a 32 French drain there, asking a patient to get an ERCP in post-op period would be a simpler or a better option rather than causing injury to the bile duct. Because a non-dilated duct, if we try to suture it laparoscopically also, it might cause more damage. We might be closing up nearly 50% of lumen just with our suture.
Yogesh, nice presentation.
Thank you.
Rather good tips for maybe everyone. May I add one tip to detect CBD injury on table? You said golden bile. In panic situation, nobody would think of seeing golden bile because many times get mixed with blood. So I will always think of the gallbladder which is not getting decompressed even after seeing bile.
Yeah.
Because that possibly, if we are seeing another collection coming and gallbladder is not being decompressed, that means I have to be watchful that I have injured something else.
Understood.
Okay. Second thing, what I saw in that large stone with emerysis, would there be a good option to do a fundus first gallbladder identify, because you directly ventured on anterior dissection?
Yes, sir. Yes. Sir.
And that's
but
how
if you, yeah, sir. But in that video, I'll tell you the liver was already coming down to the gallbladder, and gallbladder was deeply tethered in. It was more of a cirrhotic gallbladder. If we would have gone fundus first, we might have had more of bleeding towards the liver surface, from the liver surface. That was also one of the issues. So on table, from below down, below up.
Thank you.
Yeah.
Just one more thing regarding the last question.
Yeah.
What do you feel is the role of IOC, intraoperative cholangiogram, in such patients?
Intraoperative cholangiogram is a very difficult procedure to be done. To be frank, I'll tell you why. There are 2-3 things in intraoperative cholangiogram. You have to be having a good occlusion cholangiogram to see what has happened, you need to have a good, you need to have that armamentarium, the OT table, C-arm compatible, C-arm, then the surgeon himself should be able to put a cannulation or they're holding that with a proper clip and then getting it done. Getting it done is not a problem. Reading that cholangiogram is also one of the things we should be very much well accustomed with. So, very well said and done. It's not something which we routinely do. So we are not very well versed in reading the cholangiogram on table, doing it on table. Of course, it has helped after doing a bile duct injury. IOC helps to detect the type of injury which we have done, but IOC doesn't prevent injury as such.
And one more thing, I would like to differ with respect to the last scenario,
Yeah.
because a similar incident happened with me. I felt that I had injured the right hepatic duct. I
Yeah.
could do an intraoperative cholangiogram and I could see that the injury was on the common hepatic duct.
Okay.
It was a non-dilated system.
Yeah.
I could manage it with a simple sutures. 2 simple sutures can be taken. It all depends upon what
In
the
an
scenario is
expert
there.
hand, it is okay. Abhishek, definitely okay. But then my preference is I would keep because I'm working in an institute where ERCP is readily available. I can put the patient for ERCP next day itself. So I would prefer putting a wide bore drain, informing my medical GE that tomorrow morning you have to do an ERCP for this patient. So that is why if a small rent, which will cause more damage while suturing, I'd prefer putting a stent to that patient in post-op period. My personal take on that.
Yogesh sir.
Yes.
Yogesh sir, if there is a small lateral injury, like what should be the timing of ERCP? Like, you
You
know,
can
on
do it
paper-
next day. You
No,
can
that's
do it
what-
next day.
Yeah, true. But you know, intraoperatively that there is some bile injury that has occurred
Yeah.
either to the CHD or to the CBD.
Yes.
Right. So, and the drain shows only 50 cc of bile.
So there are two school of thoughts on that. If the patient is absolutely stable, 50 ml bile, you can just wait and watch, counsel the patient that this will go off. If you are working in an institute where ERCP is easily accessible, even for 20 ml bile, we will put a stent. Like that's what we used to do in Asian. We used to see 70 ml bile, but then bile, we used to immediately stent rather than keeping that drain there with the bile. If the drain gets blocked, again, we have an issue. Then again, there will be collection. Sometimes that also happens, drain get blocked. We are very happy that the drain has dried up, but the patient comes up after 3 to 4 days with a fever and collection. That can also happen. So if facility is available, if it is easily available, best is to stent.
When can the ERCP help to a surgeon for a lateral bile duct injury?
Yeah, every time it can help it every time for
Just
each and every lateral
for the
injury.
decompression
No,
part,
no,
yes.
no, 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 no. You just stent it so that the bile will not come into the drain. The fistula will heal. We have to just heal the fistula as soon as possible. And the lateral injury, probably by putting an early stent, might not lead into a stricture. Might not over a period of time lead into a stricture.
Yogesh, excellent presentation as usual. Your role starts after the injuring the CBD. Actually, one point which I wanted to add on prevention of CBD injury, especially in bad gallbladders, which one tends to forget, is putting in an additional port in left hypochondrium. It helps a lot. Just press the duodenum.
Traction of duodenum.
Yeah, it helps a lot because there are dense adhesions around, and it definitely helps. So that one point which one should keep in mind.
Yes.
Thank you, Yogesh sir.
Do you sincerely feel that routine use of ICG will avoid some bile duct injuries?
Sir, I would ask Rahate sir to answer that because I'm not using ICG routinely. I definitely ask Rahate sir to answer that because I have seen him routinely using it.
Can I?
Yes.
Yes, definitely. ICG will prevent the injury. In many cases, it will not prevent 100%, but you know, in difficult gallbladder, you know the position, particularly the contrast mode.
Yes.
Not the green one.
Yeah.
The contrast will illuminate the CBD completely, and it will even show the confluence of the cystic duct and the CBD, the hepatic duct. So now almost since last 3 years, I am doing in every case ICG.
Yes. Thank you.
Thank you,
very
Yogesh
much.
sir.
Thank you.
May I request our chairpersons, Dr. Bobde sir and Dr. Dhoran sir, to felicitate our speaker. I request Dr. Bharat Shete sir to please felicitate our chairpersons. I welcome Dr. Samir Rege sir as the next speaker. To chair this session, I would invite Dr. Mulmule sir and Dr. Girish Jatkar sir. Dr. Samir Rege sir will be talking upon role of open surgery in the era of laparoscopic surgery. I request Dr. Mulmule sir to please introduce our speaker.
Dr. Samir Rege is Professor of Surgery at KEM, presently Secretary of MASI, and I don't feel that a dynamic laparoscopic surgeon as well as open surgeon, he needs any further introduction. We too are the chairmen who are from the era of open surgery. That time, diagnostic peritoneoscopy in the era of open surgery was the topic of discussion. Now the things are reversed. I request Dr. Samir Rege to enlighten us more about indications of open surgery in era of laparoscopic surgery. Thank you.
At the outset, I would like to thank MASI President Dr. Ganeriwal, ASA President Dr. Ingole Madam, Secretary Dr. Amit Basme to invite me at this August gathering. A very difficult topic to me. My laptop also started hang just now, just looking at this open surgery. But let me tell you, I am going to show you all pitfalls what laparoscopic surgeon could encounter.
Small comment. Laparoscopic cholecystectomy was the first laparoscopic surgery which was introduced to us. And at that time, it was always told, said by the seniors, that for doing laparoscopic cholecystectomy, you must have an experience of at least 50 open cholecystectomies, then only venture for lap chole. Now the conditions are getting reversed. Younger surgeons are directly doing lap chole, and if there are any complications, they are trying to call the oldies.
The present scenario tells you about the pitfalls of depending too much on technology. When it is going to go away, we don't know. When it's going to come back, we don't know.
मोठे थे वीडियो देख नहीं सकते I'll just come back again because there's some issue with my
तो Apple है का? Apple है?
HP है ठीक है प्लीज वेट ठीक है ऑडियो नको काहीतरी गडबड आहे पूर्ण थांबलं लोकांना
थांबू ना 5 मिनिटं काय नाही होत. आता आम्ही उठत नाही खुर्चीवरनं.
ठीक आहे 1-2 मिनिटं द्या
This is exactly the point with our technology.
I'm going to come.
So times immemorial, surgery was dogged with only 2 questions. One, can I do it? And second, which was perhaps much more difficult to answer and which one had to ask to oneself, should I do it? Can I do it is very easy. Not very easy technically, but it is easy.
you acquire the expertise, but then should I do it is where your conscience comes in, your capabilities come in, your technology comes in. Should I use that? That is the pertinent questions all along during the history of surgery. To my mind, 2 hands and 1 mind is the indispensable part of all surgeries. And I sincerely hope that it remains that way in the near future also. Because that is, we are seeing technology almost overtaking us. And we have not even thought about what artificial intelligence can do to us as surgeons. It is already snapping out of heels. At present, we only have the cognitive functions with us. Everything else is practically been taken over by technology. So this is you can't resist change. Change has to be there. But then change always comes at a cost. And then you have to determine what is the cost going to be in terms of money, in terms of efforts, in terms of expertise, in terms of training. There are a lot of issues in newer technologies.
सर लॅपटॉप एकदा बंद करून टाका आणि परत चालू करा. फक्त खडू फळाच घ्यावं लागते. भाषण
equipment based problems. And that's where any laparoscopic surgery has to understand, if I don't understand my subordinate or my senior, so always in whatever era will remain, let it be laparoscopic or maybe robotic, finally seniors would be always there to guide you. So it was always a saying with my teachers, as Dr. Bapat, Dr. Mathur, big surgeons would make big incisions. However, in India, laparoscopy came with gynecologists from 1977. It was more of diagnostic. However, in 1990, Dr. Udvadia did his first laparoscopic cholecystectomy in India and became an era of therapeutic laparoscopy. Initially, it was labeled minimal invasive, but however, now the terminology has changed. Mindwell terminology has changed to minimal access. Now, he was instrumental in motivating many surgeons to MS. Now, in those era, it used to be of longer durations. We had primitive camera systems, halogen light source, instruments were non-autoclavable. Surgeon as well as the camera person, the entire team were novice with all laparoscopic procedures. And we didn't have any specialized energy sources. However, Dr. Palanivelu, he performed various advanced laparoscopic procedures for the first time, maybe in world also. Emphasized not only laparoscopic surgery, but he used more of conventional steps similar to us conventional surgery in laparoscopic surgery. Proved the importance of ergonomic triangulation, and he performed most of surgeries with knotting and suturing. So made an impact to the world that knotting and suturing are more important if you are trying to pursue any advanced procedure. He also showed that you can have a good oncology clearance as equivalent as conventional surgeries. Now, advantage of minimal access surgery is smaller incisions, so cosmesis, you have good magnification, you can have camera very near the target organ. The ports what are placed are muscle splitting, so you have less pain. So you have lesser infections and lesser hernias if closed properly. You have less tissue handling, and hence patients can return to work early. The entire team can understand the procedure because they can see on a monitor, and it's a good teaching module to teach your juniors and your subordinates. So in this, with lot many advantages of laparoscopic surgery, with people are performing from basic gallbladders, diagnostic lab to even laparoscopic nipples, are we still required to learn open surgery in this era? First, most primary intent of any surgeon should be first do no harm. And that's what we learn. So I would tend to get some disadvantage of laparoscopy, not real disadvantage, but initially we had 2D vision. Maybe a few people like Dr. Rahate can afford 3D systems. You require to have good hand-eye coordination. Most important, what you lose is tactile sensation, what an open surgeon would always miss. And you have very restricted field of vision. You've got a camera surgeon who is supposed to be in tandem with you. Abdominal wall acts as a fulcrum, so your port position are of primary importance. The assistants may not be able to help you until unless you deploy the ports properly. And also you give patient positioning, because until unless ports are not proper and the patient is not positioned, you will not have good retraction. At times for a specialized, for advanced procedure requires specialized resources. This is an equipment based surgery. So you just now saw my laptop, which was functioning up till now for 3 hours, didn't work. So even at last moment, either a light source may crash, maybe insufflator may not work, or an energy source may just give way. You require general anesthesia for many of the procedures, though many anesthetists have improvised themselves to even regional anesthesia. The cost of equipment what available right now may not be affordable to most of the surgeons. And these surgeries can lead to remote injuries. Mind well, this field of vision is restricted. So either while taking out or in of the incision, or maybe some diathermy injuries, coupling injuries, which can be seen in these patients. However, nowadays not there, but previously we always had a good longer learning curve. So most of the people always think that it should be better to open and see than to wait and what would happen and see. Open surgery, you have good 3D vision, you have tactile sensation, so you understand what tissue you are handling, whether it's a blood vessel or fibrotic strand, you try and understand. The movement what around works around the abdominal wall as a fulcrum. Here you have wrist movements as well as finger movements. So a good 360 degrees of movement which can help you in dissection, retraction, and even same time hemostasis with pressure. And you have a good large working field. So what would you think of if you're doing laparoscopic surgery when you try and open surgery primarily or try and convert? It would depend on patient factors, the disease, surgeon factors, and maybe logistics. When you talk about patient may be unfit for carboperitoneum because of either severe cardiorespiratory compromise, coagulation abnormalities, compromised cardiac function, and patients with kyphoscoliosis, ankylosing spondylitis who may be difficult to have good amount of abdominal cavity even after having a good access, or may have the difficult time because of intubations or because of fixed flexion deformities at pelvis. You may not have access to even abdomen through your ports. Patients may have economic constraints, which I will leave it too long because now most of our governments set up also go performing laparoscopic surgeries. But then yes, we have restricted energy sources at times and staplers. So maybe a little fallback that we will not be doing all advanced surgeries in public sector. And yes, if patients are in emergency cases where patients may not be optimally optimized so that they are fit for any laparoscopic intervention. When we talk about disease, it's preoperative when we think that they are very bulky tumors for malignant patients. And if these patients have associated comorbidity as cirrhosis, where they can have collaterals, especially in, as what Dr. Yogesh showed, he did not venture, even with that expertise, did not venture by doing a fundus first. That's how you can have a preoperative planning. At times, you can have intraoperative problems of abnormal anatomy. At times, you can encounter torrential bleeding. And yes, there can be adjunct injuries, even a coupling injuries, which can be remote, but may not get detected at times. And yes, trauma patient, as what Dr. Dubashi told, these are patients where you may have to act quickly at times. And if your expertise and the setup may not permit you, you may have to convert or do it open primarily. So I would rather say, looking at my scars now, it reminds me that life is short and I was just lucky to come out of the experience alive. So most important, patient be safe. Now I would try and show you some videos. This is a first port injury where optical port was used and it had directly gone into the bowel. Mind well, patient was having a primary pneumoperitoneum with Palmer's extended. So you would not understand a bowel which may be adherent from the peritoneal side at what level. Even the video is created Dr. Ashwin Thangvelu, where you can see the second trocar with a excess thirst, and he has gone through and through the bowel. So an open surgeon would always fear why these things I'm going to see if I can do a simple surgery in a shorter time, much easier. Now, when we talk about energy sources, this is a video where you have harmonic trying to do adenolysis, the small ball stuck onto the parietes. This has happened in my hands long back, where I was little careless. I'm seeing some bowel on that side and I open the small intestine. So it is extremely important. You may have good high energy sources or may have even a cold scissors. You can see this adherent bowel where we try and go. And while doing with even a cold scissors, if you are having only 2D vision, you do not understand what is going on the other side of the vision. And at times, because of traction, you have a bowel injury. And a third, where you have a monopolar diathermy, this is for doing a gynecological case. The restricted vision tries to permit you to see only what the operating part is being done. Mind well, can you see the bowel below, the small bowel which is done white? So it's a transmitted coupling injury which has gone there. So important things you may have if you're doing such advanced surgeries or even basic laparoscopic surgeries, you may encounter any kind of these. So when you're talking about any procedures, I would try and divide hernias. When you have giant inguinal hernias, if you try and attempt laparoscopic, may not be very easy to reduce. One, because of chronicity, the amount of contents, And most of the times, the half of the abdomen is outside, so they may cause abdominal compartment syndrome. Second, strangulated hernias, and if you are trying to perform a hernia laparoscopically, you may have to get well versed with the anatomy, what an open surgeon may not usually get acquainted with. When you talk about the ventral hernias, loss of domain, recurrent hernias, and patients who requiring paniculectomies may be subjected to open surgeries, and that's why you require to choose the surgical intervention. Here is a patient with such the complications in open ventral hernias are not known, where you tried to pass a suture passer and it had accidentally gone through a tributary or the main inferior epigastric. So some injuries you require to get cautioned that you can encounter at any time. When you talk about solid organs, the liver, when you talk about liver surgeries, they can be bulky tumors. You have to get acquainted with laparoscopic anatomy. You require multiple different energy sources, as maybe the ultracision and ligature may be complementary and not replaceable to each other. When you talk about chronic pancreas, if you are trying to do a lateral pancreatogenostomy or you have parenchymal calcifications, may not be very easy to do a phrase or Bigger's procedure laparoscopic, because you may have to really core out the pancreas. Talking about malignant tumors, if there are vascular tumors infiltrating supramesenteric vein, replacement surgeries doing laparoscopic would require a major skill. Or maybe the tumors with uncinate process and may requiring complex anastomosis. I'm just trying to show you a video. This was a patient with for fundoplication, trying to get the fundus away from the spleen, and you can visualize what happens next. So if you're in open surgery, maybe small things are much easier to try and tackle. It is not that laparoscopic surgery is bad, but at times you require to have proper angles, proper instrumentation, a good team to understand what would happen. So you can visualize it was the upper polar vessel of the spleen. The upper pole has already got discolored, and that's where you have to get caution for. Colorectal surgeries, it involves multi-quadrant. So port placements are primum, your vision has to be primum, and you require to have a good assistant who would understand. Stapling, you should get well versed, and their own complicating or misfiring a stapler. And yes, at times the specimen retrieval, finally you will have to do or may have to have a small cut. When you're trying to handle large tumors, you can have a lot of problems because of the spillage of tumors because of excessive traction, or can have perforation, which can have altered prognosis. When you talk about thoracoscopy, it's usually preferable for malignant cases. Benign, yes, decortication we do, but at times may not achieve good clearance at all angles because you have a hard rib cage where your ports are placed in certain points, and it may not be very easy to try. And so you may require to have assisted, or may you have to convert at times because of thick pleural adhesions. We come to commoner problems: gallbladder, acute gangrenous cholecystitis, frozen callots, associated cirrhosis, Mirizi syndrome. May the patients intraoperatively you can have hepatic artery, portal vein, or gallbladder bleeding, and at times biliary injury requiring biliary reconstruction. This is a simple gallbladder where we are trying to dissect the gallbladder. You can see a good amount of traction, counter traction mechanism, and one small mistake, you try and venture into the peritoneum of the gallbladder fossa and you open a sinusoid. So these injuries at times, these are not only basic for laparoscopy, but at times may not be very easy to handle. You may require either a good bipolar diathermy to try and control. However, if it's a sinusoid, it may not be very easy. You may require to put a suture there. Second video is of lateral injury. You have the surgeon has seen that you can have a good callots. He has already clipped the artery. Then tries to go and he identifies the entire artery. Just go ahead here. Clips, identifies it and clips it, and then he finds the golden yellow bile. So these are lateral injuries which are later documented. So important thing, the approach may not be it's not that only laparoscopy will have problems, but at times if you are not very well versed with what problems you are going to encounter, these can be faced by any of the surgeons. In laparoscopy in appendicular mass, appendicular perforations, and if you encounter Meckel's diverticulum, if you are not prepared or if you're skilled, the port placements may cause problems and at times may lead to convergence. When you talk about surgeon's parameters, you require patience. That is most important parameter I would think in any laparoscopic surgeon would require. He would get trained in hand-eye coordination. He should have knowledge of all instrumentation and should know troubleshooting. Many times these advanced surgery may go for a long time. So he should know, he may get failure, he may have fatigue of upper torso. He should have good skill where he can master the act of suturing and knotting. And when we are using carboperitoneum, he should always have an understanding of what physiological changes the patient would undergo because of this, and always have the angled port properly towards the target organs. Lastly, I would label all convergence maybe to either equipment failure. So hence, many times most of the corporate sector would have an access or a accessory kept which can be used as a standby. And there would be always limitations of laparoscopic surgery when it comes to access either in retroperitoneum because it may not be very clear, or if the patient position is not proper. Just to add, few surgeries there may be impossible by doing laparoscopic surgery. From surgical point of view, I think circumcision. So I would give a take-home message that first, it should be patient safety. It is not what procedure you do. You do the procedure as per what your skills and what your setup is. Choose the procedure and the approach which suits best for you and your patient, and not fit the same procedure to all patients. If you are trying to do a new procedure, have a good proper training and a mentor there before venturing into the complex cases. So a successful surgeon should be a man when asked to name 3 best surgeons in the world would have difficulty in deciding the other 2. That's what you should aim for. Thank you.
Excellent presentation, Dr. Samir. I think 10 years down the line, you'll be presenting similarly laparoscopic surgery in the era of robotic surgery. Any questions, please?
I may graduate to laparoscopic surgery, robotic surgery.
Right. Any questions from the audience?
Samir, I just want to highlight the problems faced by the surgeons, the laparoscopic surgeons. Is shoulder, they go, the neck, the radiation to the eyes. These are all professional hazard, and we are using the hands also, and we usually stand on one leg.
Knee
so
problems.
the knee and the ankle also goes. So that is a professional hazard for the
So
laparoscopic.
basically, if initially when it started, the monitor used to be placed little lower. Then concept came, it should be higher so that you have an extension at the neck. Now the concept is that monitor should be at your eye level. That is most important. Secondly, it should be at least 1.5 to 2 meters away from where you are standing, depending on the size of the monitor. I'm talking about a regular monitor. Preferably, you should have a good illumination in the theater. And if you're talking about knees, try and rotate pedals, or if possible, or if you can take on the fingers. So what instrument you use, you try and be acquainted with it, because if as a freelancer surgeon, they may try and go in different places. So you get different angle instruments, and that's where your wrist and finger movements change. So these are most important. So this is the same question I asked Dr. Palanivelu, because at age of 70 plus, he's still much fit than what I am. So he told me one thing. He had a surgery for shoulder, which he has already undergone, which I did not know. But if you see him fit, he works out from 4 o'clock to 5 o'clock daily. One is neck and shoulder exercise. So it's a request for all surgeons, and especially laparoscopic surgeons, do shoulder girdle exercises, because they would be required if you are trying to do multiple surgery on the same day. or major surgeries on same day?
Thank you, sir.
What about mind?
That mind has to be relaxed.
In the evening, we will
Yeah.
meet.
May I request Abhijit Deshmukh sir to felicitate our chairpersons also. Sir. For the next session, I invite Dr. Sunil Mapari sir and Dr. Ashish Dagwar sir to chair the session. Our next speaker is Dr. Mukund Thakur sir. He'll be talking about challenges in AWR. I request Dr. Dagwar sir to introduce our speaker.
Good morning, everyone. Dr. Mukund Thakur sir is a well-known surgeon, eminent surgeon, laparoscopic and advanced laparoscopic surgeon in Vidarbha. He's from Nagpur. He's director of Viveka Hospital, Nagpur. He has many presentations and publications in his name in ASACON, ASACON, MESICON, in IMA conferences. Then he has been faculty to many conferences in this conference also. I will not name all the conferences. He is regularly conducting teaching workshops at his center in basic laparoscopy, in advanced laparoscopy, in thoracoscopic laparoscopy and laparoscopic oncosurgery. He has 2 original research in his name. Then his field of interest are advanced laparoscopy, lap oncosurgery, lap hernia surgery, bariatric surgery, and thoracoscopic surgery. Over to you, sir.
Thank you, Ashish, for that kind introduction. At the outset, I congratulate the Association of Surgeons of Amravati for conducting this conference at such a wonderful venue. Challenges in AWR, abdominal wall reconstruction, has been a topic of interest. It has generated a lot of enthusiasm, interest because of number of conferences being held in last few years. Earlier, we have been doing the abdominal wall hernia repairs, but the concept of abdominal wall repairs has definitely changed in last few years. So, what is more important in this era of AWR surgeries is experience of the surgeon of doing abdominal wall repairs. Patients who have undergone multiple procedures, who have recurrences of hernias, have definite expectations from the surgeon, and nobody would like to subject himself or herself to a procedure which he has undergone earlier. Now, whether these surgeries can be offered to all the patients of abdominal wall hernias, we should do a proper assessment whether these procedures are safe or we would give a worse disease than what he is suffering right now. There are certain on-table decisions many times required to be taken during performance of these surgeries. And the results might vary from a person who is not experienced and person who has an experience of more than 10 to 15 of these surgeries. So there should be an alternative plan for the challenging situations also. So what are we going to discuss? What is the abdominal wall reconstruction? What is a complex hernia? What is the nature of this disease? What are the risk factors for morbidity and or recurrence? What is a complex hernia? The hernia which is located maybe in the midline but with a large size or placed laterally in the incisions taken at odd places like post renal transplant surgery or after cesarean sections. Whether there is contamination, if there is contamination of the tissues, ulceration of the skin overlying, what is the condition of soft tissue or skin overlying the hernias, then other comorbidities of the patients and different other clinical scenarios. I'll just briefly mention about the staging of hernias. Hernia width and wound class can be used to stratify patients into stages with increasing risk of wound morbidity and recurrence. So stage 1 is less than 10 centimeters and a clean skin. So these are the patients who can be managed by minimal access approach or laparoscopic approach. Stage 2 is 10 to 20 centimeters, clean or less than 10 centimeters contaminated wounds. And stage 3 is more than 10 centimeters or with contaminated skin or more than 20 centimeters. So stage 2 and 3 are should be preferably treated with open surgeries. Since I have very limited experience of laparoscopic AWR surgeries, I'll speak more about the open surgeries. Now take this scenario with a patient having such a huge hernia and the ulcerated skin overlying with a large panniculus with hanging skin in the lower abdomen. Now, these patients do need some kind of optimization before they can be taken for surgery. So what was done for this patient? She was admitted and given antibiotics for 5 days because she had an infected wound on the hernial sac itself. Spirometry exercises, we paid attention to her nutrition, built up her albumin levels. And then after we took her for surgery, excised all the sac and the skin overlying having lot of ulcerations. Then we entered the tar plane. This is the common site these days, creating a tar plane below the muscles, and then used one inlay mesh and one onlay mesh. So one has to be very prepared for these size of meshes. Generally in AWR, you require very large 30 by 30 size meshes, and one should have enough stock of it before you take up such a patient. So that's the final result. We see one more patient. This patient had loss of domain, was carrying hernia for last more than 15 or 16 years probably. And this was a recurrent hernia after repair. So she was not really prepared for the surgery. But the very fact that as soon as she used to get up, the whole hernia used to hang down, and that was making her difficult to even walk for a few steps. So in this case, we did her CT scan, And now you can notice the CT scan shows a very large defect in the lower abdomen. Now here you can see there is a huge gap. This is the abdominal, these are the abdominal wall muscles here, and almost all retracted muscles on the opposite side, huge gap more than 10 centimeters. So we had to optimize this patient by giving Botox injection in the bellies of abdominal wall muscles and doing a preoperative progressive pneumoperitoneum. So we used Botox injection 300 units, 150 units on either side, given USG guided at 3 spots on both muscle bellies of the abdomen. And the action took about 3 weeks. Peak effect lasts for about 1.5 months. And then we did a preoperative progressive pneumoperitoneum as well in this patient. Finally, we took her up after 3 weeks for surgery. The dissection involved excising the complete sac and the previous mesh as well. As you can see here, we could do that, but even after giving her Botox and doing a progressive pneumoperitoneum, this was the defect which was difficult to approximate, and because of huge content of the sac which was reposited back. So finally we had to be satisfied with one inlay mesh that was a dual barred mesh and one onlay mesh. So these are some of the decisions one has to take on the table, but it is all in the interest of the patient. So final closure was like this. This is one more patient of huge abdominal wall hernia with loss of domain. Again, this patient was prepared with PPP, that is progressive pneumoperitoneum, and Botox injections, and was kept, was stabilized for 3 weeks, given a lot of spirometry exercises. And as you can see, even after doing, we could achieve a very good closure, but because of a lot of dissection and undermining of the skin, there was some amount of skin necrosis which recovered. So the term comes here very commonly used as Tanaka's index. So what is Tanaka's index? Based on the CT scan of abdomen, one can calculate the abdominal sac volume and the hernial sac volume. So the ratio of hernia sac volume and abdominal sac volume, if it is more than or equal to 25%, it fits into the category of loss of domain. What are the treatment options in cases of large complex hernias? A primary repair, a mesh repair with rib stoppas, mesh placement, component separation, either anterior or posterior component separation, local flaps with the help of plastic surgeons, tissue transfer, pedicle flaps of back muscles, or human acellular dermis, that is allodome. So why AWR is necessary? If you see in all these patients, the muscles of abdomen were all pulled away. So to restore the integrity of the abdominal wall, which protects the internal organs, supports the spine. The function of abdominal wall muscles is not only protection of the organs, but it also helps to support the spine. It helps in maintaining the upright posture. It helps in urination, coughing, defecation. And there is one study which says that probably intact abdominal wall can give rise to early satiety, so that the patients do not overeat. In addition, it provides dynamic muscle support and prevents evisceration of the abdominal organs. I tried to search for exact definition of abdominal wall reconstruction. There are different versions which I came across. One says hernia repairs that try to recreate abdominal wall and restore function and structure of the abdomen. Other definitions says restoration of midline by facial closure and reinforcement of the midline by mesh prosthesis. So common thing amongst all definitions was defect size more than 10 centimeter will require some kind of abdominal wall reconstruction. And the linea alba has to be restored and muscles re-approximated whenever possible. Whenever possible, because sometimes there is loss of muscles because of repeated surgeries, and then you have to do some kind of bridging with the help of meshes. So what are the approaches for abdominal wall reconstruction? It could be laparoscopic, robotic, or open. Principles of abdominal wall reconstruction surgery. The patient selection and optimization is very, very important. As we come, we'll see it in the running course of this lecture. Durable and dynamic reconstruction of the muscular facial layer. Careful attention to skin and soft tissues. Meticulous post-operative management. This is a teamwork and multi-speciality involvement has to be there. Your intensivists should know or should see these patients pre-operatively, because they would definitely require some kind of support in the post-operative period. Open abdominal wall reconstruction. What are the approaches? Either pre-peritoneal or retrorectus approach with anterior component separation. Endoscopic component separation plus rib stopa retrorectus mesh placement. Anterior component separation with onlay mesh placement. This approach, ACS with onlay mesh placement, is generally avoided because it involves a lot of undermining of the skin, and skin issues could be there in the post-operative period. Pre-peritoneal or retrorectus approach with transverse abdominis release. This is a very commonly done procedure nowadays, because this is one plane, the tar plane as we commonly call, holds the mesh very nicely, and there are less chances of patient landing due to mesh complications if the meshes are placed in this plane. The healing is very good. So there could be challenges in the pre-operative period. Intraoperatively, there are definite challenges while dissecting these planes. And post-operatively, once the patient is out of anesthesia, you need to handle these patients with the help of intensivist. So what are the pre-operative issues which can affect the healing as well as the induction and maintenance of anesthesia in these patients? Is obesity, smoking, alcohol, hypertension, diabetes, anemia, age-related issues, nutritional status, whether the patient has undergone kidney transplant, not, patient of chronic or chronic liver disease, infected skin, use of steroids. All these pre-operative issues should be optimized before you cannot make them normal, but you can optimize these patients. So there is a term called as prehabilitation. So prehabilitation is selection of patient and optimization of risk factors. So correctable comorbidities, that is use of tobacco, should be stopped at least 4 weeks prior to surgery. You should correct malnutrition. Obesity is difficult to correct in 1 month, but then yes, you can make an attempt so that patient loses some amount of weight before he is on the table. Then correction of diabetes. Selection of correct procedure. The goal of this is to avoid any kind of recurrence, because once there is recurrence, this patient is going to come back to you only. No other surgeon would accept this patient. Primary musculoskeletal closure followed by mesh reinforcement is the principle of this surgery. So repair good fascia to good fascia, debride any poor quality, non-viable, attenuated, scarred, damaged tissues. If tension-free closure is not possible, as you could see in the earlier patients, try component separation, unilateral or bilateral, either bilateral tar release or unilateral tar release. Never close under tension, because that can land the patients in abdominal compartment syndrome, or it can cause the dehiscence of posterior wall, which you have repaired, and lead to postoperative complications. Inability to close, if there is difficulty in closure of these defects, then bridge it with mesh or leave it open for closure at a later date. That is a simpler option. Reinforce facial closure with mesh, either inlay, onlay, or sandwich technique, which I have shown. Mesh should be properly laid down, should be wide enough. You can even take the mesh right up to the psoas muscles on both sides. And it should be fixed properly. Pay attention to skin and subcutaneous tissue so that you preserve the vascularity of these and avoid any kind of necrosis. So minimize undermining. Anterior component separation, I have already discussed. Posterior component separation, you don't get skin problems in posterior component separation. Excise undermined skin if possible. You can do a paniculectomy, obliterate any kind of dead space by using suction drain. Surgical planning depends on surgeon's experience. Many a times, once you open the abdomen, because of previous surgeries, there could be adhesions of the bowel which need careful dissection and excision of adhesions. Atrophic or scarred skin needs to be excised. If there is any kind of enteric fistula, that needs to be taken down carefully. Component separation we have already discussed. If component separation fails to reconstruct the midline, take help of a plastic surgeon. So even if you feel that in the preoperative period, you would require some kind of muscle interposition, then you should discuss with the plastic surgeon and keep your plan ready. Of course, physiological and psychological optimization of the patient. Hernia site more than 10 centimeters. Loss of domain should be considered. Botulinum toxide can be given in the muscles. There are different intraoperative challenges as well. So operative time in these patients I have seen is very, very high compared to the simpler muscle or simpler hernia repairs with onlay mesh plastic. There could be concurrent intra-abdominal procedures like some kind of gynec procedures like fibroid excision or maybe cholecystectomy. Presence or absence of adhesions, avoid any sort of bowel injury which will jeopardize the recovery of your patient and would land the patient in postoperative sepsis. While creating TAR plane, entering the correct plane is very important, because in these situations where there is already a scarred abdomen, you tend to lose these planes very easily. So one should keep an eye on the planes and come back to your original plane if you find any kind of difficulty. Integrity of the peritoneal layer has to be maintained. There shouldn't be any buttonholing. If there is any previous surgery with mesh, that needs to be taken out. Posterior wall has to be restored before you lay a mesh on that wall. The defect has to be covered with a wide mesh. Use sandwich technique if the defect appears to be, if the abdominal wall appears to be quite thin. So for prolonged procedures, use DVT stockings. Post-operative low molecular weight heparin can be given. Selection and positioning of the mesh has to be very, very important. You may use 1 or 2 meshes. Relationship among these factors, when appreciated and applied to a patient management, reconstructive surgeon can achieve consistent outcomes that reflect skill, experience, and understanding. Let's come to the post-operative complications. There could be lung complications, which we have already discussed. Patient might be harboring some cardiac disease, which needs to be taken care of. DVT is definite possibility. There could be procedure-related complications like obstruction, perforation, or dehiscence of the posterior wall, which has been closed. There could be hematoma, seroma, or skin necrosis. Later date, mesh recurrence, infection, and the recurrence of hernia could be there. So early ambulation, sequential compression devices, low molecular weight heparin, incentive spirometry, adequate pain control, and tap block. Tap block can be given for post-operative analgesia. So how to overcome these challenges? Pay your attention to the surgical techniques. If you are not experienced, don't venture into it on your own. Take help of some senior surgeons. Optimization of comorbidities is very important, and the patient should understand that as soon as he reaches the hospital, he cannot be operated. So patient-centered approach has to be there. There should be a teamwork among surgeon, plastic surgeon, his assistant, and intensivist. All set standard protocols should be followed. The work on this particular issue should be supervised by a senior surgeon, and there has to be multidisciplinary approach. If you see this patient, is it possible to offer him some kind of repair? With my knowledge and my expertise, I am unable to give him any kind of solution. So refer these patients for surgeons who are more experienced than you. This is one patient of post-renal transplant, large hernia, who has undergone AWR surgery. So it is possible to treat these kind of patients, but they are definitely challenging in the pre-operative, intraoperative, and post-operative period. With the increasing incidence of ventral hernias, you are going to get these patients. So it is better to learn this technique and master this technique. Thank you.
Thank you, Dr. Mukund. Your nice. Definitely, these are the challenging hernias nowadays. Most of the patients, they are coming with the obesity, and with obesity, there is a recurrence or occurrence of the hernia, and that too large hernias, which are very difficult to control. We have shared your technique, your knowledge, and detailed descriptions of the hernia. The request has come from the organization. We are running short of time, so that will end up this session.
Thank you, sir.
Thank you.
Thank you, Dr.
Thank you
Thakur,
so
sir.
much.
I request our chairpersons to felicitate our speaker, Dr. Thakur, sir. I request Dr. Ghate, sir, to felicitate our chairpersons, please. Now for the next lecture, I invite Dr. Roshan Jacob to speak on role of NACT in management of breast cancer. I invite Dr. Rajendra Singh Arora, sir, to join me to chair the session. Dr. Roshan Jacob, I welcome you on behalf of Association of Surgeons Amravati. Dr. Roshan Jacob is a renowned oncophysician from American Oncology. He has done DNB and DM in medical oncology. He has ESMO examination certificate and MRCPSC medical oncology certificate from Royal College of Physicians, UK. He has done special training in basic and advanced life support from American Heart Institute. He is a member of various national and international organizations in the field of medical oncology. He has various publications and research papers on his record. Friends, there is a shifting paradigm in the management of breast cancer in which NSCT plays a major role. I request Dr. Jacob to enlighten us on the role of NSCT in management of breast cancer. Sir, please.
Thank you, madam, for such a wonderful introduction. So this is the organization that I represent, American Oncology Institute at Nagpur. So today the role assigned to me is to discuss about the role of neoadjuvant chemotherapy in the management of breast cancer. So I have got a very challenging job this afternoon because I'm surrounded by surgeons and I'm talking about neoadjuvant chemotherapy. So I'll start off the topic. So my today's I have limited my presentation to a few slides. So initially I'll be giving a brief introduction about breast cancer and a few points about the general investigations and management before going into the actual topic of neoadjuvant chemotherapy. So starting with the epidemiology, we all know that breast cancer is one of the most common cancers. So all over the world, globally also, breast cancer is the most frequent cancer which is diagnosed, and even in India, the age-adjusted ratio for breast cancer is 25.8 per 100,000 women, and the mortality is around 12.7 per 100,000 women. So if you see by the numbers, it is suggested that every 4 minutes, a new woman is diagnosed to have a breast cancer. So this numbers is astounding, and it is why breast cancer is a challenge even today. So you can see on this this graph that the breast cancer mortality over the last few years has been on a decline. So this is basically because of the new advances in treatment which has been happening. The introduction of these newer molecules, the change in the approach from adjuvant to neoadjuvant. So all this has helped in to bring the mortality down. So if you see the drop, actually it is almost nearly 10% in the last 17 years. Before going into the topic, I think we need to just, I can't cover the entire staging, but I'll just briefly touch upon the staging. So when it comes to the staging, we need to know the T, N, and M staging. So M is simple, whether it's metastatic, non-metastatic. Coming to the T staging, it's just the numbers. We have to remember number 2 and number 5. So any lesion which is less than 2 centimeters is T1, lesion between 2 to 5 centimeters is T2, more than 5 centimeters is T3. So when it comes to T4, T4A is chest wall invasion. Chest wall invasion, what you need to keep in mind is that the pectoralis major or minor is not involved in the chest wall. Chest wall is comprised of the ribs, the intercostal muscles, and the serratus anterior. T4B is basically comprising three of the distinctions are there, with either a ulceration, subcutaneous nodules, or there should be a pudy orange. T4C is basically both A and B together, and D is inflammatory breast carcinoma. When it comes to the N staging, basically N1 is this movable level 1, level 2 lymph nodes. N2 is basically, N2A is fixed level 1, level 2 nodes. N2B is basically the internal mammary node is positive without any axillary lymph node. And N3 is again divided into 3. N3A is basically level 3 this axillary lymph nodes. And N3B is this ipsilateral internal mammary with axillary lymph nodes. And N3C is basically supraclavicular. Why all this is important is because we need to distinguish between early breast cancer and locally advanced breast cancer. So as you can see on the right hand corner, you can see that the early breast cancer is basically something up to T2N1. So how do you define locally advanced breast cancer? Anything more than 5 centimeters, that is more than T3, irrespective of the N status. Or if it is N2 or N3, irrespective of the T status, is a locally advanced breast cancer. So what are the investigations that are required prior to deciding any management of any breast cancer? So definitely a mammogram, I think that is routinely done. So biopsy from the breast lesion is mandatory. So many, I think many of the surgeons will be used to doing only FNAC and proceeding with the surgery. But definitely a biopsy is required because it helps in many ways. One is the diagnosis. Second is we need tissue for the molecular testing. And then it helps us to decide between both these things will help us to decide between BCS and mastectomy. So breast cancer receptors testing is basically ER, PR, HER2 and Ki67 testing. These has both prognostic and therapeutic purposes. If axillary lymph node is found on upfront evaluation on a mammogram, then we need to do a FNAC or biopsy of the axillary lymph node to prove the same. And metastatic workup, we for early breast cancer, depending on the symptoms, we may decide the investigations. Like for example, if a patient has cough, we need to do CCT thorax. If patient is asymptomatic, we can just do a chest X-ray and a ultrasound. Guidelines even mention that you don't need to do any metastatic workup in early breast cancer if they are asymptomatic. For patients with locally advanced breast cancer, then definitely we have to do a PET-CT or a CCT abdomen pelvis with a bone scan as a metastatic workup. So as you all know, the management of breast cancer is a multidisciplinary, which involves the surgeons, the medical oncologist and the radiation oncologist. So I don't think I need to speak about the surgical part because anyway, you are all surgeons. So this is just a slide to tell about the evolution of surgery from being more radical to being more and less radical. So it started from radical mastectomy to MRM to now BCS and then sentinel lymph nodes. Initially, when the breast cancer was managed before the 1970s, surgery used to be the only part of the treatment. So then the first trial came in 1976, where they tried adjuvant chemotherapy. That was with CMF. That is a Milan trial, which I'll be discussing next. So that was the start of the adjuvant chemotherapy. So you can see how far we have gone from there. So from CMF, we compared CMF with AC, then AC became the standard. Then we added taxanes to AC, then AC taxane became the standard. And then we have FEC, TAC, multiple regimens came into play, and it's ever evolving. So every year some new trial comes up and some new updates are there. The first trial to show any benefit of chemotherapy in breast cancer was the Milan trial, which was in 1976. The patients were randomly assigned to receive 12 cycles of CMF or no further treatment after surgery. What was important here is that there was no other treatment in this scenario because there was no radiation, no endocrine therapy for any of these patients. So the benefit was purely because of the chemotherapy. So in the long-term follow-up, you can see that the patients were followed up for up to 30 years. There was a significant benefit of OS and DFS with a hazard ratio of 0.7 for DFS and 0.79 for OS. So which is quite significant. So coming to my topic today, what is neoadjuvant therapy? So basically neoadjuvant therapy refers to the systemic treatment of breast cancer prior to definitive surgical therapy. So this can be in the form of chemotherapy or it can be in the form of endocrine therapy. So before we go into any data or trials, I need to let you know what is PCR. So this is very important because most of our recent trials or newer upcoming trials are all keeping PCR as a marker of, as a surrogate marker for OS and DFS benefit. Now, what is PCR? PCR is defined as the absence of a residual invasive cancer on HNE evaluation of the complete resected specimen and all the sample lymph nodes following a. This is designated as YPT0 and N0 in HSCC staging. Now, why FDA had approved PCR as a marker is basically because if you just before slide you could see that the OS DFS benefit to be proven in a trial, it took almost 15 to 20 years. So you know we don't have that much of time to wait. If I start a trial today and if I will be able to tell you that the OS benefit is in 2052, then there is no benefit of doing the trial. So that is why they took PCR as a surrogate marker, because PCR is something which we can immediately assess, and we are taking it as a marker that patients of PCR will be having a OS and DFS benefit. So this was again proven in this pooled analysis, which was consisting of almost 12,000 patients. So this was proven that achieving a PCR in the breast and the axilla, it was associated with the improved EFS and overall survival. So on tumor subtype evaluation, they found that this was markedly more in TNBC and the HER2 positive subset. when a PCR was achieved, the risk of death was reduced by 84% in TNBC, the triple negative breast cancer, 92% in HER2 positive breast cancer, and 71% in a hormone positive breast cancer. So this itself suggests why neoadjuvant is important, because we are trying to do is attain a PCR. So what is the goal of any neoadjuvant therapy? It is one is to downstage the tumor, which will help in a less extensive surgery of the breast and the axilla. It will provide a prognostic information for the further treatment. Basically, the neoadjuvant, the response to neoadjuvant therapy can help us guide what is the adjuvant treatment that needs to be followed. There are newer trials which I'll be discussing later on, which have made us change our practice. And then, as discussed, the PCR. PCR itself is a strong prognostic factor, which is a marker for OS and DFS benefit. So how neoadjuvant chemotherapy started? So as we talked about the evolution of chemotherapy in the adjuvant setting. So once AC chemotherapy was proven in the adjuvant setting, then they wanted to try something new, so they tried it in the neoadjuvant setting. So this was the phase 3 trial where two arms were there. One was a adjuvant AC, the other was a neoadjuvant AC. So here you can see the increase in the BCS for more than T3 tumors was astounding, 175%. So these are all play of numbers, but what you can see is that there is a significant response rate, which is 79% and a PCR of 13%. So in the trial, they couldn't find any difference of DFS and OS, but when the subset analysis was done, for patients who had attained PCR, definitely there was a OS and DFS benefit. So after they proved that AC was good in the neoadjuvant setting, then next came the challenge of adding taxanes in the neoadjuvant setting. So this was a trial for the SAT. So this is again a NSABP B27 trial where AC followed by docetaxel was tried. Here again, there was an improved PCR, doubled from 13 to 26%. And definitely there was an improved OS and DFS benefit. This is one more Cochrane analysis, meta-analysis, which again proved that PCR was prognostically significant with improvement of OS and DFS, and the benefit was more pronounced in a more aggressive tumors, that is TNBC and HER2 positive waste. So this is just a forest plot showing that it was all in the significant range. So after the initial studies, then the further studies tried to concentrate on the different subsets of breast cancer, because they found that the triple negative subset and the HER2 positive subsets were the ones which had a lot of benefit from the neoadjuvant chemotherapy. So then the multiple trials came. So this is just to brief what are the subsets. Basically, luminal A is nothing but hormone positive breast cancer with a Ki67 of less than 14%. Luminal B is hormone positive breast cancer with more than Ki67 more than 14%, or it's a triple positive breast cancer. HER2 enrich is nothing but ERPR negative, HER2 positive, and basal like is nothing triple negative. So these are basic the subsets which help us to guide the treatment. So who should receive neoadjuvant chemotherapy? So as per the going through the guidelines, as per the NCCN guidelines, you can see the marked area. I think the first part is something that nobody would have any problem with, because the inoperable breast cancer we have to give. Inflammatory breast cancer or bulky N2, lymph nodes, N3 nodal disease, CT3-4. So these are all accepted. So the second part is something which can be controversial, where early breast cancer or operable breast cancer, whom do we need to give an NACT? So here again, the two subsets they have mentioned, that is the HER2 positive disease and the triple negative disease. So these two subsets, if the lesion is more than T2, that is if it is more than 2 centimeter, or if one node is clinically positive, then they should receive neoadjuvant chemotherapy. That is anything but that is more than T2, N1 should receive. Then the other indications are basically if the large primary breast tumor is more than the breast size, then and the patient desires to have a BCS, then again that is an indication for NACT. Clinically node positive disease, we can give NACT to make it clinically node negative, but this is again limited to N1 disease only. The ESMO guidelines also, it's more or less the same. The tumor more than 2 centimeters or optimal surgery is not feasible, and the patient wishes for BCS. These are the indications for systemic induction therapy. And for triple negative and HER2 positive, 2 centimeter and or with positive axilla, regardless of the feasibility of surgery, should undergo neoadjuvant chemotherapy. So in triple negative breast cancer, why we press for neoadjuvant chemotherapy? This was one of the recent trials which came up. This is the CreateX trial. Here they gave neoadjuvant chemotherapy for all stages of stage 1 to stage 3B, and they assessed the response to neoadjuvant chemotherapy. If the patients were in PCR, no further chemotherapy was given. If the patients were not in PCR, then they were given capecitabine. So the capecitabine was given for 8 cycles, that is almost 6 months, at a very high dose of 2,500 mg per meter squared per day. So in this trial, they found the benefit of 5-year DFS to be almost 7%, and the 5-year OS was almost 5%. So why this is important is because triple negative breast cancer is a subset where we do not have any maintenance therapy, because in a hormone positive, after the upfront treatment, we put them on hormonal therapy, which acts as a maintenance. But in a triple negative, what they found is that in triple negative, the first 3 years, the chances of recurrence are maximum. While in a hormone positive, the recurrences are late recurrences. Most of them happen after 5 years. So triple negative, the trials were ongoing because they were seeing as to what can be done to prevent these early recurrences. That was one of the reasons was this was tried, and they found a significant benefit in the DFS and OS. And this has become a standard. So for us to give capecitabine in the adjuvant setting, all the chemotherapy should be given in the neoadjuvant setting. If the patient, in spite of our full plan, that is, if we are giving 4 into AC and 4 into taxanes, in spite of that, the patient doesn't attain a PCR, then we should give them capecitabine. This is in the triple negative setting. This is a standard now. In HER2 positives, again, as we discussed in the trials of adjuvant, it showed a significant benefit. Trastuzumab showed a significant setting. So they tried it in the neoadjuvant setting, that is the NOAA trial. And here you can see that the PCR jumped from 13% with chemotherapy or 26% with that combination chemotherapy to 40% nearly. So when the trastuzumab was given with chemotherapy, the PCR rates was about 40%. Now then they tried adding pertuzumab, that is another anti-HER2 agent, to trastuzumab in the neoadjuvant setting. So in this particular trial, it went up to 45-50%. Some trials have shown up to 60% the PCR rates. Like the CreateX trial, this is the Catherine trial. Catherine trial was the one which again is a game changer for us in a HER2 positive subset. Why? Because in patients who have received neoadjuvant trastuzumab, if they don't attain a PCR, then we have an option now of putting them on TDM1. TDM1 is trastuzumab emtansine, which is a newer molecule. So here what they have tried is like there are 2 arms. So patients who have not attained PCR after the neoadjuvant trastuzumab were given either trastuzumab maintenance to complete 1 year, or they were given TDM1 to complete the rest of the cycle. So here again you can see that there was a significant difference in the IDFS. IDFS is invasive disease-free survival. So basically all this endpoints keep changing from trial to trial. Basically they take something which they can publish the results soon. So this invasive DFS, PCR, so all these many things will be coming up in the trials. Basically the benefit what was shown is significant because the hazard ratio was 0.5 in this trial. So now based on this trial, again we have changed our practice. So any patient who is receiving neoadjuvant trastuzumab, if they don't attain a PCR, we always counsel them for a TDM1. Cost constraints are definitely there, but definitely now we have an option. What about the ER/PR positive subset? So in this subset, definitely we have 2 options, either a neoadjuvant chemotherapy or a neoadjuvant hormonal therapy. Now this was one of just the trials which showed that even hormonal therapy is as equivalent or even much better than chemotherapy in this subset. But this is not as simple as that. So if you see the approach, what we should take to a patient, if a patient is HER2 negative and if it is pre-menopausal, then we have to give chemotherapy even if the patient is ER/PR positive. If the patient is post-menopausal and if it is medically fit, we have 2 options, preferably chemo, or we can give neoadjuvant hormonal therapy. If the patient is medically unfit, then we cannot give chemotherapy. The hormonal therapy is the only option. So the next controversial thing is the management of axilla after neoadjuvant chemotherapy. So all of you are aware about the sentinel lymph node biopsies which are done upfront. So what are the contraindications for a sentinel lymph node biopsy? The one is upfront N2, N3 stage, inflammatory breast carcinomas, And relative contraindication is the locally advanced breast cancer T3 or T4A, T4C, T4A to T4C. But this is again a relative. Many people still do if the node status is N0 or N1 at the beginning, at the pre NACT, if the staging was N0 or N1. NACT downstages the axilla in up to 40% of the patients. And in a patient with a positive axillary lymph node, the placement of a radio-opaque clip is to be done to identify the lymph node after the neoadjuvant chemotherapy. So the removal of the marked node at the time of a post-neoadjuvant therapy, this reduces the false negativity rate from 10% to 1.4%. So that is why it is important to mark it. So these were the trials of sentinel lymph node biopsy. You can see that there are, I'm not going into the trial details. So just to brief about what are the considerations that you should keep after neoadjuvant therapy in a sentinel lymph node biopsy. First is you place a clip before starting the chemotherapy. Then when you're doing a sentinel lymph node, dual agent mapping should be done. That is a radiotracer dye and a methylene blue or isosulfame blue dye should be given together. A normal physical examination, axillary ultrasound should be normal after the chemotherapy. When the sentinel lymph node biopsy is done, more than 2 lymph nodes should be removed, and intraoperative frozen section should be done of all the nodes that are removed. Axillary lymph node dissection should be done if there is a failed mapping, that is if none of the sentinel lymph nodes take up any dye, or if there is only less than 3 lymph nodes are being dissected, or if on frozen section any of the lymph node are positive, then you should go for the axillary lymph node dissection. So this is again just the flowchart to say how to guide the treatment. So you can see that if the upfront there are, I think no axillary lymph nodes, then it's clear. If it is axillary lymph nodes are there, once it is FNA positive, then you have to see whether it is N1, N2 or N3. If it is N1, then NACT, we have an option of going for sentinel lymph node. If it is N2 or N3, we should go for axillary lymph node dissection, irrespective of the response. So I've reached the end of my slides. So I will just press upon this. What are the indications for neoadjuvant chemotherapy? So basically, one is a locally advanced breast cancer. That is, any patients which have T3 and above or N2 and above should receive neoadjuvant chemotherapy. Early breast cancer, there are 2 scenarios where if a patient is being considered for BCS, if you want to reduce the tumor volume, then we should give it. Or second is in the HER2 and the triple negative subset. If a tumor is more than 2 centimeters or clinically node is positive, then it requires neoadjuvant chemotherapy. The third one is basically node limited clinically node positive disease, where you would like the patient to undergo a sentinel lymph node biopsy after neoadjuvant chemotherapy. That again is one of the indications. I am short of time, otherwise I could have discussed a case.
Thank you, Roshan. Very nice discussion. You have covered everything. You have covered axillary lymph node dissection after neoadjuvant therapy. You have covered the role of neoadjuvant therapy in locally advanced breast cancer and making them operable. It is very clear that what neoadjuvant chemotherapy should be given in triple negative breast cancers. But still it is not clear what should we give for triple positive disease, whether we should go for hormone or whether we should go for chemo, or we should combine it, or we should combine Herceptin with that. What should be the sequence?
Sir, if
message.
Yes, if HER2 is positive, sir, if chemotherapy is always preferred, we have to add an anti-HER2 with the chemotherapy. So if HER2 is negative and hormone is positive, then only we think about neoadjuvant hormonal therapy. Or in a rare scenario where the patient is like very aged, very unfit, then we can combine hormonal therapy with Herceptin, but this is not based on any trial. This has to be, this is off-label.
Yeah, the Herceptin is equally effective with taxanes and anthracyclines, or it is working with taxanes only?
It's not like that, sir. Basically, we don't combine with anthracyclines because of the cardiotoxicity. Because both anthracyclines as well as Herceptin have cardiotoxicity. So when you combine, though some trials have shown that it is safe, most of the medical oncologists do not combine with the anthracyclines, because we will not be able to differentiate what the cardiotoxicity is due to when we are giving it together. So for example, if I give AC with a Herceptin and a patient develops a heart failure, I will not know what to stop, because anthracycline causes a irreversible heart failure. While trastuzumab causes a reversible heart failure, which once the EF comes up, I can re-challenge trastuzumab. So that becomes a challenge. So most of the time, what we do is we combine the trastuzumab with taxanes, and then we give only anthracyclines alone. We don't give this Herceptin with that.
In LABC patients, when we are giving chemotherapy, neoadjuvant chemotherapy, how many cycles should be given? Whether it is the number of the cycles or the clinical examination that determines.
That's what I said, sir. If it is if you are giving in a triple negative setting, we have to give all the planned 8 cycles. If you are giving upfront plan is for 4 AC, 4 Paclitaxel or 4 DOSI, that is taxanes, we have to give all the 8 cycles because now we have an option of adding capecitabine if they are not in PCR. In a HER2 setting also, we have to complete the complete chemotherapy because the PCR rate with the chemotherapy plus this anti-HER2 comes to 40 to 60%. So we have to complete the planned chemotherapy as a neoadjuvant because now PCR helps us to guide the adjuvant therapy.
One thing more, with CREAT trial, you said all the patients were given 4 FSC and taxanes, or they were given.
So there were mix of patients. There were FEC also was given. Most of the patients received anthracycline plus taxanes. So it was either FEC plus DOSI, 3 FEC, 3 DOSI, or it was 4 AC, 4 Paclitaxel. But the main thing was all patients had received neoadjuvant therapy, whatever was planned.
Okay, the patients who have not gone under complete response, whether we should go for the HER testing, ERPR testing, or
no, sir. There is no benefit of ERPR testing in that scenario. If a patient after the primary treatment, there is a progression. If for example, I do complete all my treatment and while on maintenance, patient is having a progression. At that point of time, I will do a repeat biopsy and repeat the ERPR HER2 because the discordance rate for ERPR is almost 10 to 15% and HER2 is almost 5%. So that most of the time from positive, it will become negative. So most of the time our anti-HER2 or our hormonal therapy will not work at that point.
Thank you, sir.
Okay,
We are running short of time.
Sure.
So we will discuss later on. If there are any questions from the audience, they can ask Dr. Jacob later on. Thank you.
Thank you so much.
Thank you. I would like to chairperson to felicitate our speaker, Dr. Jacob. And I will request Dr. Madhuri Barabde ma'am to felicitate our chairperson.
We'll take a lunch break over here. We have reduced the time of lunch for half an hour only. We'll reassemble here at 2 o'clock. Thank you.
Laparoscopic retrograde.
See, laparoscopy is not commonly done. If you have to do some other reconstructive surgeries for the
intensive care
Check.
ठीक आहे नसतं तरी चालेल. ठीक आहे. हे बंद करतो मी. Because to that time.
task, and especially after post-lunch session, making things a little difficult for me. But I'll try to give justice to this topic in this limited time. Before my talk, my gratitude to these two masters from whom I learned the art of laparoscopic surgery, Dr. Palnivelu sir and Dr. Wang sir, from whom I learned bariatric surgery in Taiwan. So some basic things about bariatric and metabolic surgery before we proceed to the actual procedures. When we speak about bariatrics, it means weight loss. So when a person is coming asking for weight loss, it means metabolic surgery. WHO has different guidelines for Asians and different guidelines for rest of the world because we Indians are more prone for type 2 diabetes and metabolic syndrome. So 18.5 to 23 is normal for Indian patients or Asian patients. 23 to 27.5 is being overweight and about 27.5 is obesity. So anyone in males having waist circumference above 90 centimeters and females more than 80 is termed as obese. Someone coming to OPD asking you an ideal weight, very easy to answer. Just check the height in centimeters and deduct 100 from it. So someone who is 150 in height, deduct 100, 50 is his ideal weight. There can be a consideration of 10% variation to it. BMI, we get a lot of apps where you can check the weight in kgs by height in meters square, and you can get the BMI on your mobile immediately. So BMI is an important concept to understand because the whole concept of bariatric surgery and the scientific literature is based on BMI. So BMI is an important indicator where we consider the weight loss, the indications for surgery. So what happens with the traditional diet and weight loss regime, diet and exercise regime? The ghrelin levels increase if a person is exercising, he eats more, but at some point when the weight loss target is achieved, he stops eating, he stops exercising and continues to eat more. So this was a study published in NEGM where the same thing has been told, and that leads to an weight gain. And if you see these people, those who are trying for weight loss, they'll be going in circles, losing weight, gaining weight, losing weight, gaining weight. This is because of the increased levels of ghrelin. So we know obesity is no more rich man's disease. It's in fact a disease which invites a lot of troubles. If you see 30% increase in all-cause mortality with 25 to 30 BMI, and 30 to 35, the median survival is reduced by 8 to 10 years, which is almost akin to smoking. And it's an risk factor for many cancers and end-stage organ failures because of diabetes and the comorbidities. One important thing that I should mention that with pharmacotherapy, realistic weight loss is only 5 to 10%. So someone who is giving weight loss medicines to a person who is 120 kgs, 140 kgs, it is not going to work. That person will only lose about 10% of his weight with the best medical management. And if there is no 5% weight loss with medical management, the medicines either need to be changed, they need to be added or to be stopped. So one should not continue giving trial of medications if there is no weight loss at 3 months. So just as physicians choose their antihypertensives amongst all this many available, they choose anti-diabetic medications amongst the many available. Bariatric surgery surgeons also need to change and adapt and choose the right procedure according to the person's characteristics. So for bariatric surgery, as I mentioned, the intention is weight loss. The BMI for bariatric surgery, the guidelines are 32.5 and above with any 2 diseases, or 37.5 and above without any disease. But if someone has severe diabetes which is not controlled with medicines, the BMI 27.5 and above, which is not controlled with medicines, we can offer them metabolic surgery. We are not asking all diabetic patients to be operated, but those, in spite of having 3-4 medicines on, roughly speaking, 50 to 60 units insulin, even with this best medical management, if their diabetes is not controlled, the physician should definitely consider thinking about metabolic surgery. Severe psychiatric illness, chronic alcoholism, unwilling to alter the lifestyle, not motivated. Those who want bariatric surgery as a single stop solution, की डॉक्टर तुम्ही सर्जरी करा बाकीचं आम्हाला काही करायचं नाही. These are very bad patients because they will spoil your reputation. They will not exercise. They will not follow what has been told. So choosing patients is also a very important task for these surgeries. Things that we have to consider when we are choosing the procedure: age. We cannot do bypasses at extremes of age. BMI, again, above 50, bypass becomes technically challenging. Comorbidities, someone with severe diabetes, bypass is a better option, or sleeve plus procedures, which I'll speak about. GERD, we cannot do sleeve. We have to think of a bypass. Quality of life is better with a sleeve. Diet compliance, exercise compliance with this patient really come for follow-up. It's a big question. So taking into consideration all these things, we have to choose the right kind of procedure. Whether this person is a sweet eater or volume eater, the psychological factors, the follow-up supplements, the setup that we are planning to do a surgery has to be adequate. The training of the surgeon has to be good. And of course, cost is a factor we cannot ignore. Bypass is costly, sleeve is cheaper. Something about diabetes, someone coming again asking whether my diabetes would go away with this surgery. This is a very simple algorithm, ABCD score, wherein if you do C-peptide levels fasting and the levels are more than 3, this person can be cured of diabetes, you can assure him, provided it's not type 1 diabetes. So age, BMI, C-peptide and duration of diabetes, these 4 factors can help you decide whether this person would go into remission. And let me tell you, 80 to 90% of patients are cured of diabetes if the choice of procedure, the patient selection is good. And 10% of them get remission, improvement in the diabetes, wherein their number of medications reduce. So these are some of the things that when you read scientific literature about bariatrics. Excess weight loss is, if a person is 100 kgs, his ideal weight is 50. So 50 is his excess weight. So of that, with bariatrics, we are targeting a weight loss of about 60 to 80%. That is, the person would lose up to 30 to 40 kgs with bariatric surgery. So this is excess weight loss. BMI loss is the change in BMI. Someone who is 36 BMI has come down to 27 BMI. So it indicates an ideal weight. So when we are speaking whether this person has achieved ideal weight or not, we speak about BMI loss. Total body weight loss, again, a confusing indicator, but it's used by physicians generally, wherein they speak about 5 to 10% of weight loss with medicines. With bariatric surgery, we can see up to 30 to 40% of total body weight loss and 60 to 80% of excess weight loss. So now we very clear know that it's not only a restrictive or malabsorptive surgery. There are altered neuroendocrinal signals to the brain. There are altered signals to the pancreas and liver, and this is more of an hormonal surgery, which is evident by rise in GLP-1, PYY levels and reduction in ghrelin levels. So these are the 3 hormones which interplay. Their levels change after bariatric surgery, and that is how the metabolic syndrome severity reduces. Coming to the first and most popular procedure, sleeve gastrectomy, what we are doing in a sleeve is we are reducing the volume of the stomach. So fundus is the area where the ghrelin hormone is secreted. So we are dissociating less food intake and hunger. So even if the person eats less, he doesn't feel hungry. And the beauty of this procedure is, since the antrum is preserved here, the intrinsic factor, calcium, B12, all these deficiencies occur less compared to a bypass. And if the person changes his lifestyle within 1.5 years, he may not have to take any supplements after 1.5 years. So with this procedure, we see about 60 to 80% of excess weight loss. So this is a short video of the technique. So for bariatrics, we require good exposure in the upper abdomen. So liver retraction is a must. This is one of the techniques with JP drain and a straight needle. So we have published a paper on this in JMAS. There are 4 to 5 different techniques, but liver retraction in upper GI surgery is a must. You cannot avoid it. And this is the stomach which we are transecting the greater curvature side with the ligature. So the greater curvature has to be devascularized 4 centimeters from the pylorus up to the left crust. The left crust has to be completely exposed. Removal of fundus is the most important step in a sleeve gastrectomy. So once we have dissected the greater momentum from the greater curvature, a bougie 36 French is a standard measure. We pass it per orally, mark along the bougie, and then we start dissecting with a stapler. So almost 1/3 stomach is left, 2/3 is removed, and complete removal of the fundus is an important step in a sleeve gastrectomy. And after this, we fix it to the retroperitoneum to avoid any volvulus or kinking. And this can be done through a single incision, through 3 incisions or 4 incisions. So we generally employ 4 incisions, 3 10 mm and 1 5 mm. And this is the specimen that we are removing from the umbilicus. So this is a very good procedure for high-risk patient, standalone procedures, the patients who are due for a organ transplant, and first choice procedure for us because of multiple reasons. But a GERD and liver cirrhosis, alcohol abuse, of course, are contraindications. Results are good. Those who are interested can go into the Stampede trial and read the details of this. So in some instances, weight loss is almost touching 70 to 80%, which is comparable to RYGB. So this is the latest development that is happening in bariatrics over the last 3 or 4 years. Since bypass is more supplement dependent, we have something as a sleeve plus procedure where we are doing a sleeve and we are doing an intestinal bypass. According to the different permutation combinations of the way the intestine is attached to the sleeve, there are different procedures. So we have DJB, we have SADIs, we have transit bipartition and loop bipartition. So these are the most common sleeve plus procedures that are done. So while I was in Taiwan, our teacher, Dr. Wang, started doing this PJB, which I'm following. So what we are doing in this is we are doing a sleeve and a 250 centimeters bypass so that the food goes into the distal ileum early, good for diabetics who are insulin dependent. So this was selected at the World Congress in Dubai for video presentation. Bypass is something, there are various variations to bypass as well, but a standard Roux-en-Y gastric bypass is when we are doing a pouch. We are attaching the small intestine to this pouch and we are doing an enteroenterostomy so that the acid, the bile, the pancreatic juice mixes with food here. So this is the restrictive component, and since you are bypassing this element, this is the malabsorptive component. Of course, with change in hormone levels is the third addition to this procedure. So this is a procedure which is good for people who have severe comorbidities. Weight loss is also more with a bypass compared to a sleeve. What we are doing in a mini gastric bypass is we are making a small pouch of the stomach, almost like an RYGB, but it's a longer pouch. And instead of doing a Roux-en-Y configuration, we are doing a loop configuration. That's the only difference. But the major difference that happens with this is a person can eat a little more and still continue to lose weight. And that's the reason it's more popular in northern India, especially in Punjab. So this is also one of the standard procedures. And again, a small video of this procedure. So this is the OptiView entry, a standard thing that we do not go into the midline. We go from the palmer's point or the left upper abdomen. So the first step is dissection along the lesser curvature here, along the crow's foot, because the first firing will happen from that angle. So any harmonic or ligature or any energy device can do this. So once a window is created, we insert the first stapler. Depending on the thickness of the stomach, we have to choose the color. So sometimes an green or an yellow stapler is ideal for the first firing here. So once the first firing is done, the second we go on along the bougie, we start just like a sleeve, we start making the firings. Generally 3 to 4 firings are required. This is the retrogastric dissection to facilitate the final firing. So once this is done, the stomach tube is prepared. Now we make an enterotomy on this stomach tube. This is the site where the small intestine will come and get attached. So usually 150 to 180 centimeters is the biliopancreatic limb length that we take from the DJ flexure. We make an enterotomy on the small intestine. That's the enterotomy being created. Then we insert the stapler in both the ends and we fire. So once this firing is done, we close the enterotomy with sutures. One may do and again a third firing also there, but usually I prefer to suture. Once this enterotomy is closed, we do so. This is the biliopancreatic limb, which will bring the bile and pancreatic juice. The food will mix here and go distally. At the end of this, we do a leak test with methylene blue. That's the leak test, and that's an MGB. So the person has to take protein, vitamin, calcium, iron, zinc, minor trace elements, and this has to be clearly explained to the patient if you're doing a bypass that it's a lifelong commitment to healthy eating habits, lifestyle changes, exercise, and intake of supplements. So coming to the question where what are the non-surgical options, 27.5 to 32.5 BMI, we have a variety of endoscopic procedures. We have something known as intragastric balloon, where we are inserting a silicone balloon in the stomach for a period of 6 months to 1 year. And this can give you weight loss to the tune of 10 to 15% of total body. So bariatrics has been there quite for a long time in the West. We have more than 10-15 years results, and these 80 to 85% of patients do well with surgery. There is a misconception that all patients gain weight, and it's not so. It happens only in 10 to 15% of patients who take sweets. So we have to be careful about sweet eaters. This is about the learning curve. At least 25 surgeries need to be done to start individual practice. So, and important thing about cost. So central government health scheme has covered this surgery completely free of cost. In Pune, our corporation gives financial assistance. There are few insurance companies, now almost all companies, it's been mandatory since last year that IRDA has made it compulsory for all companies to include bariatric surgery. There are some companies which give finance as an option, and the expenses are covered in 2 years. There are many papers about this. But unfortunately, the awareness of this surgery is so less, even amongst the surgeons, that some even general practitioners, for that matter, that the people discourage doing surgeries. And we get patients in their late stages when they cannot walk, the spine is gone, the knee is gone, the quality of life is very, very poor, and then they come for surgery. So when there is uncontrolled metabolic syndrome or the quality of life due to obesity is hampered, this surgery should definitely be contemplated and advised to the patient. Someone who is above 40 BMI, straight away surgery, there is no other option, should be clearly informed to these patients. Again, this is as I said, it's a specialty now, the complete knowledge, not only operating, taking this care of these patients, because people will not change overnight. Their eating habits, their lifestyle, everything has to be taken care of, and they have to be imbibed again and again with support group meetings that this is something that you need to change. This is what you need to change. This is, so a teamwork helps in this regard. And every 3 monthly, bariatric unit needs to conduct support group meetings. So again, important thing is there has to be a lot of awareness for this surgery. So forums like these can help you in giving the right message to the right audience. And bariatrics, and for that matter, even hernia, it has become an individualized surgery now. It's no more that one surgery for all. With this, I would like to invite you all for the upcoming 2 conferences in Pune that we are doing. The Symbiosis AWR-Con that is happening next Saturday and Sunday. We have excellent national faculties where everything from A to Z, that's the theme of the conference we are covering in this conference. All the surgeries are being demonstrated and covered. So please do join for Symbiosis AWR-Con, that is next Friday and Saturday, 10th and 11th. And also our ASACON, our state chapter meeting that is happening from 3rd to 5th February that Dr. Kolte will tell you about in detail in the evening. And with this, if any questions, I would be glad to answer. Once again, I thank Amravati Surgical Society, Dr. Ganiriwal sir, Ingole madam, chairpersons for honoring and giving me this opportunity. Thank you all.
Thank you, Dr. Kedar, for an elaborative lecture on such a vast topic. We are running a bit late and organizers are requested to attend just few questions. So one question from my side, and at the most we would take 1 or 2 questions from the audience. What are your criteria for deciding or selecting the procedure?
As I mentioned, there are multiple things that we have to consider. The first thing that comes to my mind with whether this patient will come back after surgery. That is the first thing, whether he'll take supplements, whether he's a sweet eater, whether he will modify the lifestyle changes or exercise or diet protocol that we're advising. Someone who cannot follow up after bariatric surgery is a bad patient. So
would you be operating on that patient who is not willing to follow?
Like for example,
And
in fact,
non-compliance.
yeah, in fact, a Nagpur patient, he's an alcoholic. He's been insisting on surgery, but I've given him a time frame that you need to abstain from alcohol for at least 3 to 6 months, then come for surgery. So those patients are not willing to change their lifestyle or habits or make some changes. Giving them a diet and exercise plan beforehand, seeing whether they comply to their changes, that's a good idea. And if they comply and they are motivated to do surgery, then you can offer them surgery.
Do you have any criteria to decide, means according to the comorbidities? If he has uncontrolled diabetes mellitus, maybe since 10 years down the line, you would be selecting MGB or a RYGB or a sleeve gastrectomy?
C-peptide, as I mentioned, is a very good indicator where you can decide whether you want to go for a bypass if the patient is coming for diabetes specifically and low BMI. See, somebody who is above 35 BMI has severe uncontrolled diabetes, you do sleeve or bypass doesn't matter because he'll lose weight, his diabetes will reduce. But for the lower BMI patients with uncontrolled diabetes, we have to be choosy. That is why the criteria are different for bariatrics and metabolic. So someone who has a good C-peptide level, good insulin levels, he's not type 1 diabetic, then you start thinking in terms of doing a bypass rather than doing a sleeve. So it is the lower BMI patients we have to be choosy.
Thank you.
Okay, since this is an overview topic, we cannot go into the technical details of each and every procedure. But in general perspective, we all know that, and it has been a point of discussion regarding the numbers of bariatric procedures going down worldwide, not only in India. where do you think we are heading? The bariatric procedure as such and the surgery, the whole science is heading.
I would say since a lot of youngsters are here, bariatric was in infancy in India about 10 years ago. Now it's a mature stage that we know when to do what kind of surgery. And now that the insurance has stepped in and made it mandatory for all insurance companies to include bariatric surgery, not as a cosmetic procedure, definitely I would say 5 to 7 years down the line, bariatrics will be a separate theme in all conferences because the numbers are going to rise definitely.
Thank you so much.
Thank you.
Are there any questions from the audience? If, I think we don't have any questions. Thank you, Dr.
Thank
Kedar.
you.
Thank you.
Hello. I request Dr. Atish Bansod to felicitate Dr. Kedar Patil. I request Dr. Rahul Lokande to felicitate our chairperson, Dr. Atish Bansod and Dr. Nirmal Patil. Our next topic is recent trends in management of varicose vein. And the speaker is Dr. Anjali Davle. The chairperson for this session is Dr. Usha Gajbiye and Seema Suneman.
Good afternoon, everyone. On behalf of ASA, I welcome Dr. Anjali Davle. We all know her academic achievements. Apart from that, I wish to mention she is very actively oriented and actively participating with many associations of V surgeons. She was EC member for MASI for last 2 terms. Presently, she is treasurer for MASI. She is presently EC member for Association of Breast Surgeries of India, EC member of Venous Association of India, and EC of International Coloproctological Association. She has been an operative faculty at various state and national level conferences and workshops. She is an article reviewer for International Journal of APSI by Walter. I think she is too active in every aspect, be it academics, be it non-academic, or with the associations. I welcome you once again. We really need this thing on varicose veins. As we all know, it's a very common problem. We all see to it in our day-to-day practices. And I'm very sure she's going to give us a lot about recent trends.
So, ladies and gentlemen, good afternoon, everybody. Thank you, chairpersons, for the introduction. At the outset, ASACON, which has been well organized by President Masi, Dr. Ganeriwal sir, Dr. Ingole madam, and Dr. Basme. So it's a big hit and a big bar race for the Pune ASACON. I will say it's a mini ASACON. So the topic for the today's talk is the recent managements in the varicose vein. Now, varicose vein is such a complex topic, and day by day, the increasing number of patients are there. It's a chronic progressive disease with It's a chronic progressive disease which results into the venous dilatation, distension, and irregular wall. Now, to say a few years back, there was no concept as such like venous concept or the venous clinic concept. But over the period, as we are progressing from a maximal approach to a minimal approach in every aspect of surgery, may it be laparoscopy, may it be breast, so the venous concept with a minimal invasion has also come into this aspect. Now, with the newer adventure, if you look at the historical perspective of how the varicose vein surgery has evolved over the period of time, it is as old as mankind is, and over the period of time, people have tried to understood what is the pathophysiology behind the development of varicose veins. So the venous scarf mechanism, how it has evolved, the chronic inflammation of the venous wall, these are some of the factors by which we can decide that how the disease is going to progress. The only aim and objective that why in general surgeon crowd we should have that varicosity, is it necessary? I will say every general surgeon along with the phlebologist where you cannot approach should be the need of time. Understanding the correct nomenclature. Why nomenclature? Because over the period, the terminology of saying whether it's a great saphenous vein, small saphenous vein, accessory vein, these have been changed, and it will define in under single umbrella at international level, we can define that what is the problem at which level. And third thing is the hemodynamics, how we should approach. And fourth thing is, as many techniques are available, what should be preferred for what patient. Now, anatomy of the varicose vein, you know, the greater and short saphenous vein. Why this anatomical image should be in our front? Because we are, whatever surgery you are going to do for the varicose vein, it has to be under the guidance of ultrasound. So this image is going to give you an overall idea at what level the GSV is going to remain superficial, at what level it is going underneath the fasciolata, at what level it is going to have a junction. So this is very important aspect of the surgery. Perforator veins. Why these veins are important to know? Because the recurrence of the varicose surgery, that is perforator vein, is going to decide whether this patient is going to develop a recurrence or not. Now, nomenclature has been defined by the various international associations in last 20 years. And while we are doing the duplex scanning of any patient, these terminologies are going to define you that what is the problem, and anatomical name itself is going to tell you that at what anatomical level and in which anatomical plane you are going to offer. Now, whenever a patient of varicose veins comes to you, it may be a cosmetic problem like reticular vein. It may be a full-blown picture of the CEAP grade 4. Along with it, you should also know there is an entity called as a congenital malformation. This is one of the system of the body after the pancreatic and CBD and anatomy HPB. The second site in the body where you can have multiple enormous congenital malformations in the body. So whenever you are dealing with such patients, you should have whether this is a candidate of a syndromic manifestation, whether he is going to have, by treating varicose vein, are we going to get ourselves into trouble? So nomenclature, AV malformation, the embryological perspective, this all should correlate. Now, how to think whether this patient is having a venous malformation, arteriovenous malformation, is it a full-blown picture of varicosity, or is it having a syndrome? There are certain peculiar findings by which we can decide. So important is the maculopapular thing, which is a congenital origin. Fourth thing is there will be multiple brownish patches over the body below knee, or depending upon the AV malformation site. Third thing is these patients may have a different length of extremities. That is one of the signs that they will have a difference of 1 or 2 centimeters. It can be also seen in the upper extremities also. So whenever you are selecting a patient, these some important findings have to be kept in mind. This vulval varicosity. Many of these patients comes to you, they say that day by day it is growing, it becomes a social problem, it becomes an emotional problem. In such scenario, Directly, you cannot go for the surgical or the foam sclerotherapy. Here, you have to see whether patient has any reflux, that to a ovarian reflux. We have to rule it out first, and then we can select that what is the proper procedure for this patient. CEAP classification, this is the only classification which has been accepted worldwide. As it says, the classification basis is clinical, etiological, anatomical, and the pathological classification. Now, why it is important to classify? The clinical manifestations will decide us on what we have to treat. Suppose patient is coming just for the eczema. Suppose patient is just coming for the reticular vein. Then we can decide what maximal cosmetic result you have to give to the patient. Etiological factor classification, why it is important? Because if the patient has a great reflux at the perforator level, you have to decide that unless until you do the perforator reflux ablation, whatever procedure you do, it is going to recur. Anatomical distribution. Anatomical distribution, why I am saying is, with the chronicity of the disease, the vein is going to become more tortuous and tortuous. It will lose its anatomical plane. The vein is going to lie in the superficial plane, deeper plane, and it becomes even just beneath the skin, that even a trivial trauma is going to start a bleeding. So this important aspect has to be kept in mind. So C1 is just a reticular vein. C2 will be a profuse dilated vein. Above the level of C2, you can start the various procedures or the surgical treatment can be offered to the patient. This is C4A, where you can see because of the chronic venous inflammatory markers, there are skin changes which can be seen at the cuticular level. Clinical classification, over the period of time, it becomes progressive. It involves the skin and subcuticular spaces, and later on the color of the skin gets changed. Then there will be development of the venous ulcer, and it becomes more progressive and chronic. So this classification is very, very important to decide what type of patient, what is expectation from patient, and what we are going to offer to the patient. Now, why we need a treatment? If you do not treat, what is going to happen? Because for C2 patient, if he is coming to us, he will say, I do not have much of the problem. Will it be sorted out on just the compression stocking? But over the period of time, if patient regains weight, if patient is a surgeon, if his occupation is such that he needs to stand for 12 hours, then in such situations, he can develop a progressive disease. Sudden, with the trivial trauma, he can have a bleeding and multiple entities, by which you have to explain to the patient that these are the probable things by which you can land up into trouble. Now, a duplex scan. The duplex scan has actually made our job simpler. Why? Because as a surgeon, as a radiologist, or as a team, unless until you know how to perform the duplex scan, the surgery, whatever you are going to offer, is going to land you into trouble. Duplex scan is nothing but the venous map just beneath the skin. You try to sort out, you try to trace the GSV from ankle at the level of the junction, where it terminates into the common femoral vein. Now, why this duplex scan is important? One, it is going to give you a clear-cut anatomy. Second, it is going to give you the anatomy of the deep vein. Third thing, it is going to give you the system, arterial system, whether it has some problems or not. This has to be done always in standing position. If any surgeon cannot able to do ultrasound by his own, he will try to learn over the period along with radiologist, form a team, and then you can sort out that how this duplex scan is going to help you. Now, the second thing is, after duplex scan, is vein mapping. When patient is more obese, when the patients are more chronically diseased, on table, you may not have answer for every varicose vein. So before subjecting the patient to the surgery, prior hand, one or 2 hours prior, ask the patient to stand, ask the patient to walk, then do the anatomical markings or whichever, because once patient lie down, this venous distension becomes flat and you do not know because of the tortuosity how to go inside. Obese patients are going to give you more trouble because they have a chronic inflamed skin. The subcutaneous tissue is quite edematous, and so mapping is very, very important. Now, recent management, it comes under the heading of there are various options you can give to the patient, like compression stocking. Is it the only treatment available? Yes, it can be offered in the pregnant patients till she will get rid of the pregnancy. Sclerotherapy or the foam therapy, yes, it is one of the treatment for the reticular veins. Then surgery, radiofrequency ablation, laser, steam ablation, microwave ablation, MOCA, glue, and the high intensive focused ultrasound. So these are some of the recent modalities under which we are going to discuss. EVLA, the endovenous laser ablation, this is one treatment which is minimal invasive treatment, has revolutionized the face of varicose veins. This 1470 frequency laser machine, it has a good absorptive capacity at water level. It damages the intima of the vein. It damages the epithelium of the vein, by which it gives the occlusion of the vein totally. It has around, as compared to other methods, 95% closure of the vein wall is seen with this. How to perform EVLA procedure? Now, endovenous laser ablation is a procedure by which, by doing a puncture at the GSV under the ultrasound guidance, you are first putting a guide wire inside. Second, by putting a guide wire, you will put a sheath over it. After putting the sheath, you will pass the laser fiber. This laser fiber, although it looks simple, if the case is clear-cut truncal dilatation, only the trunk has been, venous trunk is well seen, then it is okay. But there are situations where the tortuosity of the vein is there. There are situations where there is a segmental occlusion of the vein because of the repeated trauma. There are situations where before forming a complete thrombus inside the vein, there are small plaques which are fragile plaques, and these are going to give a carbonization during your endovenous laser ablation. So such small things you have to think of. That is why ultrasound guidance is very, very important. The fourth thing is, after you insert your laser fiber inside, try to mark it along the path when it goes to till the junction of the femoral vein, so that it becomes easy to give a tumescent anesthesia. The equipments required: the laser machine, the laser fiber, various sizes of the needles for the puncture of the GSV. Now, if the venous diameter is more than 5 millimeter, the puncture will be very, very easy. But if the venous diameter is between 3 to 5 millimeter, it is going to give you a lot of trouble. So in such situation, you should have 1 or 2 extra sizes needle in your hand, so that you can decide that which is okay for which vein. Equipments are routine trolley, but along with it some glass syringes, because the foam which you, whichever you are going to prepare as a foam sclerotherapy, it will have a least friction and the foam cannot leak out. So the OT setup, here the patient, both legs should be exposed. Which anesthesia? It can be done under local anesthesia once you have performed 20 procedures, or it can be done in a spinal initially. It can also be done in the femoral block nowadays. The complete foot has to be covered along with the upper abdomen or the scrotal area, above the scrotal area, you can cover it. You first thing is perform the Doppler on table. Now, aseptic precautions are very, very important. Here, whatever ultrasound probe you are using, you have to use it in the sterile camera sheet, because repeatedly you are going to assess it. So this is a short video of how endovenous laser ablation should be done. Endovenous laser ablation, the first thing is, by under ultrasound probe, you will take a first puncture with a 18 gauge needle. Once you have taken the puncture, you will insert the sheath Once the sheath has went inside, you will select, depending upon the whatever laser machine you have, there are various laser fibers. There can be round tip, double radial, single radial. Double radial will give a good grip on the venous wall so that the even distribution of the laser energy can be done. This is the progression of the laser fiber inside. This laser fiber, once progressed, you will reach up to 2 centimeter below the junction. Now, although this looks easy while passage, but there are certain situations where there are plaques inside the vein, where there are certain situations where the patient's skin is very much edematous, inflamed. In the vertical view and in the transverse view, you will see the laser fiber differently. That custom of the radiological image has to be with time. So these are some of the important factors. Once you have assured that you are 2 centimeter below the junction, you start the energy release of the laser fiber. This can be calculated. Whatever the foam generation or whatever the energy release you can see, it is going to completely occlude your vein wall. While retracting the laser fiber, you could know that whether our vein has closed properly or not. On table, you can see. Now, whether you can do bilateral EVLA at a time. Yes, bilateral EVLA can also be done at a time, depending upon the risk factors. If patient is a chronic smoker, if patient is a chronic obese patient, if patient is on antiplatelet drugs, if the patient has been underwent a bypass or some cardiac stenting, these are the risky patients where you should be selective. But if the patient is young and straightforward truncal varicosity, yes, bilateral can be done. Now, while progression of this EVLF laser fiber, the beam of light, depending upon whether patient is a thin, thick or very obese, this light is going to define you. Are you in a correct plane or not? Have you missed the plane? There are certain situations when the vein is very, very edematous, when the vein is very fragile, this fiber can turn the vein wall and it comes to lie suddenly into the subcutaneous place. And if suddenly you have released the laser energy, it is going to give you a big burn to the skin and surrounding area. So even though it looks very simple, but every patient is different depending upon the obesity and the various chronic factors which are seen. So what at our center, what we do is, after taking the puncture, we see whether this laser fiber is going smoothly or not. We mark the passage with either betadine or methylene blue so that it becomes easy to give a tumescent anesthesia after insertion of the laser fiber. Post-EVLA actions. Now you have completed the procedure. What next? The next thing is, on table, you can assess by ultrasound probe whether there is a complete occlusion of lumen or not. Second thing is, what is the maximum energy which you have used for the length of the EVLA procedure. And third thing is whether the carbonization of the laser fiber is there or not. So by doing carbonization is one aspect, as we are surgeons, we are used to it, that at the cautery tip also we get carbonization. Such carbonization is also seen over the tip of laser fiber, and suddenly the aiming beam of the laser fiber is lost and the laser energy release for the venous wall will be getting lesser and lesser, and there will be failure of ablation of the vein. So carbonization, if and if it occurs, if it increased in size, it can have a venous, the laser fiber can get entangled within the lumen. In such situation, take a mini incision, take out the laser fiber, clean the carbonization. During this release of carbonization, there are chances that you may have the breakage of the glass tip of the laser fiber, and ultimately the fiber will go west. So these are small tricks which are very important while we are offering this surgery to the patient. So follow-up schedule, radiological evaluation, clinical evaluation, this is very much important. So contraindications, what are they? Pregnancy and lactation, yes, the conservative should be the best. Obstructed deep venous system is the only major contraindication. For that, every surgeon should know what is the duplex scanning. because even though radiologists have done the scan in a hurry, you cannot miss it as a surgeon. This is going to land you in a disaster. So severe coagulopathy, inability to ambulate, tortuosity of the vein, acute superficial thrombophlebitis is a relative contraindication. So the complications of the EVLA. EVLA complications, they do occur at various levels. Like I said, it starts from the puncture. If suddenly, wherever you are taking puncture 3 or 4 centimeter below the knee, there is a big site of perforator, and here suddenly your fiber automatically goes into the deep venous system, which you can only diagnose with the help of the ultrasound. So venous perforation, induration, ecchymosis, redness, carbonization, skin burning. So these are various issues by which this is one of the post EVLA burn by one of the Ayurvedic colleague. It was posted in WhatsApp group, but such things can also occur. And if it happens, they are going to give a bad cosmetic result as well as the lifelong problems for the patient. So endovenous thermal ablation is a very safe procedure, minimal invasive procedure, although the cost of equipment is high, but it going to give the 95% occlusion. Sclerotherapy is one of the treatment where only reticular vein, very minor superficial veins are there. And this is one of the treatment which can be done at every center. Only thing is you have to see whether the patient is having the expectation of maximal cosmesis. In such situation, you can give a prior idea to the patient that yes, cosmetic results can be achieved, but we are not beauty parlorists, or surgeon becomes a cosmetic surgeon at such level, and we should have a patience that even patient doesn't expect to have a minor reticular vein, so you can offer her the CLAX-like treatment which can be offered at the higher center. The common concentrations used for the foam sclerotherapy, depending upon the size of the vein, various concentration are available. But in India, such concentrated NDTA solutions are costly. We get only 3%. And these, once you become the percentage specific, the cost of the injection increases. So we Indians have our own solutions to our problem. So 3% we can dilute it into the 0.3%, which is not traditionally available, but we can make it with the help of anesthetists. So sclerotherapy is one of the treatment by very easy, but if patient is not willing for EVLA and she has to be subjected, then such procedure can also be done with a good result. But only thing, it has a high recurrence rate. So this idea has to be given to the patient that under the UAG guidance, this can be done, and recurrence can be there of around 40% cases. So advantages of the sclerotherapy is UAG guided is mandatory if the veins are not well seen. It is cheaper, faster, and it can be used as an adjunctive treatment for the EVLA where our laser fiber cannot reach. Now, this was a 25-year male presented to my OPD in the corona period. He lost his mother and father with the corona. He came to me that he has to be interviewed for the CRPF. And in CRPF, he was rejected. And his next interview level was 8 days after he met me. So he said me, madam, give me instant solution, whichever can be possible. He was not at all affordable. So what I did is 8 days period was the minimal period for a surgeon to give a good cosmetic result, which can be selection for the candidate. Now, what I thought, I have explained to this guy that if you don't do anything, 100% chance that you are not going to get a job. But if you are going to take risk 50%, I will take the risk 50%, we will go ahead. Then I decided to go with the only foam therapy. And you will not believe, with just a local prick at the 3 centimeter below the knee level, we have done the bilateral foam therapy under UHG guidance. He was kept for 2 hours in the hospital. And after that, suddenly next day, you can visualize, this is the first post-op day. and this is the post-op day 2. So for these next 8 days, I used to call this candidate. Next day, on the 3rd day, I have started him on the newer anticoagulant treatment also. We used to give him the hot fomentation, the compression stocking, the leg exercises, leg elevation, application of the glycerin pads, and he suddenly on the 10th day, he came to me with his interview and the certificate inside the hand that, madam, I got the job. So these are very remarkable results if you think, but it has high recurrence rate also. But if you select properly for a proper candidate, yes, foam sclerotherapy is also good. The contraindications are the patients who are having restricted mobility, arterial insufficiency, allergy to these injections, and patient on anticoagulant is relative contraindication. Now, phlebectomy. The third option, first is EVLA, second is the foam, third is phlebectomy. Now, phlebectomy is one of the things where you have to think when the vein is not reachable with whichever energy source you are going to offer. This patient had repeated trauma and he bleeding through the venous lumen, and we have subjected this patient for the microincisional phlebectomy along with the other EVLA procedures. These phlebectomy hooks are required whenever you are planning, because with a single multiple 1 centimeter incision, you have to take out the vein by looping it all around the hook. So unless until you have this proper hook instrument in your hand, you cannot do. Now, this patient, he presented to me in such situation. You can see that he has superficial venous thrombosis along with the chronicity and the edema. So here, the option which we did is we have taken the incision, we have removed the superficial venous clots. After that, we have subjected him for the compression stocking, and after 3 weeks, we did the EVLA. So every case is different. Your selection should be such that it should be suitable for that candidate. Now,
Excuse me, ma'am.
yes.
You've already crossed the time limit. Could
Okay.
you please cut it
Yes.
short?
Yes.
Thank you.
Yes. So crossectomy is one of the new treatment where the recurrence of the varicosity, where you ablate 2 centimeter below the SFJ. Here at the level of SFJ, we start ablating. Steam ablation, radio frequency ablation, microwave therapy. These are some of the treatments, but these are costly. MOCA and non-thermal ablation, glues. These are one of the best therapies where which you can give instant results, but they have their own recurrence rate. HIFU is under the investigation. Cosmetic results like reticular veins, these can be subjected for the foam, but CLAX is a recent treatment by the augmentation we can do. Venous ulcer is a separate topic, but VAI, under VAI, we have started with the registry of the venous ulcer. And in this study, as a EC member of VAI, we are working on various parameters like what is the etiology, what could be the classification in Indian scenario. So my although I have been trained under the Professor J.F. Ulf from France at Mohali, but second training I attended at Dr. Mrs. Gore Madam and Rajendra Modi sir at Zain Hospital, and that has completely revolutionized my view about varicose vein. Thank you so much.
Thank you very much, Dr. Anjali, for an elaborate presentation. But I don't think because of short of time, we have any place for question answers. Thank you so much.
Hello. Thank you, Dr. Anjali ma'am, for nice lecture. I request Sima Sunu ma'am and Ajbay ma'am to felicitate Dr. Anjali. I request Ringoli ma'am to felicitate Sima Sunu ma'am and Usha Gajbi ma'am. I request Rajan Relikar sir to give a next lecture, solitary thyroid nodule. I request Uday More sir and Rajendra Shinde sir as a chairperson. Dr. Uday More sir and Rajendra Shinde sir.
Good afternoon, everybody. It's my pleasure to introduce Dr. Rajan Redekar, Honorary Associate Professor in Surgery at RG Medical College and CSM Hospital, Thane. And he is also a very active member of EC Masi of our state 21-24. Over to Dr. Redekar, who will speak on thyroid nodule.
Respected chairpersons, at the outset, I thank Dr. Raja Ganeriwal and his team for arranging today's meet and for giving me this opportunity. My topic is of clinical interest, that is solitary thyroid nodule. Most of us are dealing with this clinical situation in our clinical practice. And majority of the solitary thyroid nodules are benign. But our main task as a clinician is to differentiate benign from the malignant. And most of the time, this task is not difficult, but at a times, with careful clinical evaluation, use of investigation based on the recommendations, we can come at the reasonable success. Now, solitary thyroid nodule is a discrete nodule present in otherwise impalpable gland. But when this nodule is present in a setting of generalized mild nodularity or a palpable contractile lobe, it becomes a dominant nodule. And when you detect the nodule on a neck imaging done for some other indication, that is a incidentaloma. Now, this panel is showing the example of dominant nodule and the other one is solitary nodule. The prevalence in a general population is 4 to 7%. This increases to up to 19 to 68% on a high resolution ultrasonography. It is 4 times more common in females with a risk factor, iodine deficiency, advancing age, cigarette smoking, and obesity. Point of relevance, reported incidence of malignancy is 7 to 15%, depending upon the age. It can be seen below the age of 20 or above the age of 70. Common in males, family history, and some other factors. So benign nodule can be because of simple, it could be colloid nodule, it could be a thyroiditis of any form, simple cyst, or it could be a adenoma. All primary malignancies of thyroid can present as a nodule with a malignancy. Rarely, there can be secondary in this nodule arising from the breast or the renal carcinoma. The first step in management of STN is careful family history with emphasis on the family history of thyroid cancer or multiple endocrine neoplasia, history of childhood irradiation to assess the functional status of the gland, presence of any pressure symptoms, morphological features of the node, and presence of any lymph nodes or mets. In clinical itself, there are some indicators which point towards the high suspicion of malignancy. Family history of thyroid cancer or medullary carcinoma, rapidly growing fixed nodule, nodule presenting with the paralysis of vocal cord, presence of any regional lymphadenopathy or METs. On the other hand, some pointers have a moderate suspicion, like age, male gender, history of radiation, nodule more than 4 centimeter and partially cystic nodule, and presence of any pressure symptoms. Now, what is the relation between the irradiation and the thyroid cancer risk? Definitely is one of the risk factor. Usually irradiation is given for Hodgkin's lymphoma or bone marrow transplant, or maybe exposure from the environment like Chernobyl incident. Suppose if you are dealing with a nodule with a history of irradiation, there is a 40% chance of it being malignant, and it is mostly papillary carcinoma of thyroid. Interestingly, there is something called the rule of 12, where we can express the risk of malignancy as a factor of 12. The risk is more in solid versus cystic, more in males versus females, and more in the solid versus cystic lesions. More common in the isolated lesion as compared to dominant lesion. So all these factors can be expressed as a factor of 12, 24, 6, 3, etc. Now, after doing clinical evaluation, the investigations would be thyroid profile, imaging studies like sonography, scan, fine needle aspiration cytology, and sometimes we do tests like calcitonin for the medullary carcinoma of thyroid, antibodies for the Hashimoto's thyroiditis. The first investigation would be thyroid profile. And if the serum TSH level is below normal, indicating hyperthyroid state, the 10% of nodules are likely to present with hyperthyroidism. And if the TSH is normal, that is a euthyroid, or elevated, indicating hypothyroid, this can be associated with the cancer of the thyroid. So what is the risk? If you look at the scan, hot nodule, chance of malignancy, just 1%. For all practical reasons, they are benign. Warm, risk is up to 1 to 5%. It can be just a functioning adenoma. But in cold nodules, the incidence goes up to 15 to 20%. The guidelines given by the American Thyroid Association is that thyroid scan is only indicated in patient having hyperthyroidism. That will tell us whether the nodule is dominant, the autonomous nodule, or whether it is a part of the multinodular goiter that is hamper functioning. Now this is a representative slide showing the normal scan. In clinical practice, we do it with the technetium M99 or radioactive iodine I-131. You can see the uniform uptake by both the lobes. This is a typical example of the cold nodule where there is no uptake. Hot nodule. And this is autonomous nodule, which takes up all the radionuclide, and the remaining gland is not visualized. Once you get your scan report, if it is a hot nodule indicating hyperthyroid state, it will go for antithyroid drugs to control the toxicity. And subsequently, you can offer surgery or in appropriate clinical setting, radioactive iodine ablation. The remaining two will go for the sonography. Now about the sonography, which is the most important imaging study. This study will provide you with the characteristic of the parenchyma as well as the nodule. It's a sensitive study to comment on the lymph nodes and advantage of doing ultrasound guided fine needle aspiration cytology as well as aspiration. Easily available. So now, after doing sonography, the sonologist will report in a particular format. American Radiological Association has developed this format, TIRADS, very easy to understand. That is thyroid imaging, reporting, and diagnosis system. In this system, the 5 parameters are taken into account: composition, echogenicity, shape, margin, and the echogenic foci. Now, depending upon the finding, the points are given from 0 to 3 for each finding. At the end, these points, summation of this point is done. So you get a total number of points from 0 to 7 or above. The 0 point indicates TR1, that is a TR level, and it goes on increasing up to TR5. TR5 level means points more than 7 or 7, that is a highly suspicious of malignancy. So you can stratify your patient based on sonography finding and thyroid score from benign to malignant. Now, what are the features which really tell you that this could be a malignant nodule? Out of this, microcalcification, irregular margins, and lesion which is more tall than wide, these are more specific for the nodule being malignant. Now this panel will show you hypoechoic nodule. This will carry 2 points. So 2 marks will be given for this. Now this is a nodule. There is a rim of calcification around the nodule. This will also carry 2 points. That is a echogenic foci. This panel is showing the macrocalcification. This is showing microcalcification. Microcalcification is 3 points. And here there is a irregular border. So it will carry 2 points. So this is how the point system is there. Now, composition. This is a typical cystic lesion, and you can see a halo. If you see a halo around a lesion, it is most likely a benign lesion. If there are small multiple cysts, it becomes a spongiform lesion. So both are likely to be a benign lesions. Coming to echogenicity, hypoechoic, likely to be malignant. Then the shape. If the lesion is taller than wide, it is in favor of malignancy. Wider than tall will be benign. So you yourself can derive conclusion looking at the ultrasound plate. This is example of microcalcification, that is echogenic foci, 2 points. Now this is a classical case where if you add these points, the total comes 12. Total 12, that is more than 7, thyroids 5, thyroids 5 is high suspicious of malignancy. Now, one more dimension is added to conventional ultrasonography at many centers, that is a ultrasound elastography. Now, this may be useful when the ultrasound findings are not clear cut, or if the cytology is indeterminate, or it can be used for follow-up studies. The basic principle is that the benign lesion will be more elastic and green in color, while stiff lesion will be blue in color and they'll be malignant. So green, benign, and blue will be malignant. Here also there is the scoring system. We will not do details of that. Benign lesion, it will be more green, and malignant lesion will be more blue. So you can derive a lot of conclusion from the elastography. Now, we have got the sonography report and we have collated all the findings of sonography into form these patterns: high suspicious, intermediate, very low, benign. Cystic will be benign, and with the thyroid score of 7 or more will be high suspicious. So they will have 70 to 90% chance of malignancy. It will go down, and the benign will have just 1%. So based on this, we have got a size criteria for FNAC. If it falls in the high suspicious zone, even if the lesion is 1 centimeter, you have to do FNA. The remaining criteria is more than 1 centimeter. Now, after doing ultrasound and getting the adequate information and the probability of the malignancy, fine needle aspiration cytology is an investigation of choice for evaluating these nodules further. It has a sensitivity in the range of 65 to 95% and specificity in the range of 70 to 100%. Now, after doing this cytology, it should be reported on a system which is called as a Bethesda system for reporting thyroid cytopathology. It's a universal standard system. Now, what is this Bethesda system? When you get a cytology report, they will report something like this. First is a non-diagnostic criteria group. Second is benign. Third is atypia or follicular lesion of undetermined significance, AUS or FLUS. Fourth is follicular neoplasm or suspicious for follicular neoplasm. Then you got a suspicion of malignancy, and last is malignant. In Europe, similar system is followed with some minor changes. They label this as a Thigh 1 to Thigh 5. In this system, this group is clubbed together. 3 and 4 of American system is grouped. So that becomes a thigh group. Now, this Bethesda system of reporting will also tell you the risk of malignancy. In the first category of non-diagnostic or unsatisfactory, the risk of malignancy is 1 to 4%. While if you go down, if the FNAC reports a malignant lesion, chance of malignancy are almost 97 to 99%. So depending upon your reporting, if it is a benign, you can just do a clinical follow-up. If it is a non-diagnostic or something like ATP of undetermined significance, you can repeat FNA. Follicular neoplasm cannot be differentiated as a cancer or just adenoma on FNAC because you cannot comment on the capsular or vascular invasion. There, you can do lobectomy and histopathology. The remaining two groups can go for a surgery straight away. Now, this FNAC has limitations, like it is not a foolproof to rule out the malignancy. There can be sampling error. Expertise may not be available. Then there is a confusion between certain reporting, especially Bethesda 3 and 4. So to improve your probability, to improve the decision making and to avoid confusion, can you do anything else? Yes, there is one more study called as a molecular marker, which is nowadays available. These molecular markers use has been suggested by National Comprehensive Cancer Group. If the reports are positive, you can go for total thyroidectomy. If they are not indicative, you can keep the nodule under surveillance. Now, these markers are of 3 types: main topic, immunocytogenic, and epigenic. These markers should be used with care. This science is evolving. The cost is more, and it has also limitations. So guidelines say that molecular markers should be interpreted with caution and in context of clinical, radiographic, and cytological features of each individual patient. Worth mentioning, one of the marker that is a red gene marker, RET, which is studied in the familial medullary carcinoma or Main syndrome. If the red oncogene germinal mutation is positive, the family members of this patient can be advised prophylactic thyroidectomy to prevent medullary carcinoma. Then DNA study is also available. And nowadays, even microRNA levels can be estimated in a peripheral blood of a patient with thyroid cancer. This science is evolving and it may replace some of the newer studies. The few words about the thyroid cyst. 30% of the clinically isolated swellings are likely to be cystic. Most common cause for the thyroid cyst is either idiopathic or colloid degeneration. But point to remember that both follicular as well as papillary carcinoma of thyroid can present with cystic degeneration. The upper panel is showing follicular carcinoma and this is a papillary carcinoma. Now, how do you manage thyroid cyst? If it is a simple cyst, unechoic on ultrasonography, it can be aspirated and that will solve your problem. Surgery like hemipterectomy is indicated if the cyst persists after 3 attempts of aspiration or if the cyst is more than 4 centimeters in size and cyst with solid component, wherein it is preferable to do FNAC from the wall or the solid component. Friends, surgery is indicated in STN in a cases of proven neoplasia or some case of suspicious neoplasia, recurrent cyst, toxic adenoma, functional adenoma, pressure symptoms, cosmetic concerns, or patient's choice or preference. Now about the levothyroxine, some people give T4 as suppression therapy in the treatment of small benign or warm nodules. But American Thyroid Association clearly says that routine use should not be done in a patient's having coming from the iodine sufficient area because it has got a very moderate response. And you must consider long-term side effects of a subclinical hyperthyroidism on the heart causing arrhythmia, on the bone causing osteoporosis. The word of caution, if the patient is on thyroxine and if the nodule shows rapid increase in growth, it could be malignant nodule. So you have to reinvestigate that patient. Now another contentious area is about the frozen section. Sometimes we feel it's a good facility. If there is doubt, we can arrange for the frozen section, and on table we can get a diagnosis. There are proponents who say that by doing frozen section, we get a diagnosis on table, so we can avoid the second operation. We can go for completion thyroidectomy if required on the same sitting. So that will avoid the second anesthesia, second admission, second surgery, and complications related with the next surgery. But the opponents say that it has low sensitivity and low negative predictive value. It may not be useful in certain cancers like follicular cancer. There may be technical errors and comprehensive assessment may not be possible. It can add to the cost, operation room time, and expertise may not be available. So should we do or should we not do? Yes, it can be done in certain select situations where the good expertise and facilities available. Certainly, it can avoid two-stage surgery. And in some clinical settings where patient is high anesthetic risk, likely to not follow, poorly compliant, or some young patients or elderly patients, this can be done. There are newer techniques, better not to mention, because thyroid also will go away from a surgeon like us. So there are techniques where we can ablate the nodule, but they are mainly useful for the cystic lesion. So friends, let us recapitulate what we have discussed, that once you come across the case of STN or solitary thyroid nodule, first thing you assess the functional status by doing TSH levels. Accordingly, you can go for the scan. The next important investigation being ultrasound. Depending upon the findings, you can categorize patient based on thyroids as a benign or suspicious of malignancy. And the most important investigation would be fine needle aspiration cytology. There also, if the diagnosis is not clear cut, your choice of repeating FNAC under the image guidance, or you can do a standard simple operation of hemithyroidectomy, study the histopathology results, and you can counsel the patient for the second surgery for a completion thyroidectomy. And if the lesion is less than 1 centimeter or less than 2 centimeter, no capsulovascular invasion, that should be the treatment. So we have addressed both the contentious issue of molecular markers and frozen section. They should be utilized in a relevant clinical situation. At the moment, markers are basically in the setting of a research. Thank you, friends, for your kind attention.
Thank you, Dr. Rajan Redekar, for an elaborative lecture on solitary thyroid nodule. I think so. We are running short of time. So I request if there are any questions, please ask afterwards. Thank you.
Thank you, chairpersons.
Thank you,
for
Dr.
patient hearing.
Rajan Redekar, sir. I request Dr. Uday More sir and Rajendra Shinde sir to felicitate Rajan Redekar sir. I request Dr. Avinash Lawari sir to felicitate Uday More sir and Rajendra Shinde sir. I invite the next speaker, Dr. Pradeep Arora sir, on basic medico-legal defense in surgical practice. And the chairperson is Dr. Kaustubh Sarda and Dr. Atul Yadgiri sir.
Good afternoon. Now the session is by Dr. Pradeep Arora sir, and he will be speaking on basics of medical legal defense in surgical practice. It's a very interesting topic, and to introduce him in few words, he is a champion of 3 trades, that is surgery, and then he's a gold medalist in law. He did his LLB 2020, very latest. But before doing law, he used to contest his own cases in the High Court as well as Supreme Court. And the third aspect, which is mentioned in his CV, is that he's a chess champion as well. So these 3 things makes him a very formidable force, and we will like to learn from him a lot about his very upcoming interesting thing in the surgical practice. Dr. Pradeep Arora sir.
Thank you very much for the introduction. But when you have too many trades, there is risk of being jack of all trades and master of none. So I have modicum of mastery though of each one of them. So this is the subject today. And first of all, I am extremely thankful to Dr. Ganeriwal and Dr. Ingole for inviting me for this talk. And really the conference is very well arranged. I cannot say, I mean, I am really impressed. So thank you very much indeed.
Now, coming to the subject, basics of medical legal defense. I have macular problem, so I cannot, from here I can't work. Basics of medical legal defense in surgical practice. Now, semantics and words are very important in any, when it is anything legal. So defense means that I would not be talking much about the prevention part, because defense means the things that the suit has already started. Medical legal. Medical legal means that there is a law aspect to it, and very importantly for all of you, there is a medical aspect to it, and you must understand that medical legal suit is very different from any other suit, because the inputs from the doctor are more important, if not less, as compared to any other legal suit. So it's not that just you will retain the counsel and it is the end of it. If you do not remain actively engaged, and if you do not give inputs regularly and supervise this, you are the master. What lawyer more can ask for? If you don't take interest, he will take his fee and the outcome is your destiny. So naturally, the rat will play when the cat is away. So you have to take full interest, and we will be talking very elementary things, basics of it. Now, what is the common causes of medical negligence suit? Failure to diagnose, failure to treat timely and properly, the injury during surgery complications and post-operative complications, lack of proper consent. It has become bogus these days to say, "Mujhe bataya nahi tha. I don't know. I was not told enough." So this has become very important cause of legal suit, and medication errors. They are more common than you might like to believe, and are behind many medical legal suits. Whatever be the specialty of surgery, whatever be your specialty of medicine. Now, elements of medical legal negligence, more correctly speaking, definition of medical, there is a duty of care of doctor towards his patient, there is a breach and there is some damage, and there is some nexus between the breach and the damage. And fifth, which is less commonly known, that the breach that has occurred or the event that has occurred, that was foreseeable. If say something severe occurs during the course of surgery and you have investigated sufficiently, well, this is not foreseeable. And there are many events which happen all of a sudden. So if an event must be not foreseeable for it to be included in the criteria of medical legal negligence. Now, what are the jurisdictions? Criminal law, the patients can file FIR. FIR, now there is notification. I will come to that. Under 304A for gross negligence, 304 for, it's a very aggravating kind of crime. Very rarely this Indian Penal Code is invoked. When you have lower grades, 335, 330, I will not go into that. More commonly used is consumer law, that we are fighting against now, and civil law, the tort law, because consumer law only in our country is being done. Otherwise, in most of the countries, civil law. If judiciary is slow, we need not be penalized for that. And we are now subjected to a quasi-judicial summary kind of jurisdiction, that is consumer law. Now, State Medical Council, High Court petition, relevant in case of those government hospitals where patients are operated, have complications, they can invoke Article 226 for violation of fundamental rights in High Court. And then you have jurisdictions like Clinical Establishment Act, but that it is not in force in our state. And new nursing home rules 11G, you have provision of grievance cell where patient can go and report. Soon you will have these grievance cell in all municipalities. And Human Rights Commission, Women Rights Commission, Child Rights Commission, to complete the list. There might be few. Any case, any law suit, facts are important. And paradoxically, you will find that your lawyers are very poor at facts. And when it comes to medical legal suits, they are not able to grasp the facts. So that is one problem. So, but the facts is the first important thing, is of top importance. Then second is the substantive and procedural law. Your lawyer can do that. And in normal lawsuit, these two are good enough. The facts are to be supplied by the client. But here it is different. The main input is from your surgical subject. In fact, the facts are integrated with your surgical discipline so much that you can't separate the two. And if you don't take part, don't participate in your own lawsuit, it is harakiri. I show you that in 1 or 2 examples where case have been won, the doctors engage themselves fully. So if you get legal notice, if you don't reply, if you reply, then there is a fear that I will have disclosed my defense. If you don't, then he might be emboldened that he doesn't have any defense. So this is the dilemma. So what to do? You see, most of the time, the balance tilts in favor of not replying. Now, this is one advice which I will never give you because they want you to reply, only then they get the work. But then most of the instances, if you find that the complaints are not tenable or there is simple frivolity, let him be happy in that and don't disturb it. Don't tell him that he is wrong. Let this wrong be carried into court also. That would be better for you. Because if you will explain that, then he is going to find litigation is usually because of the type of personality and temperament of the patient rather than the actual aggravation. So there are certain types who are litigatory in nature. So they will go anyway. So, but if you find that he has put his best foot forward, then you should reply so that it might act deterrence. This will be true only in 5 to 10% of the cases. 90%, royal ignore, massive ignore. Now, next. Most important medical, if I ask you, you tell me one thing which is most important in medical legal defense. Just one term. So guess, can anybody tell me what is that term? Okay, that is Bolam principle. This is that holds the key to medical legal defense. This holds the key. This is all about medical legal defense. In one word, if medical legal defense is to be put, this is a golden word. Bolam principle. Bolam in 1957. Bolam must be turning in his grave because of this principle, he lost the case against Free Hospital Management Committee, where he was given a convalescent, which is given psychiatric, and it broke his bones, and he was not restrained, and he was not told about it, and he was not given any relaxant. All three. So the court said, no, this is normal practice. And you said that you were not told. You see, it touches the consent aspect also, that you were not explained about it, but then it is a common practice. Sorry. So there is no negligence. So you see, Bolam means that if it is a common average practice, then there is no. So these are the features in this. It applies to all aspects of medical performance, that is diagnosis, treatment, everything. Consent part also. And there is no negligence if the act is proper according to a responsible body of surgeons skilled in that particular art. Now, what is responsible body of surgeons? You are responsible body of surgeons. In fact, you can create your own local guidelines and you can crystallize them, put in piece of paper, have some kind of seal of common approval, and that becomes your guideline that can protect you in the court. This is what the position of law is today in India. I walk the talk, that's why I am telling you. So this is Bolam principles, that the medical law actually has been placed into your own hands. Now it is up to you how you do it. If you remain apathetic about your rights, if you don't make any guidelines, then when things go to court, the court keeps on marveling what it is, and then they pass judgment. And remember, case law is very difficult to undo. So case law is very difficult to undo. Most of medical legal jurisprudence is product of case laws. Legislature has never included medical field into the consumer law. It is only by case laws that it was included. It is only by case laws that it has become milder to harsher. What was supposed to be inclusion on the basis of in very simple cases like wrong site surgery, wrong organ surgery, etc. Now over nuanced, nuanced or controversial kind of situation where there might be any negligence, one gets a penalty, and very hefty penalty. So it is all case law, all court-made law, and if you are proactive, you can create guidelines to protect yourself. Now all it requires is ordinary skill and knowledge, not the one sitting at the top of the Clapham omnibus. That is not the person who is most expert, just the average, the laparoscopic surgeon average. What would be his complication rate? If he has injured bile duct, can average surgeon do it? Yes, in the books it is given. 2%, 1% will have it. So it is just inherent hazard. There is nothing to feel guilty about it if it has happened once in a great while, and if you have acted with good conscience with the patient. So mere complication is not negligence, and it is a peer review system. That is, you cannot, it is contemporaneous system. What negligence is today, what is okay today, may be negligence tomorrow according to contemporaneous time of that contemporaneous time. So when you will think retrospectively about something, you will think that those things which were available at that time, those procedures which were available at that time, and the standard of care which was available at that time. Now, Jacob Matthews, State of Punjab. If Bolam principle is the golden principle, then the gold mine of principles is the Jacob Matthews judgment. This is the Bible. This is the gold mine of valuable principles. One of them is Bolam principle. So it was explained herein. I have given you this. We will not go through this. It will be tedious. And then just to give you two examples, because gallbladder is one operation, so I brought two judgment pertaining to Supreme Court judgment. And this doctor did surgery. He found gallbladder very difficult. It happens at times, and he converted it. He observed the courtesy of coming out, interacting with the husband, and then he converted. She went from there. She was all right. She had retained gallbladder stone, which after a long time it was the resurgery was done, but that is separate thing. Her grouse was that why it has been converted. She didn't. She has not given that consent, although consent may not have given. Now we normally take precaution that we put this in the consent paper that, well, conversion is a possibility. Maybe that it was not there. So what does it mean? It means the crores of rupees. Is it? No. The surgery has not been changed. Only modality has been changed. So material was presented that this is a inherent risk, and sometimes surgeon is simply constrained. It happens so rarely, with certain expert surgeons, that they don't think that the patient will be unnecessarily scared. So scaring part I will come later. So the judgment was in favor of Dr. Jhunjhunwala, who converted in college. The Gurmeet Singh, he fought case himself. This guy, he injured bile duct, but then after that he gave the treatment very diligently. The patient was out of through. The patient improved, patient survived. There was no problem. But then, since there was bile duct injury, the case was, again, this was in National Consumer, this judgment was given. They had learnt from earlier experiences. So National Consumer Court again here said that there is a three times higher risk of bile duct injury laparoscopy. Now she is saying something else, that why he did laparoscopy if the chances of bile duct injury documented are more. Now, National Consumer did not allow it and said that maybe overall judgment has been taken by and this is an approved modality of doing it. He was doing accordingly, and there is no reason to think that there was anything immoral, unethical, or intentional behind it, or there was any lack of diligence. So it was done, but inherent risk is more, but there are many benefits also, so he cannot be blamed. So when you will present your make submissions, Bolam principle, what is Bolam principle? Bolam principle is that you will submit the material in form of textbooks. They write textbooks more paradoxically as compared to journals. The reason is that courts think that in textbooks is the ultimate distillate information which comes, which is really average, which is really ordinary. In general, you may have very expert body of professionals who might be doing a special procedure, and in textbooks it comes when it is ratified by many studies, and then it comes. So they rely on textbooks paradoxically more. So the day has come, you go back to your Lavant Valley, take it up and show it there. So standard guidelines, I have talked about it. Now, expert opinion and witness. You can take experts in the field. You can take, your rival can also take. Now, what is expert opinion witness? It is again extension of Bolam principle. When the expert will give advice to what is normal standard or normal standard of care according to the specific facts of that case, not a general statement. So general statement can be found in textbooks, but the facts of each case are peculiar, specific. So in that context, the need of expert witness is there. So that is also now assumption of risk. Like I said that now normally, many times patients are saying that, I was not told enough. So this is the assumption of risk. All you have to prove is that the patient knew about the risk, and even after knowing the risk, he gave the consent. Now, after this has been done, there cannot be any criminal liability, because according to section 88 IPC, once he has been told about the risk, anything is done with, and the intention to harm is not there, there can be no criminal liability. But the question is that we have to take informed consent or real consent. Most of the people would say informed consent. Unfortunate, there is lack of information there. What you require according to our law, which has been given by Supreme Court, 3-judge judgment, which holds lot of binding power, that is real consent and not informed consent. I cannot stress this point more. So what is informed consent? Informed consent is, it is Canterbury, Reedberg, Australia, Canada, and America. All of them are following informed consent. In our country, informed consent is only for clinical trials. In our country, is a real consent, which is doctor-centric. Informed consent, what a prudent patient would want to know. He would not. He may want to know about inguinodynamics also. He may want to know about properitoneal approach also. He may want to know about all varieties of mesh also. Supreme Court said all this is not required here. Our patient will be scared away. You can customize your information, the disclosure, which is to be given to the patient according to his needs, educational needs, social needs, whatever. But then you have to answer every question, and you have to essentially cover what needs to be covered. If a patient comes to you with gallbladder, it will be crime not telling him about laparoscopic surgery. But if a patient has come for hernia and you are not doing laparoscopic surgery and he is not demanding it, and there is I am not saying just like that, there is a case law behind it. Court said no, there is no negligence in not disclosing that hernia can be done by laparoscopy also, right? So, but then if patient asks you that laparoscopy mein hota kya, then if you withhold information, or say it is prolapsed rectum and young patient is saying you that, sir, choose the procedure you are doing, you said that you will put mesh behind my prolapsing rectum, but please do a procedure which doesn't affect my sexuality. I am at the verge of marriage. Now, if you don't tell him what can happen after posterior rectopexy, and maybe anterior rectopexy and perineal procedures are better than this, maybe at the cost of little more recurrence, then you are immoral and you are doing something illegal and unethical. So morality would, only thing is that you can take liberty to what extent you can explain, but then you will have to defend everything if your action is called into question, and it must be clear that you have not done anything, you have not taken a shortcut for personal gain. So with that caveat, you get the liberty. Now, Samira Kohli, and this is the repository of law on consent in our country. This is the judgment. You read this judgment. You read Jacob Matthews, and Jacob Matthews just, 50% of the medical legal defense. You read Samira Kohli judgment, you know another 20%, right? Just these two. So Samira Kohli judgment, it talks all about consent. It is for the doctor to decide. The discussion is with doctor only. With reference to condition of the patient, nature of illness, and the prevailing aesthetic practices, how much information regarding this and cost. So I will hurry through. Consent in surgical practice, I have told you all this. Now, circumstances of case, this is yet another important criteria, that if you, in corona period, like oxygen was not available, if patient dies of hypoxia, it won't be negligence. So recently, one judgment has become viral, that death of the patient, doctor cannot be at negligent just because operation theaters were busy and gangrenous limb could not be operated on that day and patient died as a result of that. The court said, no, this is not negligence. So circumstances are very important. Most of the times we don't register, don't submit in our submissions that their circumstances were such. In mass casualty, not doing something would be different than in ordinary course. So these are the various, these are self-explanatory. Contributory negligence is when you have operated and patient gone home, he takes alcohol and lot of food, and then either the wound burst or something happens to the intestine. So this is contributing negligence. That is, your patient is responsible. Expert witness I have talked about. Citations, references. Citations are given by lawyer, references by doctor, and complaint medical violence is there. Please register FIR. It may be a good bargaining tool if your case is weak. Now, res ipsa loquitur means things speak for themselves. If the death is wrong side surgery, wrong person surgery, or say foreign body left in the abdomen, this is res ipsa loquitur. Jacob Matthews, again another gift. It has reprimanded the other courts to not to deploy this doctrine too much. In every DOT, they say it is res ipsa loquitur. That is not the case. That is not to be done. So you have to go into detail that how much it helps you. But this is one. Then, if there is a FIR is to be filed against you, there is allegation of 304A. Then now National Medical Commission and earlier Jacob Matthews, the third gift from the Jacob Matthews, that a inquiry committee must be there, competent opinion of doctors who are in government service and are from same specialty. Like if accused is surgeon, there got to be one surgeon in the committee, and they should apply Bolam principle, and only cases of gross negligence shall be shall go for FIR. Then you have 304, which is appalling IPC. Sometimes it has been slapped on doctors also. This was in case of Ratnagiri gynecologist when they prescribed medicine on phone, and then because of pulmonary embolism, their patient died in the same evening. Then committee perhaps gave this decision that since prescription was not given without examination, that's why this accident had happened. As a result, 304, which carries 10 years of imprisonment in contrast to 304A, which carries 2 years, and 304A is eminently bailable, whereas 304 is not bailable. And they went to Supreme Court, and there what association should do and what I did in this, that I impleaded in this case in the Supreme Court and made submissions 100 pages. That at that time telemedicine was yet to be a law, and it was in 2018. And then I gave Bolam principle again, that it is being done in world all over. What is the problem? How regressive it is to say that if somebody has not seen the patient, not touched the patient, then it is culpable negligence. Culpable means 304. It is ridiculous. So yes, I was intervened. It made a history because in criminal case, you are normally not given intervention. Subramanian Swamy when did Nirbhaya, or when Amanullah Khan, this is another case, they did from the side of victim. From the side of accused, this was the first case that anybody was given in impleadment. Because from accused, it is very difficult to say them. What you are practically saying to the court, I would have done the same. I do the same. I give the instruction on the phone. So what? If she is, you have put 304 of them, then everybody is guilty here. So, I mean, the foolishness was going on. So I had to implead, and they were granted bail value. Association is our fundamental right. It is a fundamental right under 19(1)(c), the associations that we have. And we are office bureau. Flocking together is in our evolutionary history. It is innate, it is inherent, it is ingrained on this, it is visceral. And in every species you will find this, because you can look for food better, you can protect yourself better, you can hunt better. Wolves, 360-degree view they take and they make strategy. So making association is our birthright, and association should have a litigation center where they should be dealing not only with this medical legal defense and malpractice suit, but whole range of medical legal issues, including the medical laws and the fundamental rights of doctors. He was a very lawful man, law-abiding person. He obeyed all the laws which he made himself in Germany. But the problem was that these were bad laws. And there is another man who broke all laws because those were bad laws, and the laws were made by the oppressor. Now, in these times, we are somewhere in the middle. We have attained freedom. We have to respect the Constitution. And within the scope of Constitution, we must be law protester when the law is bad. And here in Supreme Court, I am fighting the case for COVID widows who didn't get 50 lakhs. Now we have come to this turning point in the history. Against Consumer Protection Act inclusion of doctors, the Bombay High Court has dismissed the petition and SLP has been put in the High Court. I am writing another SLP. 13 associations have associated with me and other associations should also come. This was one of the agenda for me coming here. Academic involvement, being absorbed in core academics is okay, but huge problems cannot be ignored for long. So my dear friends, Bolam principle is sheet anchor of medical legal defense in surgical practice. The real consent and not informed consent is required. Circumstances of the case under litigation is often ignored. SC judgment of Jacob Mathis and I will add Samira Kohli is gold mine of medical legal defense, and association should impede in fighting bad laws concerning medical legal defense. You take out CP away, that is the best antidote to medical, that is the best support to medical legal defense. Thank you very much.
Thank you very much, sir. That was a very great, insightful talk on the current practices, which in view of society turning into more litigant society. And there are so many areas in law as well as medicine which are watershed areas where there are full of contradictory judgments and contradictory case laws. Then to share a small example, in Amravati city, without taking his name, 40 years of general practice. After that, he was accused of rape by a female patient who was young, and he had to pass through so many bad things. That is an experience in itself. But in view of that and so many things, I mean, this was a very less time covering this vast topic. Any questions from the audience, please?
Yes, I can hear you. While taking consent, you are asking because of that RG Stone, Vinod Khanna versus RG Stone judgment from National Consumer Court. No, you know that the stay has been put on this. And again, Bolam principle. In fact, there was a slide on it. I removed on way to Amravati because there were too many slides. And again, I overshot time. Yes, that is the pre-printed form will continue. This is right now. This is the position.
Sir, can we use technology for the consent? That is audio-visual recording of the consent process.
It is double-edged sword.
Okay.
It's double-edged sword. Because then your whole, if you produce that, right, then you are also under scrutiny. The rival party may take advantage of it, that he didn't tell this, he didn't tell that. And you know this, that you are more vulnerable than the patient. So I will not advise it. Although some people are doing it, but you can do it, but just keep it with yourself. If you think, you may produce it or you may, but actually it is not legal if you don't warn the patient when you're that we are taking this interview under CCTV and this must be part of the recording when you produce. So we are both are otherwise, you are unequal. He doesn't know, he's off guard and you are taking all the precautions. So court would not accept that.
Thank you, Pradeep Arora sir, for nice presentation. I request Dr. Kaufso Sada sir and Atul Adgir sir to felicitate Dr. Pradeep Arora sir. I request Dr. Dagwar sir to felicitate Dr. Kaufso Sada sir and Atul Adgir sir.
progress in life. This is a famous marketing slide. This is called the bridge over the river Cholatuca. In the southern American country of Paraguay, a municipality built this bridge, not realizing the river was changing course. This may also apply to our own careers. If we don't see the way surgical science, maybe I think Niranjan is going to speak on lasers in surgery. I'm waiting to hear what it is. But whatever it is, if we don't keep ourselves abreast of changing science, we are going to be like this bridge left around. We all know Nokia, one of the most blue chip companies of the world, had to be shut down. And the famous words he said was, "We didn't do anything wrong, but somehow we lost." These were the last words at his press conference when the entire board of Nokia resigned and was taken over by Microsoft. We didn't do anything wrong, but somehow we lost. Think about it from your own life. I think for a young resident here, I think this is, what do you?
कामयाब होने के लिए नहीं, काबिल होने के लिए पढ़ो. सक्सेस के पीछे मत भागो. एक्सेलेंस का पीछा करो. सक्सेस झक मार के तुम्हारे पीछे आएगी.
In life, I've realized that we often make excuses. I'm busy in practice. I've got commitments. I have financial problems. But whatever you are not changing, effectively you are choosing. Read that again and think about what I'm saying. If you choose to be where you are, it is by your own personal choice, not by circumstances that make you happen. If one does not know which port one is sailing, no wind is favorable. And this is my favorite man who I look upon as a role model, which in life. And I think some of you young people who are beginning in your career, important that you define your vision and work towards it. It's very likely you may not achieve all that you wanted to achieve, but not for lack of trying. There is something called the Dunning-Kruger effect. When I see young surgeons who come fresh out of a bariatric or a minimal access or robotic program, they feel they know all surgery. And you can see them in conferences asking questions, sometimes inane questions, just to show that they are smart. And I call this peak amount stupid. As time goes, they realize with some gray hair or no hair, they make mistakes, they get complications, and they come to what I call the valley of despair. And some of them will have enlightenment. Some of them remain stupid, but some of them will get enlightened with time to the plateau of system. This is the Dunning-Kruger. This is not what I am saying. This is what the American Psychological Association said in 1971. In a position paper or any new technology, they said this is what is called the Dunning-Kruger effect. Atul Gawande, I think he's been to Nanded, very close here. And I think this is something that every young resident, a fellow who joins me, is given this book. And I make sure they read this book, the Checklist Manifesto. We all think we are competent. I think I'm a reasonably competent laparoscopic surgeon. But there is a circle which you actually know, and there is another circle outside which they think they know, but they don't actually know. I think I know everything. I can do as good as Raj Gajvi in bariatric. I can do as well as Dr. Jatkar in trauma, but maybe in some things I am good and some things I'm not so good. And you need to identify what is the second circle around your primary area of core competence. So how to improve yourself as a surgeon? Define your perimeter of circle of competence, slow yourself down, work to expand the circle, and never fool yourself. If you think that you don't get complications or you are doing well in life, please, something is wrong with you. Read and learn from other people's mistakes. There is no urgency in life. You will achieve what you want to do if you are fixated on outcome. If I fixate on saying that I'm going to be the best laparoscopic surgeon in the country, I may not make it, but I may come to 99%. That is fixation on the ultimate. Don't get bogged down by information overload. I think as surgeons, access to YouTube, access to net, we have so much stuff coming on. Be very clear what you will accept, what you don't accept. And I think lasers in anorectal surgery is a good example. I think you need to separate the wheat from the chaff, understand what is a marketing tool and what is scientific basis. Have a good work-life balance. And I'm the last person to tell you about this. I've had the worst work-life balance of any of you in this crowd. But think about this. This is a book called Ikigai. There's an island in Japan where people live almost the year of 90 years. And this book is a wonderful book. It's called Japanese Secret to a Long and Happy Life. It defines why these people on this island in Japan actually live that long. It analyzes their sport, their life, their food. And this is the spoof on that is Ikigai. आपल्या आयुष्यात आपली इतकी घाई असते ती इकिगाई कधीच होत नाही. For the youngsters in this audience, don't compare your chapter 1 to someone else's chapter 20. If you are 5 years out of MS, don't compare yourself with Dr. Mapari or Dr. Gajbie. This is chapter 20 in life. Wait, your time will come. The goal is to improve yourself, not to compare yourself to, you want to be the next Dr. Palnivelu, I understand, but don't forget the troubles and challenges that they've had in life to come to where they are. So never compare your chapter 1 to somewhere chapter 20. Have some kind of spiritual basis in life. I think a lot of my change, I think I've changed a little bit for the better, is 12 years मी वारी करतो. पंढरपूरची एकादशी वारी करतो आणि त्यात थोडंफार माझे पाय थोडे जमिनीवर आले त्या वारीमुळे बघून इतर लोकांना. पण काहीतरी आपल्या आयुष्यात एक स्पिरिच्युअल, आय एम नॉट सेइंग रिलिजन, spirituality, philosophy, call it what you like. You must have something beside that in your personal life to complete yourself as a human being. I think all of us surgeons are like jugglers with 3 balls. One ball is your professional life, one ball is your personal life, and one ball is your social commitment. It is almost inevitable that one ball goes higher. In my case, the professional ball is very high. The personal life and the social commitment always suffers. So you need to define for yourself what the ideal balance is when all the balls are adequately in the air and you become a complete human being and you give back to society what society has given you. TME is not the TME plane of seer rectum, it is time, money, and energy. You need to define what you have and what you are likely to be. This was Steve Jobs giving a
you
graduation
can't
ceremony.
connect the dots looking forward. You can only connect them looking backwards. So you have to trust that the dots will somehow connect in your future. You have to trust in something, your gut, destiny, life, karma, whatever, because believing that the dots will connect down the road will give you the confidence to follow your heart, even when it leads you off the well-worn path, and that will make all the difference. Your time is limited, so don't waste it living someone else's life. Don't be trapped by dogma, which is living with the results of other people's thinking. Don't let the noise of others' opinions drown out your own inner voice. And most important, have the courage to follow your heart and intuition. They somehow already know what you truly want to become. I wish that for you. Stay hungry, stay foolish.
Many times in life, the career path you choose is extremely important. It depends on whether you choose the avenue of soothing applause or the trail of prickly criticism. Think of this carefully. It is very easy to follow on the... I give an example to my fellows when they leave my hospital, having worked with me for 2 years and go into practice. I said, practice is tough. There are GPs, there are consultants, there are pharmaceuticals, there are many things in life. It is your choice. And I also tell them that none of us is white or black. We are all shades of gray. If you think I am white, I am not. We have to choose what shade of gray we want to be. We all need to draw a line in the sand, how much we will bend and how much we won't bend. So this is important. The trail of prickly criticism often will pay you in the long term, but you need to pay in the short term. This is another thing I tell young people.
In this video, I'll share with you the life of an entrepreneur. The life of an entrepreneur is a tough one. It is a life of struggling. It's a life of fighting. It's a life of pushing and pulling. Your friends might seem to indicate that they want to help, but normally they don't really come through to help. They'll just watch at a distance. But it is your battle. You have to keep fighting. You have to hold on. You would have many things pull you down. It may be corrupt individuals. It may be the economy. It may be just circumstances. It may be the family. It may be friends. It may be people that are just surrounding you. They may be pulling you down to mess. And doing nothing about your situation. But you have to realize at the end of the day that it is about you and your future. Then those that you care for will start walking away in numbers. They'll leave you struggling. They'll leave you alone, and only a few will remain around you. Those may be leaders, only a few will remain behind, right, on your own. My message for you is keep pushing. And the universe has a way of conspiring to bring in help to you. So it may be those that you least expect to come through to your aid. They'll certainly come through. Just hang on. Just keep pushing. Help is coming your way. Don't lose hope. Keep hoping. Help will come your way in ways you least expect. Sooner than later, help would have come your way. And you'd have an opportunity to swim out of that. In this video,
भारत तांबेंची कविता आहे, जन पलभर म्हणतील हाय हाय. अशोक गेल्यावर मला या कवितेची फार आठवण आली. So what will shape surgical practice in the years to come? There will be disinformation, there will be pseudoscience, there will be technology, and there will be changing patient-doctor relationship. Madam, can I get some water, please? There is something I call pseudoscience. We have many alternative therapies in cancer that we talk about. We have stem cells, we have keto diets. More recently, we have HCQS and tocilizumab. This is what I call pseudoscience. There is a difference between disinformation, which is a deliberate lie to mislead, versus misinformation, which is an honest mistake. Even the best journals, NEJM and Lancet, have been guilty of misinformation, and that is pseudoscience. 20 years ago, we were told that butter is bad. Now they say that gai's tup is not so bad. Beware of false knowledge. It is perhaps more dangerous than ignorance. So we'd have a journal club in our hospital every month. And I always tell my residents is when you read an article from the best journal, you need to separate the bullshit from the science. And many times these are concocted pieces of bullshit which have no value. There is a strong pharma bias or device company bias behind this. And I want to propose to the organizer of the next ASACON is every speaker in the first slide must have a no conflict of interest slide. If Ethicon is paid for my car journey from Nagpur to Amravati, I must disclose that in my slide before I talk on harmonic as an energy device. I think this must be made mandatory in state and national conferences like it is internationally. I was a big believer in evidence-based medicine. Whenever my residents or a colleague would tell me, I would ask for evidence. I think some gray hair has taught me otherwise. Clinical experience has been defined as making the same mistake with increasing confidence in contrast to evidence-based, which is perpetuating other people's mistakes instead of your own. Though evidence-based medicine is good, it is not infallible. It is not inclusive and may not include everything. It is the wise wisdom. The problem in our country is सगळेच कवबॉय असतात. माझ्या हातात असं असतं. माझे एक प्रोफेसर सांगायचे केएम मध्ये माझे सोन्याची बोट आहेत, मी असा टाकून पॅनक्रियास बाहेर काढतो. पण प्रॉब्लेम इज ते नंतर लीक्स आम्ही सांभाळायचो त्यांचे. ते सोन्याची बोट इज सायन्स हॅज टू बी टेम्पर्ड विथ विजडम अँड एक्सपिरियन्स. You need to draw a fine balance in between. It is not only evidence-based medicine. There has to be something after themselves. So I think as a surgeon or as a doctor, I think handling loss is important. In life, when there is no wind, you row. Think of this. You will come through phases in life which are difficult, but you need to come out of it. Teach. If you want to master something, teach it. The more you teach, the better you learn. Vidya dhyanena vardhane. So never forget that whatever stage, whether you're in a PHC or in a teaching hospital, keep teaching. You will improve yourself as चलता रहूंगा पथ पर चलने में माहिर बन जाऊंगा या तो मंजिल मुझे मिल जाएगी या तो अच्छा मुसाफिर बन जाऊंगा. I have another 5 minutes with your permission, Raj.
Please go ahead.
So we are drowning in information but starving for knowledge and wisdom. So there's a difference between information, knowledge, and wisdom. We should be aware that we are biased. All of you are biased. So I'll give you my own example. I was a big believer in the STAR operation for rectal prolapse and obstructive deficient syndrome. I learned this in Germany. I started doing STARs right, left, center. For those of you who don't know, it's a stapled transanal rectal resection. So whenever I used to get a paper coming in a journal, I see, oh, it agrees with what I'm saying. It must be a good study. I was right all along. I'm a genius. If somebody said the STAR operation was bad, then I would look at the material methods carefully. It must be a biased study. There must be a flaw in the patient methodology. There must be statistical analysis not good. Remember, the time you read the material methods of a paper is inversely proportional to whether it agrees with your own preconceived conclusion. So any paper that said that STAR was good, I never read the material methods. The conclusion is good, STAR is good, and vice versa. We generally tend to seek out information that confirms your belief and avoid contradictory evidence. So the senior surgeons who said Lapcoli is a useless operation in 1995, they would find that CBD kapla, tala port side infection tala port side metastasis tala. You can grab those pieces of evidence and say that laparoscopy is useless. Am I condemning robotics? No. I went and just did a training in Gurgaon for robotics. I may not buy robotics, but before I decide to take it or decide to discredit it, I must know everything about it. I'm not fortunate to be in a department like Raj Gajvi to have a Da Vinci given to me, so I need to justify it to myself. The disease should not be adapted to technique, but vice versa. An example is rectal prolapse. I think in our country, unfortunately, 99% of operations for rectal prolapse are laparoscopic posterior mesh rectopexy. There are perineal operations, there are ventral mesh rectopexy, there is sutured rectopexy, and there is mesh rectopexy. But in our country, 99% are posterior mesh rectopexies, which is basically wrong. I think you need to fit the operation to the patient and not vice versa. So you have a young patient versus old patient, fit versus unfit, somebody with ODS, no ODS, constipation, no constipation. So this is one fundamental problem that we have. We learn one hernia operation and we'll do the same hernia operation for everyone. If I'm a laparoscopic surgeon, EAP is the best, it's a godsend. I will never do Liechtenstein. That is wrong. I still in our hospital do open hernia surgery under local anesthesia in appropriate patient. This is something called the Texas sharpshooter fallacy. It's again a well-documented scientific thing. So it's look at this man firing. He fires all his shots in one side and then goes below and draws a circle around that. We seek out facts and evidence that support our biases. I will look for all papers in literature which say that lap hernia is better than open hernia. This is what is in science called Texas sharpshooter fallacy. Never forget that. Better surgeons know surgery is more cerebral than technical. Every year I have 4 fellows who join our department in minimal access surgery. And they all want to come and I want to learn lap hernia, I want to do lap AR, I want to do fundoplication. But I tell them that 60% is in the brain. 40% is a skill that you learn from me. You will get to do volumes of work, but if you understand the operation, you will probably be a better surgeon than a technical surgeon. I call this the optimism bias in surgery. Number 1, drains and antibiotics do not compensate for errors. Number 2, do not argue with authority. And I'm not saying this because I'm a boss and I have fellows. I encourage them to ask me. We are habitual casual theorists. In my hands, asats hota. Maja lab kool drain mein taktoch, kais hot nahi. Look at what the world is doing. Nobody is putting drains for lab kool except for certain indications. We find every reason to avoid re-exploration. We on the average get 2 or 3 CBD injuries every month from peripheral hospitals. And each of these patients has a dangling Ryle's tube, which is not draining anything. Patient is usually transferred from day 4 to day 8, who's got tachycardia, tachypnea, and peritonitis. And invariably, surgeon tells me, drain मध्ये काहीच नाहीये. Ultrasound केला फक्त 10 ml fluid आहे. WBC count 9000 आहे. त्याला काहीतरी pulmonary embolism झाला असणार. It isn't. You do a CT or put a scope. See, your lap call has to go in 48 hours. If your lap call is not behaving well on day 5, there is a intra-abdominal problem. Very rarely it will be pulmonary. Blame the anesthetist, blame the physician, but don't blame yourself. So I would strongly advise youngsters, if you have a post-op patient is not doing well, get the third-party surgical friend to come and see the patient. We generally find every excuse to avoid re-exploring our own patient. And I'm also guilty of that. We believe, God willing, everything will be all right. It doesn't happen like this. You must recognize the bias and entertain contrary views. This I call the 559 rule. Anytime on table, if I find anastomosis 50-50, 99% anastomosis leak honarats. That is what I call the 50-50-90 rule. Every time you think that you may get away with this, 99% patient will get a leak, will get peritonitis, or will die. So on table, if you're not satisfied, don't close the patient. Do what you like, spend as much time. You're not fighting with the clock, you're not fighting with the anesthetist, you're only fighting with the surgeon. Remember, the surgical results depend on surgical morbidity and how quickly the patient walks home, not how much time you spend in the theater. I get young fellows coming from BJ Medical, KEM, Nair. I'm always scared of these young guys who say, sir, kai kutli gallbladder mi karto. अजून मला काही गॉलब्लॅडर पांढरे केस होतात इतके 2000 गॉलब्लॅडर केल्यावर सुद्धा. So I'm always scared about people who are not scared when they ought to be. When you have a shrunken contractor, Mirizi, alternate LFTs, when these young guys say मी करून टाकतो, I said हात CBD कापणार, त्यालाच वॉच करा. आणि तो घाबरट सर्जन असतो तो सावकाश करतो. I always prefer that boy. I will let him do a difficult gallbladder first before the so-called overconfident surgeon. So this is important. There is knowledge and there is wisdom, and we can talk on lasers in aerorectal or we can talk on robotics. Initially, we all have skepticism of new evidence, and then the last is hawkish intervention. Like when you buy a 10 lakh rupee laser, every anorectal problem will have a laser fired at it. Believe me. Sometimes laser on the operating room table or the कट्ट्यात असलेल्या लेझरचा फायदा असतो कारण पेशंट तरी तुमच्याकडे येतो. लेझर वापरतो की नाही हे दुसरी गोष्ट आहे. On the other hand, there is medical nihilism versus knowledge transfer. Think of all this. And I'll finish this by a little word of advice I give my youngsters when they leave. This is a poem by Longfellow. I used to read a lot of poetry when I was in medical college. And it says, looking in the mirror. If wrong you do and false you play, in summer amongst flowers, you must atone, you shall pay in winter among showers. The unfortunate reality is even I am a medical entrepreneur. I have taken a large loan to start a 150-bed hospital. I have lots of things. So I am a businessman. I am an entrepreneur. This fine balance between being a good professional and being a good entrepreneur is blurred. Like I said, we are all shades. Everybody in this room is a shade of gray. We just need to choose the shade of the gray that we behave. And this is my final slide. Again, a poem called Man in the Glass. And I'll read it out to you. When you get what you want in your struggle for self and the world makes you king for a day. I think Dr. Ganirewal, you're president today. Raja, you'll be president tomorrow. The world will make you king for a day. Just go to the mirror and look at yourself and see what that man has to say. But isn't your father or mother or wife whose judgment upon you must pass, the fellow whose verdict counts most in your life is the one staring back from the glass. He's the fellow to please, never mind all the rest. But he's with you clear to the end, and you have passed your most difficult, dangerous test if the man in the glass is your friend. You may fool the whole world down the pathway of years and get pats on the back as you pass, but your final reward will be heartache and tears if you cheated the man in the glass. Thank you very much. I think fortunately no questions on this, Raj.
Thank you, Roy, for a wonderful lecture. It is one of the finest lectures I have ever heard.
That's rich compliment. Thank you very much.
Thank you so much.
Thank you.
Thank you, Roy, sir. I request Dr. Raj Gajbee and Dr. Vikas Jain sir to felicitate Dr. Roy Patankar sir. I request Dr. Umare sir to felicitate Dr. Raj Gajbee sir and Vikas Jain sir. I request Dr. Niranjan Agrawal sir for next lecture on laser in management of anorectal surgery. And chairpersons are Dr. Rahul Hantodkar and Dr. Wankhede sir.
Hello, Dr. Niranjan Agrawal, sir. He's a consultant colorectal surgeon and assistant professor, Bombay Hospital Institute of Medical Science, Mumbai. He's a consultant surgeon at the Oakwood Hospital, Jain Hospital, Cardinal Gracious Hospital,
The workup is same as you do for any open surgery. You have to stop anticoagulant. You have preoperative laxatives to empty out the anal canal. You can do it under auspice and pull out. You will see that the descent probably after the patient is relaxed is more than what you have seen in your OPD patients. After doing that, the first thing is to do a hemorrhoidal artery ligation by palpating the superior hemorrhoidal artery branches. I'll show it in the video which will be followed by this. And then after doing that, all the 3 or 4 branches which you are feeling, you have ligated by a figure of 8 stitch. There is a puncture made at the mucocutaneous junction with the laser fiber, conical fiber. And why mucocutaneous junction? Because if you puncture it at the dentate line, there are some CCR network which remains unattended and they may cause recurrences. And if you puncture below and you go through the sphincters or intersphincteric plane, then there are chances that you may even damage the sphincter. So it is better to go through the mucocutaneous junction, which will cover both the CCR network as well as the prolapse cushion network. And the current use is 6 watt 1 second pulse, and thereafter having entered the hemorrhoid, you use a 6 watt 3 second pulse in a fan shaped manner covering the entire hemorrhoidal mass, and slowly keep on withdrawing every 5 millimeter. But remember, the amount of energy which you deliver per pile mass should not exceed more than 150 to 200 joules. And remember, never push the fiber against resistance, because then you are likely to miss the plane. And if the light is too bright, then you're very close to the mucosa, then do not activate the laser. If it is too dull, you may be in the deeper planes and may burn the sphincter, so do not activate. So it has to be an appropriate light, and the hemorrhoidal masses are not going to shrink on table as you think. They are going to take their own time to shrink. So don't keep on giving more energy to shrink them further. Just wait at 150 to 200 and then they will shrink at the end. At the end of the procedure, you keep in an ice pack for relaxing the thermal energy which is given, and cold pack should be applied for around 48 hours, after which you can give your regular cis bath, post-operative antibiotic, analgesic, etc. as per your open surgery. So this is redefining the hemorrhoidal degrees. Then palpation of the hemorrhoidal vessels by your finger. This is the 7 o'clock hemorrhoidal artery terminal branch. To take a figure of 8 stitch and tie it. This is the 11 o'clock which has been taken now. So it is not necessary that you will get only 3 such branches. You may get more also, but most of whatever is clinically palpable, you must ligate all those branches. But the puncture is made at the 3 primary sites only. And if there is another one very large hemorrhoid, then you can, so this is the puncture which is being made at the largest hemorrhoid first. So you can see the light energy over there. Once you activate the laser, keep on withdrawing every 5 millimeter while delivering the energy at all the 3 major hemorrhoidal mass. That was the papilla which was hanging. We just cut it with the laser energy itself. You can do that with cautery also. Now never spray laser over the mucosa or the hemorrhoid, because that is going to cause ulcerations. So don't do that. So these are the post-operative and pre-operative comparison. The advantages are, of course, there is no obvious surgical trauma, or you can cause less surgical trauma with reduced operating time. There is significantly less pain post-operatively, but it is not painless. It is less pain. Remember that. When you tell the patient it is painless and tomorrow he'll come back and keep on shouting, "Bahut pain ho raha hai." So don't promises wrong, as Roy was just telling you. Be within the shade of gray which is making you comfortable. Don't overshoot the gray shade. So it is lesser pain, not painless. And definitely patients can go back to work a bit early. And these are not without complications. I have purposely put all the photographs of the complication. You can see there edema, you can see bleeding, you can see ulcerations, thrombosis, etc. if it is not used properly. Inadvertent use is going to damage and cause more complication. And Roy himself keeps on saying a fool with a tool is always a fool. So be careful and use your technology appropriately. So these are few evidences in the literature about the laser usage in hemorrhoid and their comparison. Most of the paper you will find that they have said that there is a good minimal invasive procedure for grade 2 and 3 hemorrhoids, but you have to be very careful when you use it for grade 4. And if it is a circumferential prolapse, then this is not a procedure of choice, because then MIPH becomes a better procedure. So I'll just go through them because the conclusion is more or less the same. You can go through this slide where is the table which showing the success rate. If you see, most of the people who are doing a hybrid procedure, where that is Doppler guided ligation along with hemorrhoidoplasty, the success rates are more than 90% in majority of the studies which you see, which is actually comparable to your conventional hemorrhoidectomy. But yet, when you actually compare in the double blind study, they have only compared conventional with hemorrhoidoplasty. They have not compared with FGR with hemorrhoidoplasty. So that literature has yet to come out. So to conclude, its proper laser popularity is growing slowly, and definitely it's a minimal invasive procedure in hemorrhoid with obvious benefit, and combining it with other procedure is yielding better results. Appropriate use of the machine will reduce complications, and there is a need for evaluating further before accepting as first line of treatment. But remember, today, if you are offering laser or any procedure to your surgeon where there are multiple modalities available, it is better to discuss the pros and cons of each and document it on paper and take their signatures. Because if today they will say, I want laser, but tomorrow they get recurrences, they will blame you, okay, you have not done it properly. So it is better to take their signatures on paper. That will save you a medical legal problem in future. Coming to the next disease, that is the fistula in ano, the procedure is called FILAC, that is fistula laser ablation. Principle is ablation of the tract using a laser energy which destroys the endothelium and shrinks the tract. It's obviously a sphincter saving procedure because we don't divide any sphincters over there. And because it's a sphincter saving procedure, you will see that the incontinences are minimal, but at the cost of higher recurrences. So how to tackle this higher recurrences? Again, mixing another procedure. So if you're not able to form your own sarkar, do a Mili-Juli sarkar. So here again, you form another, take another party from there and mix up with you and form a coalition, a hybrid procedure, which are supposed to give a slightly better result. In fistula, especially in complex fistula, this can be offered as a first choice, especially in a non-recurrent cases because they are sphincter sparing, and their uses do not prevent a more aggressive approach later. If they fail, if your patient falls into that 70%, well and good. If they do not fall, then you can still go ahead and do a complete excision and a sphincter repair. So the hybrid ones are where they have combined laser with either waft or laser with lift or laser with even fistulotomy, low fistulotomy, which we do it for low fistula, or in tract which extends above the anorectal ring or the puborectalis ring. If the tracts are extending, you need not cut or divide them. You just transect the fistula tract at that portion, scoop out the tract which is going into the supralevator region, and then ablate it completely. Again, the pre-operative preparations are same as for an open surgery. The steps are, you identify the internal opening like you would have identified in your open surgery. Second step is to widen the external opening, curate out the whole tract, clean it thoroughly, wash it, and then with a Corona 360 radial fiber, you deliver energy from internal opening and slowly withdrawing it to the external opening. The dosage given is 10 watt in a continuous mode. And once having done that, you excise the internal opening area and close it either with a figure of 8 or a fish eye closure stitch, and the same post-operative management which otherwise you would do in an open surgery. Why laser fails in fistula is because many times we fail to localize the entire tract. It being a blind procedure, you are not able to see where you are going. There may be some side branches also. And sometimes the tracts are not uniform. Somewhere it is fibrous, somewhere it is more dilated, etc. And lastly, there is improper cleaning or application of energy. If you withdraw the laser fiber too fast, then there are skip areas of the tract which remains, and that is where they may cause recurrences. So you have to be very careful, and that's why you give continuous mode also. So there is one photograph where this young boy, around 18-year-old, had an external opening in the groins and internal opening at 1 o'clock position. We did a waft with laser. You can see there were hair follicles here in this tract. So this boy recovered after this procedure within 4 weeks of time. There was no wound left. This is the second man who had an anterior fistula. You can see the pictures over here. We did a lift along with laser, and this man also healed in around 3 weeks time. There's a small video of the same patient you can see here. So it's a small, simple tract in the anterior area, but long tract. I'm doing a lift over here. So you dissect the tract, tie it at the internal end. So disconnect the tract, scoop out the tract from the external opening thoroughly, send that tissue, granulation tissue, for histopathological examination. Close the distal end, keep it long, put in your fiber, and once as you are pulling the fiber, tighten it so that you know it is watertight. Deliver the energy and clean the tract thoroughly. Thereafter, close the wound. So you see the size of the wounds are pretty small. There is hardly any wound. And the healing also takes fast. This is again a horseshoe fistula. You can see over here with 2 openings on either side of the buttock. What I did was a laser fistula, low fistulotomy along with laser ablation. There's a small video here too, you can see. So the dye is coming through both the sides. We open the post-anal space, which is the main culprit in a horseshoe fistula at the 6 o'clock position. Scope out all the material which would be present over there. Send it for histopathology. And then by using laser fibers, ablate both the tract after you have scooped and cleaned them. And at the end, we would close the internal opening area with a mucosal flap over there. So both sides are being ablated. This man, the right-sided tract healed within 2 weeks time, but the left-sided tract, he gave me a lot of trouble till 1.5 months. I had to keep it repeatedly scoping and washing till he stopped drainage. So that is closure of the internal opening. So again here the review of literature. There are multiple papers which are coming on laser. Again, they are mainly for use of laser alone, which is that the success rate is mainly around 64%. But the good thing is if you repeat a laser in your recurrent patient, then the success rate have shown to excuse me, to exist to somewhere around 70%. Excuse me. And it also shows that the length of the fistula tract determines the success. So shorter the tract, the outcomes are much better. Again, another study showing around 70% success rate. And when you compare all the studies which are available, it does mention that it is a lesser invasive surgery, but more costly, and it needs to be evaluated further. So coming to the main point again, the evidences of a hybrid procedure for fistula also to compare to the other procedure is still missing. And so it is difficult to say whether the hybrid procedures will be the gold standard tomorrow. So to conclude about fistula, it's a simple, safe method using laser, sphincter saving, but higher recurrences, and therefore not good for recurrent fistulas because no patient would want to come back again and again on table. And hybrid are apparently showing improved result, but the supporting data is still to be awaited. Fissure in NO, again, laser sphincterotomy is the same as you would do an open sphincterotomy using a knife or a blade or a scissor or whatever you are. But here you use a laser energy with bare fiber, which actually causes more pain, and the data supporting laser use in fissure is small, and the comparative data is still missing. And probably I would say that it's more of a marketing gimmick because patients are demanding now कि हमको laser से ही कराना है. There is obviously no much benefit in fissure surgery, but definitely the benefit is for the surgeon for obvious reasons. Pilonidal sinus, again, a last entity which I would be talking about. When you use laser alone, it is called SILAT, that is sinus laser ablation of the tract. And if you use a mixture of two procedures, that is EPSIT and laser, you call it VALAB, that is video assisted laser ablation. Again, the workup is same as you do for any other procedure. The step of the procedure are put the patient in the jackknife position under local or whatever anesthesia you want. You widen the external opening and using either a skin biopsy punch or your cautery or blade, whatever you like, curate out the whole tract, clean the whole tract, remove all the debris and the hairs. And at the end of the probe, you make an iatrogenic secondary opening over there, and then give the wash so that there is a communication like a fistula over there. And using your radial fiber, you ablate the tract. This causes minimal pain, but there is a discharge which keeps on troubling the patient for around 3 to 4 weeks. This is a small video about the Silet. This video belongs to Dr. Kamal Gupta, my friend, and I have borrowed him for today because I didn't have my own video for the laser pilonidal sinus. So you see he has removed all the debris and now he is burning the tract completely. So that's it, a small wound which gets created, which heals very fast. So complications which can occur with Silet is again hematoma, bleeding, or discharge about it, then the collection get remain there and form an abscess. There are a lot of papers which support use of laser in pilonidal sinus as a minimal invasive procedures, which shows very high success rate, around 90% of the cases. Most of the studies, if you see, they have got very high success rate, including those patients with VALAPs or laser alone. So it's showing a promising short-term management, long-term results are awaited. So to conclude lasers in proctology, friend, there are multiple modalities available for all the proctological procedures, and the search for a better modality keeps on continuing and new procedures keeps on getting added. Similarly, laser has got added and its popularity is increasing. It's minimally invasive with obvious benefit like simple to use, reduced complication if used diligently, not otherwise, with early return to work. But since it is technologically dependent, it is more costly, and they are still unable to match the cure rate about the with the most of the conventional procedure which we use, and hence the gold standards cannot be it cannot be termed as gold standard yet. There is definitely some evidence to suggest that hybrids are showing better results. Thank you so much for your patience hearing.
Thank you, Niranjan sir, for nice and excellent presentation about the laser used in anatomical surgery. I think that take home message is laser is not a magic machine.
It is not, yeah.
You use it judiciously, and hybrid procedure is always better than the laser alone.
I agree to you.
Any question from audience?
Thank you, Dr. Niranjan Agrawal, sir. I request the chairpersons to felicitate Dr. Niranjan Agrawal.
Madam, just a minute. Let me wish Niranjan sir happy birthday.
Happy birthday, Niranjan Agrawal.
Thank you so much.
We celebrate in our banquet. I request Dr. Vikas Jain, sir, to felicitate our chairpersons. After this, we will have the virtual lecture by Dr. Dharup, sir, analgesia post-surgery new technique, and immediately followed by inaugural function. Dr. Darvi, sir, and Dr. Sanjay Jain, sir, have already joined on Zoom for the inaugural function, so we'll do it in continuation. There will be break up.
Good evening, everyone. At the outset, I would like to thank Amravati Association of Surgeons of Amravati and Dr. Ganeriwal sir for giving me this opportunity. I'm Dr. Sanjay Kolte, organizing secretary of next MASICON, which is going to be held in Pune this coming February. So Pune Surgical Society, Pune Surgical Society proudly presents you this 44th MASICON, which is going to be there on 3rd of February to 5th of February 2022. And the theme for our conference is Resurgence, Reflect and Refine. The conference will assure you a feast of good academic program and a loaded scientific program. And we, Pune Surgical Society, stand committed to make sure that you will go home with memories of a great conference befitting our city, also known as Oxford of the East. So I welcome you all to the conference MASICON 2022, which is 44th MASICON at Pune Surgical Society at Pune next year from 3rd of February till 5th of February at JW Marriott, Pune. The registration forms and the details of the conference registration are kept at the registration counter. So kindly register yourself at the earliest with early bird offer. Thank you very much.
Namaskar. At the out. Namaskar. At the Namaskar. At the outset. Namaskar. At the outset, let me congratulate Association of Surgeons of Amravati for organizing this event ASACON 2021. I am Dr. Satish Dharap and I am going to speak on post-surgical analgesia. As surgeons, all of us are concerned about post-operative pain. Each and every surgery causes some kind of pain. Pain is most severe in bone and joint surgeries and bony injuries. In general surgical practice, open surgeries are associated with more pain as compared to laparoscopic surgeries, and abdominal surgeries are more painful than other surgeries. Pelvic and gynecological surgeries also cause pain, but it's relatively less as compared to general surgical operations. Bone and joint surgeries, although they have more intense pain, their systemic effects are limited, whereas abdominal surgeries have more chest complications. So what does this pain cause? First of all, it causes poor patient satisfaction, delayed discharge and readmissions in daycare surgeries or short stay surgeries. There is reluctance to mobilize, which leads to slower restoration of function and rehabilitation. Long incision on the abdomen causes shallow breathing because of pain, leading to inadequate ventilation, collapse of the lung or atelectasis, and may predispose to hospital-acquired pneumonia. Prolonged immobilization as a result of pain also makes patients prone to deep vein thrombosis and pulmonary embolism, and also due to prolonged lying down, pressure sores. So the control of pain is a major concern for surgeons. Pain is defined as unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Acute pain after surgery is normal. It is usually of limited duration, less than 3 months, but usually 7 days. It is body's Namaskar. At the outset, and I am going to speak on more painful than other surgeries. Pelvic and gynecological surgeries also cause pain, but it's relatively less as compared to general surgical operations. Bone and joint surgeries, although they have more intense pain, their systemic effects are limited, whereas abdominal surgeries have more chest complications. So what does this pain cause? First of all, it causes poor patient satisfaction, delayed discharge and readmissions in daycare surgeries or short stay surgeries. There is reluctance to mobilize, which leads to slower restoration of function and rehabilitation. Long incision on the abdomen causes shallow breathing because of pain, leading to inadequate ventilation, collapse of the lung or atelectasis, and may predispose to hospital-acquired pneumonia. Prolonged immobilization as a result of pain also makes patients prone to deep vein thrombosis and pulmonary embolism, and also due to prolonged lying down, pressure sores. So the control of pain is a major concern for surgeons. Pain is defined as unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Acute pain after surgery is normal. It is usually surgeries. There is reluctance to respond to a noxious stimulus. It is protective in nature and it resolves with healing. Whereas chronic pain is abnormal, it persists even after 3 months. It has no protective function. It affects health and function of the patient, and its mechanism is not peripheral, but it is central sensitization. The most important point to remember is inappropriate control of pain in acute setting may help in pain becoming chronic. So initially, pain is a peripheral phenomenon caused by tissue damage or nerve damage. When there is central sensitization, patient may experience hyperalgesia, means it is increased response to normal threshold of peripheral stimuli. So slight painful stimulus may lead to very severe pain. It may cause allodynia. Allodynia is increased spontaneous pain due to innocuous stimuli. Like even a breeze of air may cause pain. And sometimes it may cause spontaneous pain even without any kind of stimulus. So if there is central sensitization, patient has to suffer in the long run. And therefore, our aim should be to control pain well in acute settings so that there is no central sensitization. What are the causes of postoperative pain? Of course, it is operative trauma. But at times, if you crush too many tissues, if you cause hematoma, if there is a lot of thermal injury to the tissues, inadvertent inclusion of nerves, as may happen in hernia repair, ischemia of tissues, infection of the tissues, residual disease, or some other complications, like after abdominal surgery, patient developing anastomotic leak. All of these cause pain. And as surgeons, it's our primary duty to recognize these problems and address, because unless the cause is treated, the pain is not going to get relieved. But WHO has come out with a pain management ladder. Initially, it started with 3 steps. When patient complains of pain, you begin with basic analgesics like non-opioids like paracetamol or NSAIDs. If pain is still persistent, you may add a weak opioid like tramadol. But if that doesn't control pain, you may add to other non-opioids or adjuvants. And in severe pain, you give strong opioids along with non-opioids or adjuvant. The 4th step has been added now, which includes interventional techniques such as patient-controlled analgesia. When the pain is under control, your weaning is also along these steps. So you take one step at a time to control pain, and you climb down one step once the pain is controlled. So which are these analgesics which we can use systemically? When we consider non-opioids, paracetamol or NSAIDs are the workhorse of most of our post-operative control of pain. They act by inhibiting the synthesis of prostaglandins. They reduce the potential inflammatory response causing the pain.
नाही नाही गर्दीच नव्हती कोणी इथं केदारनाथला कोणीच नाही म्हणते आली का हा? त्यामुळे थांबले इतकं मोठं काय? नाही का? सर म्हणे काही करू दे.
उधर बैठ गए ना दोनों Zoom पे लॉगिन होके जॉइन करो
फक्त 80 राहिले सर बाकी नाही
Zoom पे join.
Hello, good evening all. I request all the delegates to assemble in the auditorium. We are going to start the inaugural function in few minutes. Sir, will you- आणि ते लाइटनिंग लॅम्प ठेवायचं आहे ना लाइटनिंग Hello. Good evening, all. I request all the delegates to assemble in the auditorium. We are going to start the inaugural function.
यहाँ से आवाज बड़ा
ठीक हेलो
I request all the delegates to come in the hall for inauguration function. I request all the delegates who are in the lobby to come in the hall for inauguration function. And I request the people who are sitting behind should come forward. I request all the delegates who are sitting back should come in front. I request all the delegates and faculties to come in the hall for inauguration function.
Hello. Swagatam, Suswagatam, Suswagatam. On the occasion of ASACON, Dr. Ravindra Kasat, myself, welcome all the dignitaries, guests, and my fellow surgeons. It gives me immense pleasure to welcome you all to a pious destination that is Amravati, blessed by Goddess Ambadevi and Ekvira Devi, and protected by Lord Shiva, and prosperity showered by Lord Venkatesha. Amravati has unique history in the central province and Berar, as it was called previously. Cotton, jowar, and oranges are the hallmarks of this area. I shall be forgetting my duties if I don't appreciate the present president of Surgeons Association of Amravati, Dr. Jayashree Patil Ingole. She not only acted as a source of inspiration to us, but also provided necessary impetus in organizing this conference. She played a pivotal role in organizing. I welcome you all once again and I proceed further. मैं आमंत्रित करता हूं मंच पर आज के प्रिसाइडिंग ऑफिसर डॉक्टर जयश्री इंगोले। प्रमुख अतिथि वर्चुअली हमारे साथ ज्वाइन है अभय दड़वी सर, प्रेसिडेंट ASI, डॉक्टर राजेंद्र गनेरीवाल, प्रेसिडेंट ऑफ मासी, डॉक्टर AT देशमुख, डीन पंजाबराव देशमुख मेमोरियल मेडिकल कॉलेज, डॉक्टर नारायण उमाळे, हेड ऑफ द डिपार्टमेंट ऑफ सर्जरी PDMMC, डॉक्टर समीर रेगे, सेक्रेटरी मासी, डॉक्टर अंजलि ढवळे, ट्रेजरर मासी, डॉक्टर अमित भस्मे, सेक्रेटरी ऑफ अमरावती सर्जन्स एसोसिएशन, डॉक्टर कौस्तुभ सारड़ा, ट्रेजरर अमरावती सर्जन्स एसोसिएशन। मंचासीन होने के पूर्व मैं सभी डिग्निटरीज से निवेदन करता हूं कि वे दीप प्रज्वलित कर कार्यक्रम की विधिवत शुरुआत करें।
Good evening, everybody. The chairman of the Maharashtra. President of
Now this is the time for floral welcome of our guest. मैं डॉक्टर जयश्री इंगोले से निवेदन करूंगा कि वे डॉक्टर राजेंद्र गनेरीवाल को पुष्प गुच्छ देकर उनका सम्मान करें। डॉक्टर नारायण उमाळे का स्वागत करेंगे डॉक्टर कौस्तुभ सारड़ा। डॉक्टर समीर रेगे सर को सम्मानित करेंगे डॉक्टर अमित भस्मे। डीन डॉक्टर A.T. देशमुख का स्वागत डॉक्टर जयश्री पाटिल इंगोले करे, ऐसी मैं उन्हें विनंती करता हूं। डॉक्टर कौस्तुभ सारड़ा से विनंती है कि वे डॉक्टर अंजलि जी का पुष्पगुच्छ देकर सम्मान करें। सर्व उपस्थितांचे आपण एकदा जोरदार टाळ्या वाजवून स्वागत करूया। In the age of male dominance in the field of surgery, a lone woman can make miracles. She can also perform a Herculean task of organizing such conferences. I invite Dr. Jayashree for welcome speech and introductory remarks. Dr. Jayashree, please.
Honorable Chief Guest, Dr. Abhay Dalvi sir, Guest of Honor, President Masi, Dr. Rajendra Ganediwal, President-elect ASI, Dr. G. Siddesh, Honorary Secretary ASI, Dr. Sanjay Jain, Honorary Treasurer ASI, Dr. C.K. Prasad, Dean, Dr. Punjab Rao Deshmukh Medical College, Dr. A.T. Deshmukh sir, HOD Surgery, Dr. Umale sir, Secretary Masi, Dr. Sameer Rege, Treasurer Masi, Dr. Anjali Dawle, Secretary ASA, Dr. Amit Bhasme, and Treasurer Dr. Kaustubh Sarda, dignitaries of the dais, respected seniors, and dear colleagues. It gives me immense pleasure to welcome you all for this August gathering after a long period of lockdown due to COVID. It is a matter of great honor for Association of Surgeons Amravati that the President, we are felicitating the President ASI and President Masi on behalf of Association of Surgeons Amravati. Dr. Dalvi sir tried his level best to join this function and be present in person, but due to some unavoidable circumstances, sir couldn't join, and so he is joining virtually. We are fortunate to have Masi President Dr. Ganediwal sir to support and guide us. I welcome Dr. Dalvi sir and Dr. Ganediwal sir on behalf of ASA. There is a lion's share of Dr. PDMMC in every academic as well as social activities of our association. I am thankful to Dean Dr. A.T. Deshmukh sir and HOD Dr. Umale sir for their kind cooperation. I welcome them for today's inaugural function as a guest of honor. Organizing a conference is a teamwork. Hence, I cannot forget my supporting team, the Secretary ASA Dr. Amit Bhasme, Joint Secretary Dr. Narendra Wankhede, and Treasurer Dr. Kaustubh Sarda. The success of conference also depends on participation of the renowned faculties who spare their valuable time to share their knowledge and spread the light of knowledge. I welcome all faculties on behalf of Association of Surgeons Amravati. Amravati Surgical Society welcomes all EC members of Masi, GC members of ASI for their gracious presence. We welcome our MMC observers, Dr. Ashish Dagwar and Dr. Anand Kakani for the 4 credit points MMC has awarded to ASACON 2021. And most important is our senior surgeon with extraordinary talent, who is shouldering the responsibility of Master of Ceremony, Dr. Ravindra Kasat sir. I welcome Dr. Ravindra Kasat sir. My association is my family. With the blessings of seniors and active participation of all colleagues, we have tried our level best to make the conference successful. I also acknowledge the presence of the better of President Masi, Dr. Renuka Ganediwal, and Dr. Ujjwal Hingole sir. With these few words, I end my speech and hand over the proceedings to Dr. Kasar sir. Thank you, sir.
Thank you, madam. Now, I invite Dr. Abhay Dalvi, today's chief guest, to announce the ASACON is duly inaugurated virtually. Dr. Abhay Dalvi, sir. He has already declared. Thank you, sir. I invite Senior Surgeon, Professor of Surgery, Punjab Rao Deshmukh Memorial Medical College, my classmate, Dr. Narayan Umale, to address the House.
Namaskar. Dignitaries on the dais, of the dais. माझे मित्र डॉक्टर रवी कासट. आजचा ऍक्च्युली दुग्ध शर्करा योग असा होता. We wanted to felicitate ASI President and Maharashtra ASI President. Unfortunately, Dalvi sir इथे नाही आहेत. Otherwise, we would have enjoyed more in the evening. I also welcome all EC members of Maharashtra ASI as well as governing council members of ASI. Some of them are, I think they are coming for the first time in Amravati. So we will offer them all hospitality in the evening. I wish success to our conference. Thank you very much.
Thank you, Narayan. मी आमंत्रित करतो डीन पंजाबराव देशमुख मेमोरियल मेडिकल कॉलेजचे डॉक्टर A.T. देशमुख यांचा GMC नागपूर ते डीन PDMMC चा प्रवास मी अत्यंत जवळून पाहिला आहे. अगदी कमी वेळामध्ये आपल्या कार्यशैलीने सगळ्यांना चकित केले व आपला डीन म्हणून एक वेगळाच ठसा उमटवला आहे. त्यांनी यावं आणि आपले विचार मांडावे.
Thank you, Ravi. Good evening to each and every one of you. And I'm really surprised that after a day-long session, so many people have stayed back for the inauguration. Usually, we find that most of the inaugurations nowadays are in the evening only. By the time the inauguration function starts, most of the delegates have already left for their various visits to the city. Dignitaries on and off the dais, I won't take any names because for want of time and to save time, I welcome each and every one of you to the august city of Amravati, as Ravi has aptly described, a very pious city. On behalf of the administration of Dr. P.D.M. Medical College, I know it's not being held presently in Dr. P.D.M. Medical College, but all the same, a warm welcome to each and every one of you, especially all the delegates who have come from other cities. I see many of my friends sitting in the hall. I'm the only odd man out amongst all the surgeons. A pathologist addressing a motley crowd of surgeons is taking a big risk, and that too a practicing pathologist. But as a guest of honor, it's my duty to acknowledge and thank the organizers for having given me a chance to interact with you. In my short period as Dean of Dr. P.D.M. Medical College, this is the third function I'm attending of ASA. And I mean, even during the pandemic, that they could organize such functions, such on such a large scale. Really, credit goes to Dr. Ganediwal, Dr. Ingole, and all the office bearers of Amravati Surgeons Association. Friends, as I already said, I am not in a position to give you any advice, but such activities have become the need of the day, especially those who are medical teachers. They know that NMC has drastically changed the curriculum, a curriculum which was more, oriented towards didactic lectures, has now the core element of that curriculum is that we should produce a medical graduate who is competent enough and who has acquired all the skills and the attitude to practice that particular branch. So in that sense, acquisition of skills has become quite important and has become essential for practice of that particular branch. So in that sense, such activities definitely help in not only honing your skills, but for the youngsters to acquire more and more skills practically, especially when stalwarts like the topmost surgeons from Maharashtra, they are teaching or guiding you. So in that sense, these activities are very important. And I'm happy that the Amravati Surgeons Association has been actively involved in arranging such activities. I would just add here that as a institution, PDM Medical College will always stand behind any organization which is interested in organizing or arranging any academic activities. And as has been the experience of ASA over the years, we have stood behind ASA, and that is why a lot of workshops and live workshops could be organized in PDMC. Now we have further strengthened the infrastructure in PDMC, and I hope with the setting up of a skill lab and also improving the infrastructure facilities, more and more such activities would be organized in Dr. PDM Medical College. And I assure you that as an head of that institution, I will help you in giving you all the facilities, in making available all the facilities which are available in PDMC. With these few words, again, I would like to congratulate all the organizers and would also like to profusely thank them for inviting me, and also hope you have a wonderful time, not only in the evening, but also tomorrow. Thank you very much.
Thank you, Dr. Deshmukh. A person who has exerted even during Corona pandemic and has given justice to the responsibilities of President of MASI. I invite Dr. Rajendra Ganeriwal, but before that, on behalf of Surgeons Association of Amravati, I request our chief guest virtually and the dais to felicitate him with shawl, shrifar and floral bouquet. Dr. Ganeriwal, and I request dais to felicitate him. On behalf of Amravati Surgeons Association, Team ASA, I request all the members of ASA to come forward on the dais, please.
Thank you all. Respected Dr. Abhay Darvi, sir, President ASI, Dr. Jayashree Ingole, Madam, President ASA, Dr. Siddesh, sir, President-elect ASI, Dr. Sanjay Jain, Honorary Secretary ASI, who is present virtually, Dr. Samir, Honorary Secretary Masi, Dr. Anjali, Honorary Treasurer Masi, Dr. A.T. Deshmukh, sir, Dean PDMMC, Dr. Umade, sir, HOD PDMMC, Office Bearers of ASA, Dr. Basme and Dr. Sarda, EC members of MASI, ASA and VSA, faculty and chairpersons for today's conference, my senior colleagues and dear delegates. Greetings to you all on behalf of Maharashtra State Chapter of ASI and my personal self. Today is a big day for us. We have ASI President Dr. Abhay Darvi, sir, in our midst, but on a virtual platform. Sir had to leave for Bihar State Conference and he is going to guide us virtually. Thank you, sir. Your presence even virtually means a lot to us. It is an honor for me to be felicitated by ASA. This felicitation I accept in all humbleness. My felicitation is the felicitation of the entire Association of Surgeons of Amravati. The felicitation of the efforts which has been taken by all members of Association of Surgeons of Amravati to conduct various social and academic activities. Association of Surgeons of Amravati is a very cohesive unit which works in unison for the upliftment of the association. The results are there for all to see. 3 big conferences in 4 years speaks a lot about the enthusiasm of ASA members in organizing academic activities. We had conducted SurgiCon in the year 2017, MASICON in the year 2020, and now ASACON 2021. We have received support from all quarters of Maharashtra. I would specifically mention Dr. Abhay Darvi, sir, Dr. Roy, sir, Dr. Samir, Dr. Pratap Varute, sir, Dr. Prashant Rate, Dr. Raj, Dr. Mukund, and all the senior members of Maharashtra State, Vidarbha and Amravati. We have constantly received support and encouragement. Thank you all. This conference has also been a meticulous planned conference by President ASA and with her team. The CME, as you have all witnessed, is a grand success. I wish the very best for tomorrow's workshop and all the future events that the ASA plans. This conference will also witness the felicitation of our National President, Dr. Abhay Darvi, sir, and I won't stand in between you all and the historic moment. With these few words, I take your leave. Thank you. Jai ASI, Jai Masi, Jai ASA. Thank you so much.
Thank you, Raja. I invite Secretary ASI, Dr. Sanjay Jain from Bhopal, if available virtually, for his blessings.
Good evening. Am I audible there? Hello. Am I audible? Am I audible? Hello. 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 Hello.
Hello, sir, you're audible, sir. You can.
Yes, if I'm audible. Hi, good evening, everybody. Respected Dr. Jayashree, the President of the ASA, Dr. Abhay Dalvi, sir, who is virtually present in this meeting, President of ASI, Dr. Rajan Ganeriwal, President Association of Surgeons of India, Maharashtra State Chapter, dignitaries on the dais, off the dais. See, it was a unique opportunity which I probably missed to meet all my friends at Amravati and the friends of Maharashtra just because of some prior commitments. So I really say, I want to regret this, that not being with you physically. What I have seen, this pandemic has given us a lot of issues, but the challenges are being converted into opportunity, and many numbers of good academic activities have been performed, even being on the virtual platform. I congratulate the Amravati team for organizing this event too. And I also congratulate the Maharashtra, which has probably the most, I will say, being secretary, the number of city branches which are active and doing very good academic activities is on the top. So my heartiest congratulations. And this is probably the unique time when we felicitate our own seniors, and in this we are felicitating Professor Abhay Dalvi. He is a senior surgeon. He is always a friend, philosopher, and guide, not only to me but many of us. This unique event I have seen, I have been there for quite long time, and excellent lectures, excellent content. So again, a good thing, again, congratulations to you all. And what I will say, wish a success. It's already a successful program. Before I conclude, I would like to express my sincere gratitude for all the surgeons, all the members of the Amravati, all the members of the Maharashtra chapter and the national ASI. You know, the amount of love, affection, support which has been extended in last month only, and because of this, we will be working together for next 3 more years. So I hope and I commit that I will be there in the Amravati as soon as possible. Thank you very much, and long live ASI, long live ASA, long live Masi.
Thank you. I invite Dr. G. Dr. G. Elect. Not available. Okay. मित्रों, अब बारी है आपसे रूबरू कराने की आज के मुख्य अतिथि जो वर्चुअली हमारे स्टेट CS मेडिकल कॉलेज और KM हॉस्पिटल मुंबई से अप्रैल 2021 में प्रोफेसर ऑफ सर्जरी के पद से सेवानिवृत्त हुए आज के हमारे अतिथि डॉक्टर अभय दलवी क्रिकेट के खेल में खास दिलचस्पी रखते हैं और क्रिकेट का नाम आया तो मेरे अंदर का कमेंटेटर डॉक्टर नरोत्तम पुरी जागा तो उनके सर्जरी के पिच पर बनाए रिकॉर्ड स्कोर कार्ड प्रस्तुत करें। शिक्षा के मैदान पर डॉक्टर अभय सर ने MBBS और MS की उपाधि धुआंधार पारी खेलते हुए अर्जित की है। होम पिच मुंबई में अंडर ग्रेजुएट पोस्ट ग्रेजुएट एग्जामिनर के रूप में रिकॉर्ड बनाए हैं। देश के बाउंड्री के बाहर भी कई इंटरनेशनल जर्नल्स में पब्लिकेशन प्रेजेंटेशन 1000 से ज्यादा फैकल्टी इनवाइट प्रस्तुत किए हैं। मॉरिशस, जर्मनी, USA, शंघाई, टोक्यो आदि देशों में सर्जिकल पिचेस पर कीर्तिमान स्थापित किए हैं। वर्ष 2021 में एसोसिएशन ऑफ सर्जन्स ऑफ इंडिया के स्पीकर यानी अध्यक्ष बने। गैस्ट्रोइंटेस्टिनल एंड इंडो सर्जन के राष्ट्रीय स्तर पर एसोसिएशन ऑफ सर्जन के राज्य स्तर के अध्यक्ष के रूप में चुने गए। अब तक 21 बार ओरेशन देकर दर्शकों का दिल जीता है, जिसमें डॉक्टर CK सेन मेमोरियल एवं डॉक्टर CM फड़के ओरेशन भी शामिल है। सर्जरी में अपने बल्ले से कमाल दिखाने के बाद आपने ऑर्गेनाइजर की भूमिका भी बखूबी निभाई, जिसमें लैप्रोस्कोपिक कोलेसिस्टेक्टोमी, नॉटिंग एंड फीचरिंग वर्कशॉप, एशिया पैसिफिकॉन वर्कशॉप, अमेरिकन वर्कशॉप, ASI महाराष्ट्र स्टेट के एनुअल कॉन्फ्रेंस ऑर्गेनाइजिंग सेक्रेटरी, IADES फेलोशिप प्रोग्राम के ऑर्गेनाइजिंग सेक्रेटरी, IADES के एनुअल कॉन्फ्रेंस के ऑर्गेनाइजिंग प्रेसिडेंट के रूप में आपने दर्शकों से वाहवाही की। किसी अंपायर की क्या मजाल कि वो आपकी ओर उंगली दिखा सके, पर हर इंसान के जीवन में एक सिली पॉइंट आता है, यहाँ पर खिलाड़ी कैच कर लिया जाता है और उन्हें भी कैच किया और इनकी मैच बनी डॉक्टर सुजाता जो गायकवाड़ी। आपका एक सुपुत्र अधिक है जो माइक्रोसॉफ्ट में सिएटल US में कार्यरत है। उन्हीं शब्द सुमनों के साथ मैं आपको मिलवा रहा हूँ। मिनिमल एक्सेस सर्जरी के तेंदुलकर, टीचिंग के सहवाग एवं एकेडमिक्स के विराट डॉक्टर अभय नरेंद्र दलवी को उनके सर्जरी के रिकॉर्ड ब्रेक पारी के लिए आइए स्टेडियम में सभी उपस्थित प्रेक्षक जोरदार तालियों से उनका सम्मान करें। Thank you. Sir, as it was going to be your maiden visit to our hometown president of Masi, after occupying the chair of president of ASI, we took this opportunity to felicitate you, but you are not available today, but you are available virtually. I request Dr. Ganeriwal to felicitate sir and Dias to join in, and I request Dr. Ganeriwal to go through the scroll of honor. Dr. Ganeriwal.
It is my honor to read the scroll of honor which has been given to Dr. Abhay Darvi sir on behalf of Maharashtra State Chapter of ASI. The scroll reads thus. Dr. Abhay Narendra Darvi was born on 14th April 1958. A bright student right from school and college days, he had the option of joining IIT and Medical College both, a unique feat opportunity which is achieved by very few. But due to keen interest in medical science, he opted for medical profession and did his undergraduation and post-graduation in general surgery from State GS Medical College and KM Hospital, Mumbai. This was the starting point of the illustrious career which is being hailed by one and all. Sir has been a great academician throughout and was recognized UG and PG teacher at the prestigious State GS Medical College and KM Hospital, Mumbai since 1984 till his superannuation in April 2021. Apart from more than 50 publications in national and international journals, Sir has been awarded the Hargobind Traveling Fellowship of USA in the year 2007. He is visiting professor, Rotary Grant, Mauritius. He has been faculty in many international conferences like World Congress held at Germany in 2006 and at Shanghai in 2016, stages in USA in 2010, Asia Pacific Hernia Society in 2017, and as a reviewer in SAGES in the years 2018, 2019, and 2020. With such a great academic background and achievements, honors were expected to flow. Sir is at present President Association of Surgeons of India. Sir was President of IAGS in 2015, of which he was a founder joint secretary in the year 1993. Sir was President of Maharashtra State Chapter of ASI in 2013. He has adorned the Board of Governors of Endoscopic and Laparoscopic Surgeons Society of India and is member of SAGES of RAFC and CNE Committee. Sir has delivered 21 orations till date, which includes the prestigious Dr. P.K. Sen oration in 2019 and the 15th oration in the year 2016. Apart from being an academician, Sir has been an excellent organizer and has organized various conferences and workshops. Few important ones are Maharashtra State Chapter of ASEC Conference in the year 2011 as organizing secretary, Annual Conference of IAGS 2015 as organizing president, Fellowship Programs of IAGS in 2013, 2014, and 2016 as organizing chairman, and ASACON 2009 as workshop chairman. We are fortunate to have such a multifaceted and multi-talented personality as our national president. Sir, you are an inspiration to many, mentor of many, and professor of professors. Going far beyond the call of duty, doing more than what others expect. This is what excellence is all about. Excellence comes from striving and maintaining the highest standards and going that extra mile. Sir, you are an epitome of excellence and excellence personified. A truly amazing mentor is hard to find and impossible to forget. Presented this scroll of honor to Dr. Abhay Narendra on this day, 4th December 2021, with all respect and humility from the entire Maharashtra State Chapter. As Sir is not there, I would request Dr. Sunny Zilgi, his beloved student, to please collect the scroll of honor and the memento on behalf of Dr. Abhay Narendra.
I request Dr. Abhay Dalvi sir to address virtually and give us blessing. Dear friends, as a master of ceremony, I am being entrusted with task, which is my duty, as well as my privilege. I am extremely glad to be host at an event where my classmate, my friend, my soulmate, Dr. Virendra Rao Vaz, is about to be honored with Lifetime Achievement Award of the Amravati Society. There could not have been better person to be chosen for this award. What can I say about him? A surgeon par excellence, a great human being, Yaro ka Yar, a person whose presence was theatrical, where whether it is operation theatre or an open theatre. My dear Prabhu, I hand over the proceedings for presentation of this award to Dr. Jayashree Ungolepai.
Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Guruve Namaha. These precious words are dedicated to the senior surgeon of our association, Dr. Virendra Vaz. Dr. Virendra was is a dedicated surgeon and with a great surgical skill and best teacher who has sculptured many surgeons. Amravati Surgical Society has bestowed Lifetime Achievement and Best Teacher Award to acknowledge his work. Today, Sir is fighting with cancer, but a surgeon never defeats. The prayer of all surgical fraternity are with him. Sir could not come to receive the award, so I request his friends Dr. Ravindra Kasat sir and Dr. Umarai sir to receive the award on behalf of Dr. Vak sir. I request Dr. Ganeriwal sir to hand over the award to Dr. Vak sir and Kasat. Sir has sent a virtual message for all of us. I request the AV people to display his message.
I'm extremely thankful to my colleague in Amravati and around who practice surgery and taught me how to do so. I have learned my surgical skill from my senior colleague and from my junior colleague. The knowledge I got in surgery from this colleague, I try to impart them sincerely to my patient. And I get immense satisfaction when they come back smiling with
Thank you, madam. Now, I call Dr. Rajendra Ganeriwal, President Masi, and Association of Surgeons of Amravati, wants to felicitate the EC members of Masi. I call upon Dr. Rajendra Ganeriwal to carry out this.
I request all the EC members. I invite them. Dr. Rajendra Shinde sir, Vice President Masi. Dr. Samir Vege, Secretary Masi. Dr. Sanjay Kolke, Vice President Masi. Dr. Sanjay Kolke. Dr. Anjali Rao. Dr. Roy Patankar, sir, GC Anchor. Dr. Praveen Suryanshi, sir, GC ASI. Dr. Siddharth Dubachi, sir, GC ASI. Dr. Siddharth Dubachi, sir. Dr. Sachin Jamma, sir, GC Masi. Dr. Uday More, sir, GC Masi. Dr. Kishore Abhyanta, sir, GC Masi. Dr. Kedar Patel, GC Masi. Dr. Ravindra Telkar, GC Masi. Dr. Atish Bansu, Dr. Rajan Redekar. I'll skip the name of Dr. Jayashree Hibal. Dr. Vikas Jain. Dr. Snehal Pegri is not there with us. Dr. Girish Jatkar, sir. President VSF, Dr. Girish Jatkar, sir. Dr. Nirmal Patel, Secretary VSF. Both are not there. We are thankful to all its members for their grace this occasion. Thank you, sir.
Final solicitation of Dr. Jayashree Moy, EC member and President A Group.
Thank you all its members. मी आमंत्रित करतो डॉक्टर अमित भस्मे यांना त्यांनी यावं आणि सगळ्यांचे आभार व्यक्त करावे. डॉक्टर अमित भस्मे.
Good evening, all. It's an honor to offer vote of thanks on occasion of this great ASACON. On behalf of Team ASA, I sincerely thank our guest of honor, Dean Dr. PDMMC, Dr. A.T. Deshmukh sir, our chief guest, Dr. Abhay Dadvi sir, President ASI, Honorary Secretary of ASI, Dr. Sanjay Jain sir, Honorary Treasurer of ASI, Dr. C. Prasad sir, for being present virtually. I'm very thankful to all the speakers of today's CME for sharing their valuable knowledge and experience with us. I sincerely thank to all the chairpersons of today's CME. I am very much thankful to all the delegates for sparing their valuable time and attending this conference. I want to extend my generous thanks to all the state EC members and GC members of ASI who has come long distances to attend this CME. I want to extend my thanks to all the sponsors, audiovisual people, event managers of this conference, Bodhankar Events, for making this conference an easy go. I'd also like to thank all the members of ASI for helping to make this conference a great success. And last but not the least, I would like to sincerely thank our MOC of today's CME, Dr. Kasat sir, for smooth conduction of today's event. May I request Dr. Jayashree Ingole madam to give a memento, a token of appreciation and love to sir. Before we conclude, there are a few announcements. I'd request all the EC members of MASI to come for conference hall for EC meeting. T Lounge, 3rd floor. I would welcome you all for tomorrow's operative workshop being conducted at Dr. PDMMC Medical College, Guyton Hall. There'll be live transmission over there. So we'll be starting sharp at 8:30 in the morning. And lastly, I would like to welcome you all for today's banquet at 8:30 p.m. in the lawn here itself. And yes, register for ASACON Pune. Thank you.
थँक्यू. सगळ्यांना विनंती, कृपया राष्ट्रगीतासाठी उभे राहा.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा. विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा. तव शुभ नामे जागे, तव शुभ आशीष मांगे. गाहे तव जय गाथा. जनगण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे.
अध्यक्ष डॉक्टर जयश्री इंगोले यांच्या परवानगीने हा कार्यक्रम इथे संपला असे मी जाहीर करतो. धन्यवाद.